who all use WhatsApp. I think everybody uses WhatsApp. And who all have used ChatGPT or any AI format. So majority of you have used, but I believe many of you have still not used any of the AI format. So if we feel, do you have a hand mic, please? Ubi, do you have a hand mic? So please get the hand mic to me.
Good morning.
So yesterday I was about to make this presentation of mine, because this is not a presentation, this is an interactive session between us and you, between how we can efficiently use AI in our daily practice. So this is the prompt. I believe I'll just increase the font. So I have prepared this slide in less than 4 minutes, this presentation, using ChatGPT model. But ChatGPT is not the only AI model which is available. This is the widely used model we have. We have ChatGPT, we have Perplexity, we have Genora, we have Claude, and I believe many of these names may not be familiar to you. But it is a constant learning between you and this artificial intelligence. उनको देना जब मैं पूछूंगा, ठीक है? So it's a constant learning between artificial intelligence and an intelligently applied science, which is a healthcare uses artificial intelligence in a better way. So this is what we are going to learn. So what is the most important thing? Yesterday one doctor asked me a question, which is the most important thing. He just asked me one thing. Suppose I type abdominoplasty in ChatGPT and you type, that means I am going to type abdominoplasty in ChatGPT. Will the response vary? What is your answer? Will the response vary? Yes or no? Yes. Because we have given only one word to ChatGPT, abdominoplasty. The response will 100% vary because AI works on the prompts. So prompt ka matlab hai the question which is being asked to the AI will work on that. And second point, it will learn your questions. It will learn your responses in the history which you have made. So more and more interaction as you do with your child, as you do with your a software platform. AI is a software platform. That means more and more interaction you do with ChatGPT or any other platform, it will adapt to your questions, it will adapt to your likings and dislikings. Supposedly, I recently went to Malaysia. So I just typed, I am planning a family vacation to Malaysia for 5 days. Provide me an itinerary. So what he did, he already knew age of my child, 16 years and 6 years. He already knew name of my wife, my name. So he started by saying that, excellent, I will plan a family vacation for 4 of you. So this is what I'm telling you. The ChatGPT or any model will learn how you ask questions from them. So how many of you know the name of the AI model which is dedicated to medical or medicine only? Anyone can tell me name of one AI model which is dedicated to medicine only? So we are all asking all our questions to certain or one used AI platform, and they're all based on the information provided by them on the open AI format. So one of the widely used or used by me platform is Dr. Oracle. So I'll show you a thing, Dr. Oracle, how Dr. Oracle works. So this is Dr. Oracle. You can see it on the screen. This is all live going on. Ask Dr. Oracle now. So if some of you want to ask any question to Dr. Oracle, it will generate a medical response. It will take care of all the things. I think there is some lag in the Wi-Fi, as I have not been provided with the Wi-Fi from the Indian Heritage Center, but yes, it is opening. So any one of you want me to give any prompt to Dr. Oracle? Any question which is coming in your mind pertaining to your practice, daily practice, be it a guideline to manage diabetes, be it a guideline to manage hypertension, or any other thing, then we will proceed with the questions which we can ask AI and how we can take information, pertinent information out of it. Supposedly we want to ask recent guidelines to manage hypertension. So this is the prompt which we have given to Dr. Oracle. It is searching all the literature, it is reading papers for you and optimizing thoughts. But it is using a 2017 ACC or American Heart Association guidelines. So you can see it has given you the level of the blood pressures, when to initiate pharmacological treatment, the first line pharmacological treatment, blood pressure targets, lifestyle modification, treatment, titration, and this way you can generate your hand notes, this way you can generate all the things. But if you're not happy with this, so do you have a more recent guideline pertaining to Indian scenario? Just ask him this. So this is how you interact and prompt pertaining to any prompts given to the AI. So what is he saying? He's saying now the general practice is applied globally, but in India has specific consideration. The Indian guidelines largely align with international recommendation only, and they are in association with American Heart Association. Similarly, in ChatGPT, which I asked him yesterday, was what are the AI applications and tools relevant to Indian general practice? So it was AI decision assistance platform. There is a eSanjeevani CDSS, government telemedicine AI, which I was not aware. Eka Doctor, you can see these are all Indian names now which are coming up. If you see and write down AI which is available globally, they will come up with all American tools. But these are Indian tools which are available. And you will see a boom in all Indian tools. But more importantly, which I asked was how these are helpful to no, yes. 10 practical ways Indian doctors can use AI daily. So what are the 10 practical ways? This is the main important thing which we can use daily. Every person may be having their own requirements, like what they want to do. They can use ChatGPT or other AI tool as a smart junior doctor. They can take down their notes. How do they take down their notes? You can just voice type and they will take down. They will be typing. Gone are the days where you need to type again and again. You can just use voice assistants and they will type for you. Automated OPD notes. Explain diseases to the patients in their own regional language. You all know, a patient came to me, he was from Maharashtra, he was not very good in Hindi or English. So what do? You just take the picture of your prescription or any guidelines, put it on the ChatGPT, and it will come up with a Marathi version of the similar thing. Okay? So, or a Kannada version of similar thing. So, we can quickly see, this I usually do. I'm not very well versed with medicines, I'm a surgeon. So this we quickly do. If there is a drug which is your patient taking, and I don't know the name of the drug, sometimes there are so many names available. The salt, the patient may not remember the salt, he may not show you the medicine name. You can just put the name. In spite of putting it in Google, you can put it here. Likewise, if you can tell me any of the drug which you use commonly, we can put it here. It will bring all the necessary information which is needed for that drug. If there are any interactions or not, it will come on that. So, but more important is these things, I'll just quickly go through it because of the paucity of time, and we can talk about it the entire day, how AI works and helps a doctor. You can use it for preventive health and risk prediction, radiation and lab report interpretation, patient flow via AI. You can use AI on WhatsApp as a tool if you're using automated WhatsApp tools to send patients feedback forms or patient their date of follow-up as a reminder. They can use that and create health awareness. You can make internet content, website contents. You can write small blogs using AI and use AI as a research tool and audit also. But most important and the bottom line which I asked was, what doctors should not do while using AI. Do not let AI make the final clinical decision. What AI does not do it, do not decide diagnosis based on AI only. Nothing can change your proper history taking and examination. AI will give you an information based on which you have provided to AI. he is not going to see the patient. So the final diagnosis and when to start or stop treatment is on you only. Do not skip history and examination, as I've told you. Do not copy paste AI notes blindly, as AI can make mistakes. Do not share identifiable patient data, because this is being, a lot of patients are being telling that you are giving all the data to the internet, my personal data. So you don't have to disclose the name of the patient or any other thing, because they can all search the history which you have searched from the AI. As it is learning, it is also storing your information on the cloud, what you have searched for. So do not use AI for prescription without cross-checking. Again and again, do not assume all AI is up to date, because the ChatGPT model, which currently the free version they are using was devised in 2022 or 23 late, and we are living in 2026. Do not use AI to bypass any informed consent, and do not over-investigate just because AI told you to do so. And do not let AI replace human communication. And do not forget the legal responsibility. If you are sued, you will be sued, not your AI. You cannot say this, because once I was reading a paper, somebody in America told that, no, this was done by my AI. But AI is not likely to be prosecuted or penalized. It is you only. So it is important how to interact with AI as a healthcare professional, but it is also important to understand, ultimately the onus is on you to treat the patient. You can use them wisely. You can use them by prompt learning. And one of the easiest way to know how to learn prompt is to ask AI what is the prompt. So if you want to ask, okay, what will be generate prompt to learn about diabetes management in general practice. So now it will not generate data, it will just generate a prompt. See, it has generated a prompt. I'll simply copy this prompt. You can just, so see, this is not a prompt which is generated by me, okay? I copy and I paste this prompt again to ChatGPT only, and I press OK. Now the response will be entirely different. Otherwise, as I told you, generate a prompt for guidelines based on management of hypertension. Now see, based on the prompt, it is searching, and below is a practical guidelines, and in about 14 seconds, it has generated an answer as if it is an expert endocrinologist, as a senior endocrinologist. So you can see here the response which is being generated, it is still being generated. And if you spend about 15-20 minutes of your day in reading any topic of your interest, or you have encountered during your day-to-day practice, this type of searching, this type of prompt generation, and then posting the question, and this type of learning will surely help you in coming days. If there are any questions, we'll take up now, and we'll wrap up this section, because in the interest of time, we have to start the next presentation. Any question pertaining to AI, use of AI? So if there are no questions, you can always put up your questions with us. So see, it is still generating the response. It has not stopped. How extensively it generated the response after giving a proper prompt. So initially, it generated only a superficial information to manage hypertension. But now it has generated a response which includes everything about management of diabetes. And if you know about these things with your years of experience of knowledge, then definitely you're going to give a better care to your patient. And this is a very good way to revise what can happen with the patient or not. Because we are all referring to internet. We are referring to, most of us are not referring to books right now. Who all are having textbooks at your desk and referring to textbook to know about things? I believe many of us do not refer to textbook or open a textbook. Gone are those days when at the desk of your physician, there were a lot of textbooks which were lying there, and you always refer to them. They were being marked, but now they're not marked. It's always stored, and you can see my response, you can see all the things which I have asked from ChatGPT, they can bring up in my search history. Some are related to medicine, some are not. So you can always see. And I'm using this 5.2 version. This is a paid version, but you can opt any version, take it as a guideline, but ultimate onus is on you, which I've told you, why we should be cautious about disseminating the information which has been provided by AI to you. Any question, sir? Sir, Dr. Agarwal, any question? I think this, for ChatGPT, it is roughly about 2,000 per month. So Perplexity is another AI which is free for Airtel users for a year. So, but then also they will charge 1,700 per month.
All these tools, like we have Perplexity, Claude, and all these tools. So, which of them do you think we should buy, and the paid versions, and which ones are okay in the regular versions, like Notebook LLM, etc.?
So you have to use at least 5-7 types of AI before you get versed with one. So I'm well versed with ChatGPT. I'm okay with Oracle, not very much familiar with Oracle. I have used about 7-8 types of AI, but to me, if you use only one machine, or if you teach only one child, it will learn better. So if you use 10 of AI, the machine learning will be disseminated. So for me, my ChatGPT model, which is installed on my computer, has learned over about a year or so on which I'm using it, what my preferences are. So you have to use one which is best for you.
Dr. Neeraj, I would like you to demonstrate the voice command.
Yes, I will do so.
Yeah, because the thing is, it will obviate the need of even writing or typing. So that will make it further easy for the practitioners.
And how many of you have used voice command prompt for writing some letter or writing a draft or something on ChatGPT? You have used it. So you just tap this button and type it. So I'll see if this works with, hello? So please write down a thanks message to all the audience which are there, and tell them it was a great interaction with them, and we can use AI in healthcare efficiently if we give good prompts to ChatGPT, and let's see what future holds for us as medical professional by using AI. I believe the voice was going through my phone, but not through the laptop because it is connected with some wires. Sometimes it happens, but let's see. So I have written this, I have posted the prompt, and now he's writing polite, warm, and future-looking. Thank you all delegates for being such a wonderful audience. It was truly a great interaction and engaging exchange of ideas with all of you. Today's discussion reinforced one important message: AI in healthcare can be used efficiently and meaningfully, and when we ask the right question and give the right prompts, especially while using tools like ChatGPT. As medical professionals, we stand an exciting crossroads of medicine and technology. Let's stay curious, responsible, and open-minded, and see what the future holds for us as clinicians with AI as our ally. Thank you. You can stop the sharing. Title slide. I just changed Saraf presentation.
Thank you, Dr. Neeraj, for such an exciting talk on AI, and I'm sure we'll all go back home and try Dr. Oracle today. So with that, we now proceed to our next session. It is my privilege to invite Dr. Malik, sir, who's the Dean of GRIPMER and a visionary academician, architect of structural postgraduate training in our hospital. He will give us deep insight into what goes on and how far we've reached education-wise. Welcome, sir.
Sir, Raji, sir.
GRIPMER update 2026?
Yeah.
Huh?
Yes.
Second one, na?
Yeah, that's right. GRIPMER update. No? Your phone?
So you're okay with this type of thing?
What? No, give me the video
Full?
stuff.
Okay, just this arrows. Huh?
Okay.
Next slide.
A very good morning to you all. I am indeed grateful to the organizers, Dr. Manchanda, Dr. Neeraj, and Veronica, to give me this opportunity and to have me here talk about a subject which is not the key subject for the day, but some kind of a introduction about what we do at Sir Gangaram Hospital when it comes to academics. You all know about Sir Gangaram Hospital, and I bring to you the greetings from Sir Gangaram Hospital. This presentation I prepared essentially for the audience who are not from Gangaram Hospital, just to give them a glimpse of what academics is at Sir Gangaram Hospital and how we have organized it and how things are moving. So, as you all know, and I think we pay tribute to our founder, Sir Gangaram Hospital. He was a civil engineer, a philanthropist, and he started a small hospital for a social cause to serve the widows and the orphans. And this was established in Lahore, where he had a number of other buildings which he designed, sort of designed for public use, like their GPO and Atchison College. Number of other buildings in Lahore on the Mall Road bear ample testimony to his genius. In view of his recognition, and of course, he turned desert Punjab into a fertile Punjab. In lieu of that, he was rewarded by a large tract of land, which he utilized. The income from that he utilized for all his philanthropic activities. And Sir Gangaram Hospital is part of that philanthropic activity, which has outlived all other things that he had started. At the current time, we are a 737-bedded hospital in the central location, and there are two affiliated hospitals, City Hospital and Colmet Hospital. Overall, we have 33 modern and modular operation theater, 63 ICU beds, and 14 NICU and PICU beds. Just to give you an introduction to the place that we are. So we have recently added a few facilities and expanded our infrastructure. Radiation oncology is the newest kid on the block, state-of-the-art bone marrow transplant unit, PET unit, molecular hematology laboratory, research laboratory, including stem cell research, where we are in the frontiers, and it is headed by Dr. Ganguly, who was the Director General of Health Services, Government of India. And that's where we are doing all kinds of stem cell research, and I'm sure in times to come you will hear more about it. Robotic surgery, and we have 2 surgical robots in our operation theater complex, where our department, general surgery, and other departments like urology, gynecology, they are doing all state-of-the-art robotic surgery. Next-gen genomics is part of our infrastructure, and I think we have more than 1 machines in 2 different locations, and nuclear medicine, which is now state-of-the-art system, where we have the opportunity of treating, not only doing the diagnostic, but also treating conditions which are amenable to be treated by nuclear medicine or nuclear pharmaceuticals. Now, what is this Gangaram Institute of Postgraduate Medical Education and Research? Now, this is our academic wing, you can call it. It is a body which has overarching influence over the academics and research that we have at Sir Gangaram Hospital. We started this DNB program in the year in 1984, and this academic body, which was consolidated in 2012, so that all activities are under one particular umbrella. We give faculty designations to our members based on the NMC or National Medical Commission guidelines. We coordinate the research projects which are being funded by external agencies like ICMR, DBT, and WHO, DST, and Ministry of Environment. We also run GRIPMER local fellowship in specialized and sub-specialized areas, and herein we get the applicants from national and international areas. Now I'll just give you a little update about what we are all doing. That is the core for our work today. Our functions are academics, and we always make sure that we excel there. And one of the testimony to excellence in academics is that our postgraduate thesis, which are submitted after completion of the course, are returned with commendation. At least 10 to 15% of our theses are returned with commendation by the external evaluators of our thesis project. That's the kind of excellence that we aim for. All our protocols which are submitted are accepted, and none of our theses has ever come back under the title of rejection. We conduct CME and different location, orbit, that is outreach program of Sir Gangaram Hospital. That's also part and parcel of our ambit here. And this CME also is in a way, our, should I say, inspiration that we have over the years taken part in these CMEs and always try to involve people from outside, so that our outreach into the society and getting people to know about what we are doing becomes more well recognized. We conduct research not only through the postgraduate process, which is of course thesis which all the postgraduates have to do, but in other research projects whichever are submitted either internally or through external help, are always vetted through our processes, and that's where we have a major role to play. We are now bringing out a journal which is a regular feature, and I'll come to that in a while. We do guest lectures from experts coming from outside and some experts from India who have big name. And last, I think we had an oration by Dr. Nagi Reddy, who talked about AI and medical practice. And I'm sure Dr. Neeraj's presentation today has taken that process forward. And these are the orations which not only inspire but also give us the glimpse into the future. And these are called GRIPMER orations, which we hold regularly every year. We ensure compliance. As far as the National Board of Examination is concerned, there are many compliance activities to be done, and all these activities are done through us. And I'll tell you that how these programs have expanded and how this system has now become even more widespread than it used to be. And last but not the least, we create a situation, create ambience in our hospital wherein we bring about bonding between our faculty and residents through programs like sports meet and cultural evening, and also our newsletter, which gives them a 360-degree view about what we are doing at Gangaram Hospital and how to interact better with their own resident colleagues. So these are all the activities, that we are part of, and I'm really happy that administration has given us this responsibility to create something like a medical college environment, and we call ourselves as the AIMS in the private sector, and I'll tell you why. We started off in 1984 with only 5 disciplines. At present, we have 350 DRNV, that is specialized program, that is doctorate of National Board, and DNB, that is Diplomate of National Board, FNB, that is Fellowship of National Board. So these are 3 different programs, and the National Board of Examination that we run in 52 disciplines. So I think starting from 5 disciplines and about 20 candidates, we have moved over to 350 residents and 52 disciplines. That is something like it is the largest program anywhere in the country as far as the number of specialties are concerned. We have 19 broad specialties, 23 super specialties, and 10 postdoctoral fellowships. It's the largest program, and we are considered to be the ideal institution as far as running the DNB program is concerned, and that's where I think a comparison with AIIMS comes up as far as the number of programs that we have. So these are the areas, where we have the programs, and these are the 10 departments where we have postdoctoral fellowship, overall 52 disciplines and counting. So now we have come out with a comprehensive cancer center that has become the focus of our activities in the last couple of years. And oncology in the forefront, that's the theme. We have ongoing programs in surgical oncology, in medical oncology, ped hemato-oncology, and DNB in nuclear medicine. So in these 4 specialized areas we have, which basically cater to the cancer patients, we have ongoing programs. And as far as the programs in the pipelines are concerned, we have a gynae oncology program coming up, radiation oncology DRNB program in the pipeline, and possibly an FNB program in the colorectal surgery. So with these aspirational 3 programs on the horizon, I think our number will increase to 55 as we enter the next year. So as I was talking about research, I think one of the distinguishing feature of Sir Gangaram Hospital is that we have a great focus on research. And if we were to look at institutions which are doing research, you will find in the private sector, you would we are proud to say that we are number 1, and I'll give you some numbers here. So this is a Scopus Index publication from the time period of 2008 to 2015, and all NMC institution, AIIMS stands on the top with 11.2% papers coming from All India Institute, and in this MEMC stood at 1.95%. So these are all NMC institutions, and the number of publications were 101,034. So when it comes to the private sector, again, they look at 1.06% of all papers, close to about 1,100 papers coming from Sir Gangaram Hospital, and it was only second to LV Prasad Eye Institute, Hyderabad. So that's the kind of pride that we have, and that's the kind of literary output into the scientific publications that we have from Sir Gangaram Hospital, and that was the period of 2008 to 2015. Recently, we again looked at the data, and we found that in the period of 2021 to 2025, we had overall 1,183 publications in Scopus indexed database, and overall we have been having about 350 to about 250, or rather put it other way, 250 to 350 publications in the Scopus database indexed journals coming out in a yearly basis. So that's the kind of research, and that's the kind of milieu that we have at Sir Gangaram Hospital. And we are coming out with this academic report which will highlight it further, what are the areas which we are focusing upon. And we are indeed proud of this fact that being number 1, and I think these last 5 years, no private institution has contributed so many papers to the Scopus indexed papers like we have done in the last 5 years. So we have, again, a very well appointed library. A lot of material is available, and this library is open throughout the 24 hours when the exams are taking place. Otherwise, it's also open till about 10 o'clock every evening. We have a huge number of online resources through Clinical Key, up to date and anywhere. And our budget for the library, which is astonishingly high, is about 2 crores, which I think no private institution has that kind of a budget like we have in Gangaram Hospital. Recently, we have come out with GRIPMER Skill Center. We strongly believe that skills, especially in the those situations where some kind of interventions are involved, be it critical care, be it ophthalmology, be it surgery, be it laparoscopy, can be imparted in the setting of skill center, which can be transferred to the operating room. So for this idea, we started off, can I have a couple of minutes more? I'm just at the last slide. Yeah. So we started off with this skill center. We currently have tools for open surgery. We currently have mannequins and dummies, for procedures like tracheostomy and endotracheal intubations. And we have laparoscopic endotrainers. So we believe that our younger generation will have a better learning experience when they are exposed to a skill center where their learning process will become more wholesome and they will be doing a better job. Obviously, our aim is that over time we should become more digitized in as far as skill imparting is concerned. So we have a regular publication from Sir Gangaram Hospital that's called Current Medicine Research and Practice. It is indexed in MBase, it is indexed in DOAJ and Web of Science. It was launched in 2011, and it's coming out regularly without any issue being dropped, and comes out regularly a week in advance of its date of publication, and comes out every 2 months. And through this presentation, I'll be very happy to invite you to send in your manuscripts for publication to our journal. So with this, thank you very much for giving me an idea, giving me an opportunity to tell you what we are doing at Sir Gangaram Hospital as far as academics is concerned. And thank you, Dr. Manchanda, for giving me this opportunity. Yeah.
Thank you, sir. Any questions or any comments from the audience? Thank you so much, sir. Next, we have the man of the hour, Dr. Sanjay Manchanda, sir. Can we have a huge round of applause for the organizing chairperson of this CME? Sir is a consultant in HD at sleep medicine in Sir Gangaram Hospital, and today he will be talking about the art of and sound healing and what are the benefits and how does it really work on different disorders.
Well, good morning, ladies and gentlemen. I welcome you all to this annual CME, the 15th annual CME. We've been holding it for last 17 years, barring the 2 years of COVID that were unfortunate. But we have been trying our best to bring forward the latest technology. This first session, actually, we have done more of a tangential kind of a thing, that it is not pure medicine, which will follow definitely. So this is basically, today I'm going to talk on healing through sound and music. It is primarily because of my love for the music that I have, taken up this topic, and I have, made a music also for insomnia and, the other kind of disorders, which will help the persons mentally, physically, and emotionally. Now, everything in this universe vibrates. The resonance is the frequency at which something naturally oscillates. The universe was created by a big vibration, as we say, the Big Bang Theory, and the sound. Every living system, from cells and organs to tissues, bones, carry their unique tone, together forming a symphony. It is like an orchestra. If it is in sync with each other, you are healthy. But if anything which goes awry in this orchestra, like somebody playing a bad note, then you become a diseased person. So health, in health, every organ vibrates in harmony, like instruments in the orchestra. In disease and trauma, dissonance takes over. And we can correct that with the normal, say, sounds of the resonance in a lot of people. And this was first, say, coined by Jonathan Goldman. The thing is, actually, we have an age-old history of music and its healing properties. But today, the scientific elements have joined together so that we can, talk about it in a slightly more scientific or medical way. So the ancient wisdom meets the modern science. It can be found in many spiritual and sacred traditions. The best doctors heal with divine sound, that was published in 3 BC in Ayurveda. Sarva Rog Ka Aukhad Naam, and that was published by Guru Nanak Dev in the Holy Guru Granth Sahib. Every ailment is a musical problem, and cure lies in the musical solution. And this was by a Western mystic by the name of Novalis, and it was published in 18th century. And sound and music for healing, the sound healing is relatively a new modality, though it is an old modality, but in today's perspective, because we want data for everything. Unfortunately, we need data, rather the experiential thing that we should do. The current field of sound healing is enormous, and its scope and virtually encompass all the aspects of auditory phenomena, from music to nature to sound and electronic and vocal sounds. But there are so many ways in which this can be given to the patient. It could be because of music imagery, it could be because of the tapes, it could be with electronic ear, it could be with the harmonics, it could be with the mantric chanting. So guess the greatest instrument that you have for healing, one that is naturally, that is cost effective, does not require any batteries and electrical outlets, and that is the human voice. How many times it has happened to us that somebody on a telephone talks to you and you feel that noise is not just gelling with you and you don't want to talk to that person. But there is another part of the spectrum where you hear a voice and you would like to communicate with the person because the vibrations are matching, the frequencies are matching. So sound healing aligns the body's energy center, that is the chakras, through vibrations, now recognized as a form of energy medicine, reduces the anxiety, pain, and improves the quality of the sleep. Well, the history dates back to prehistoric times when shaman chanting was there. Ancient schools of Egypt, India, Greece, and other centers of knowledge, they have used sound and music for the healing and were highly developed at that time and even today. The sonic vibrations were known to be fundamental creative force in this universe. So as far as the Vedic civilization is concerned, the oldest in the history of the mankind, so is the classical Indian music, and we have the effects that transgress into the different things, and they can be for the type of the day, the seasons, the feelings, the mood, and the timing. So we have ragas for everything, and if we pertain to them or if we listen to them at the same time, we have got a much better effect. So in modern times, Hans Jenny demonstrated how various substances in plastics, liquids, and sand would take different shapes in the form of life, that is, starfish, human cells, microscopic life, depending upon the different frequencies they were subjected to, and thus showing the ability of the sound to affect the change in the molecular structure. And since the body's 75% is water, it is easy to understand that how sound can create changes in the body. Well, sir, important people who have contributed to this field in last around 100 and 150 years, Peter Guy Manners from England, Alfred A. Tomatis from France, Robert Monroe. The thing is, he discovered how to use the sound waves to synchronize the hemispheres of the brain and cause accelerated consciousness. Now, do sound and music work? The basic principle is resonance, as I've already told. It is possible to use the sound to project the correct resonant frequency so that the body part causing it to return to its normal frequency, and this is done through electronic instrumentation or human voice. Well, do all the people vibrate at the same frequency? No. because that is where interpersonal relationships generate. If you are having the same kind of vibes, same kind of, say, frequencies, you try to gel with those people a lot more than the other people. Even though they might not have done any harm to you, but you do not like to communicate. So since the sound can potentially rearrange molecular structure, the possible healing applications of sound are limitless. But there is a flip side to the story as well, and it is conceivable that a person receiving sound from instrument may not resonate with that at a particular frequency, and it could be counterproductive. The least invasive, of course, is the human voice, as I've already told. Now, the role of chanting. What we do is when we chant together, there is an area of influence which is created around us. Like if you throw a pebble into a pond, the waves will form and they will reach the periphery. You may not be able to see them. But bigger the rock, larger the waves, and you can see them. So larger the area of influence. I'll just tell you a very important, experiment that has gone. The therapeutic effects of meditation relaxation, they include lower heart rate, respiration, brain waves, activity, which seems to alleviate many different medical problems and can improve the immunological systems. Now, what is the difference in the sounds that make healthy and that can distress us? I'll just tell you. Yeah, I'm just getting it. It's just stuck a bit. Well, the thing is, have you ever thought why all the sacred names, they start with vowels? Whether it is Om, whether it is Allah, whether it is Amen, it is for the simple reason they generate a vibration, which is a self-healing kind of a vibration. And the results of Om chanting has been demonstrated in Harvard and many other institutions to see the drop in the blood pressure, the calmness of the mind, and the better productivity of the person. So it is based on the vowel sounds, and I'll just explain you the experiment very importantly. The first effects of the mass meditation and the prayer, they became noticeable when the number of people participating in an event was greater than 1% of the total population. And this experiment was done by Greg Braden in the United States, and he repeated this thrice in a crime-prone state, accident-prone state. And during the chanting, it was found the number of those events, they decreased dramatically all the 3 times. So the thing is, yes, they have. That is why we have the Buddhist chanting and the other kind of chanting, and which help the area to heal. It is not just one person. It is the complete area surrounding you may heal. Now, as far as sound is, the heart rate, breathing, intensive care surroundings, communication problems, especially autism, because autistic children are much more, receptive towards music. Mozart was an autistic child. So the thing is, they are helped a lot when the music is the key. Then psychotherapy, schizophrenia, rehabilitation, dementia, and of course sleep medicine, that is my subject. Now I'll put forward the music to see that what exactly is there. Volume. I think it is a pretty jarring kind of a note. Nobody will be enjoying this kind of a thing. Now moving from... And listen to this one now. It will soothe your nerves. It will help you respond better. It will make you feel better. Now this is what is the difference between a frequency which hurts you and a frequency which soothes you. As a person and as a, say, ardent lover of the music, I created a music with one of the most revered say musicians, that is Ustad Zakir Hussain. And I'll show you. The thing is, we used acoustic Indian instruments. The instruments that were used was Tanpura, Ek Tara, Swar Mandal, Manjira, and flow of water. So there were no chantings, only the instrumental music were painted as abstract colors of the vibration. Now, this is what. Now, I'll request all of you to close your eyes, relax your body, put your head a bit down, and just close your eyes, relax your body, relax your shoulders, take normal breathing, no effort in the breathing. Before lifting your heads up, rub your neck and rub your forehead. So the thing is, future directions are that sound therapy has to be personalized. It cannot replace medicine. It can only supplement the medication. Digital therapies are there. Integration with lifestyle medicine should be there. The sound has a measurable biological effect, safe, non-invasive, and powerful complementary therapy. As Nikola Tesla once said, that if you want to find the secrets of the universe, think in terms of energy, vibration, and frequency. Thank you, ladies and gentlemen.
आज ऊपर ही आ जाइए
Thank you so much, sir, for such a relaxing session. I think the tone for the day is set. So any questions anyone has? Okay. So I have a question for you, sir. Sir, so we spoke about healing through sound. So, sir, is this for patients, specific patients who are suffering from insomnia, or like all of us can use it?
The patients of insomnia, we have done 250 cases on that. And the thing is, the results were there, and we did a polysomnography, that is a sleep study in all of those patients, along with the music and without the music. And certainly the efficiency as well as the quality of sleep improved. The deep sleep improved, and the thing is, the patients did feel better. Apart from that, there are specific ailments like autism. In children, it is something which is going to give a lot of benefit. And we have received it, and this CD which we have developed, actually I have not gone public with this thing for the simple reason I take it as a therapeutic tool and not as a selling tool.
Yes, ma'am.
Pardon? I just couldn't. The frequencies are something which is purely individualistic, and that is why I said that you have to tailor-make certain things. And for that, you need a very, very in-depth knowledge. I do not have that. I have to use other people to develop that. But the thing is, there are equipments today which can give you the feel of those frequencies, like Tanpura. There is electronic Tanpura also to match your scale, to match your singing. So the thing is, the same thing is there with the frequencies of the sounds which are there, and we can use them and we can try them on individuals, the person who will feel better with a particular thing. because we can't face rejection is there. As I told that there is a flip side to the story as well. So we have to take care of that part. It is total sleep architecture. Total sleep architecture. If there is properly an increase in the slow wave sleep, or what we call as the deep part of the sleep, because that is the area where maximum amount of, say, immunologically we become stronger, our connections are met with. If the REM sleep is there, it helps you, say, maintain your this thing, memory consolidation is there. So we have to use a lot of things, and it needs a lot of workout right now also. It is not something which is very common, but definitely the benefit is there.
Thank you, everyone. Now we'll move on to the next session. For this, I want to invite Dr. B.B. Agarwal, sir, who's the head of the Department General and Laparoscopic Surgery, Sir Gangaram Hospital. So he'd be talking about lesson learned from Bhagwat Geeta, and we're really looking forward to this very exciting session. Welcome, sir.
Good morning, everybody. Thank you for coming here. Greetings from our institution, and thank you for blessings of seniors present, Dr. Malik, Dr. Richa Devan, and many seniors I don't know as yet. Dr. Manchanda set the stage for my talk. I think 3M, M for Manchanda, second M for music, third for music for mind. And thank you very much. Today's, I think CME is a multivitamin nutrition of academics. I say MVN because 3 letters, M for Manchanda, V for Veronica, N for Neeraj. Thank you very much. So I'll be speaking mostly citing references from other than mine, but we have done all scientific studies on what I'll be speaking. So lessons learned from Geeta. I was surprised when Dr. Manchanda asked me to talk about it. I think it was following my 2.5-hour oration at a Kurukshetra University at Geeta Mahotsav. So I request you all that our basic teaching is this shloka, Om Sehna Vaptu Sehnau Bhunaktu Se Virya Karvavahe Tejasvi Nam Dhidamastu Vidvivashamahe Om Shanti. It means all intelligent minds should sit together, nourish themselves together without any conflicts, fights. There may be opposing views, but we can learn from everybody and we go enriched from everybody else. Geeta inspired Einstein, Tesla, everybody, all the scientists. Oppenheimer is famous after explosion of nuclear bomb. Another intellectual, Aldous Huxley, wondered, has the medical science helped in health? He said, modern science has made so much of progress that hardly any human being is healthy now. So what is lacking? Since the topic is Geeta, as we know, Geeta was, Mahabharata was told to Parikshit by Shuk Maharaj. And Shuk is also famous for what we call as his conversation with Apsara Rambha. So again, for scientifically minded people, that हम जितनी conferences में जाते हैं, तीर्थ निर्मलम ब्रह्म वृंदनम, वहाँ बड़े बड़े ज्ञानियों का समूह होता है intellectuals का, और वो सारे ज्ञानी चिंतन और अनुवाद करते हैं, लेकिन हमें वादे वादे जायते तत्व बोधा, हम एक दूसरे से बात करके बिना ईर्ष्या के कुछ तत्व का ज्ञान प्राप्त करते हैं, और उस ज्ञान से हमें चंद्रचूड़ यानी कि शिव आदि महादेव का ज्ञान जो अल्टीमेट ट्रूथ है वो प्राप्त होता है. As of today we know Geeta from Krishna to Arjun, but it was told to father of Surya, Vivasna, then passed on to Manu, Manu passed on to Ikshvaku, then down the Ikshvaku dynasty, it disappeared in Treta Yuga, and Krishna was there to recite it again. So what is it? It is a conversation when Arjun is feeling helpless, fearful. So scientifically, since we are all scientists, what is happening? एक छिपकली का दिमाग, रेप्टिलियन ब्रेन, जो लिम्बिक नर्वस सिस्टम हमें पढ़ाया जाता है, कि जिसके लिए हम खाना पीना, सेक्स, सर्वाइवल और अपने ज़रूरतों के लिए ही लगे रहते हैं, तो उससे हमें डर होता है. डर से क्या? फियर, फ्लाइट एंड फाइट रिएक्शन, कैटेकोलामीन्स कानिन. सो एड्रेनालिन इज जनरेटेड. Entire science of healing is nothing but minimizing your adrenergic responses, converting adrenaline into dopamine and to serotonin. This is what Krishna did to Arjun, converted his adrenaline surge to pleasure, chit anand, happiness, satisfaction, confidence. So it's a timeless science, as Einstein said, nothing new. It has 700 shlokas, of which 85 are questions by Arjun. And all questions by Arjun are repetitive, full of fear, doubt, arrogance. So what does Geeta say? There is a triangle of our thought process. We call it त्रिगुणात्मक निश्चय. So उसमें मन, बुद्धि, अहंकार. तो अर्जुन को क्या हो रहा है? वो डरा हुआ है, उसके अंदर डर है, क्या अगर मैं हार गया तो क्या होगा, मैं अपने भाइयों को क्यों मारूं? उसकी बुद्धि संकुचित है, वो देख नहीं रहा कि ये लड़ाई क्यों हो रही है, ये युद्ध क्यों हो रहा है. और उसको अहंकार है कि मैं तो आज तक किसी से हारा नहीं, अगर मैं अब हार गया तो क्या होगा. ऐसे में ये सारा हमारे साइंटिफिकली कैसे करता है. सो when we developed a technique for laparoscopic gallbladder surgery, hernia surgery, which became international guidelines, I was invited to write editorial for the topmost journal. This is surgical endoscopy. So I had mentioned, this was in 2008, that whatever I have learned from study of Upanishads and Geeta. It was mentioned in this editorial, published in an American journal. So I said a scientist, whether surgeon or physician, should respect the ancient wisdom and culture. हमारी पढ़ाई लिखाई में हमने क्या देखा मौलाना आजाद से और आज तक, कि हम पुरानी बातों को क्वेश्चन नहीं करते, उनको नेगेट करते हैं कि ये गलत है, घी खाना गलत है, रिफाइंड ऑयल खाओ. वापस अब साइंस, फ्रेमिंगम स्टडी जो 48 में शुरू हुई थी, जिसने फैट्स को आउट कर दिया, अब वो कह रही है कार्बोहाइड्रेट को आउट करो, फैट को लाओ और घी को लाओ. सो हमें कभी भी अपनी पुरानी चीज़ों को नहीं नेगेट करना चाहिए, क्वेश्चन करना चाहिए, मॉडर्न मेथड से उसे स्टडी करना चाहिए. सो फॉर दिस एडिटोरियल आई कॉइंड ए वर्ड इमेजिनियर, imagination driven engineer for doctors. So doctors should be innovative, he should understand body at molecular level, he should respect ancient wisdom, he should know anatomy, embryology, genetics, he should be well versed with the modern technology, and he should not be afraid of taking up things which are coming like machine learning, as Neeraj told us, and robotics, etc. So Arjun was suffering from this self-doubt, fear of defeat, and fear of his own limitations. So this triangle of our decision making is akin to clinical decision making. If we take care of this triangle, our clinical decision making will be very simple. As long as our decisions are not affected by arrogance, anger and greed. So मन, बुद्धि, अहंकार अगर ठीक होंगे तो हमें कोई चिंता नहीं होगी. जैसे कि वेस्टर्न साइंस में प्लेटो को कोट करते हैं कि डॉक्टर नोज़ व्हाट इज़ राइट फॉर द पेशेंट, उसको कुछ बताने की ज़रूरत नहीं है. तो हमारी गीता में तो ये पहले से ही लिखा हुआ है कि अंतरात्मा जो है वो परमात्मा से जुड़ी हुई है और हर मनुष्य परमात्मा का अंश है. तो सही और गलत का निर्णय लेने में अगर हम अंतरात्मा की आवाज़ सुनेंगे तो हम कभी गलती नहीं करेंगे. सो मॉडर्न साइंस कॉल दिस एज द लिम्बिक सिस्टम, छिपकली का दिमाग, कि हम अपनी बेसिक नीड्स पे ही लगे रहते हैं और हम उससे आगे जाते नहीं हैं. साइंस बिहाइंड गीता, अभिमन्यु का हम सब जानते हैं. अभी लास्ट 2 months बैक there is a study published in this high impact journal which says during fetus development hearing mechanism is the initial one to develop. 10 minutes over, so I am not started. So these are the Geeta shloks pertaining to health. We know health is प्रो इन्फ्लेमेटरी साइटोकाइन ज़्यादा होते हैं, एंटी इन्फ्लेमेटरी कम होते हैं तो हम बीमार होते हैं, एंटी इन्फ्लेमेटरी ज़्यादा हो तो हम हील होते हैं. और इम्यूनिटी और इम्यूनोसप्रेशन में इनडायरेक्ट रिलेशनशिप है. और हमारे साइटोकाइन या तो बैक्टीरिया के इंसल्ट से बनते हैं या हमारी सोच, डेंजर एसोसिएटेड मॉलिक्यूलर पैटर्न्स भी होते हैं जो साइटोकाइंस को ड्राइव करते हैं. और हमारा जो वातावरण है वो होस्ट, पैथोजन और ये वाला ट्रायंगल नहीं है, एपिडेमियोलॉजिकल ट्रायड, बट आई सेड इट इज़ ए क्वाड. The fourth dimension is the environment which we carry outside and inside body. We call it microbiome. And 1% of our cells are, 10% of our cells are human cells and 90% are microbiome. DNA and RNA, 1% is human, 99% is microbiome. So they all are working to make our body healthy. So we wrote an editorial in which said we should forget epidemiological triad, we should be talking about the quad. We call it microbiome. We studied that the gut microbiome and skin microbiome helps in skin healing after surgery and convalescence from surgery. There is level 1 evidence which shows that infections are less, paralytic ileus is less, pain requirement is less, infections are less, antibiotic requirements are less, and surgical site infections are less if our microbiome on the skin is healthy. So we conducted a study and published that सर्जरी से पहले आप दही से नहाकर आते हो तो आपको वो इन्फेक्शंस कम होंगे, जो गीता में एक श्लोक से आता है जो आप पढ़ सकते हैं, यहाँ लिखा है. इसी तरह गीता योगा पे जोर देती है. योगा में क्या है? चित्तवृत्ति निरोधा योगा, स्थिर सुखम आसनम. मतलब आपका मन और शरीर में कोई विरोध नहीं होना चाहिए और वो वाली एक्सरसाइज करनी है स्थिर सुखम आसनम, जिसमें आपको कष्ट की अनुभूति ना हो और आप आराम से उस पोज में कुछ समय रह सकें. और ये इसमें साइंस क्या कहती है? डॉक्टर मनचंदा ने कहा हमारे ब्रेन में 95% मेटाबॉलिज्म हैपन्स इन एन एरिया जिसे हम कहते हैं शैतान का दिमाग, इंग्लिश में कहते हैं डिफ़ॉल्ट मोड नेटवर्क. जो काम करने वाला दिमाग है वो 5% मेटाबॉलिज्म यूज़ करता है ऑन फंक्शनल MRI PET स्कैन्स. दीज स्टडीज आर ऑन बेस्ड ऑन फंक्शनल MRI PET स्कैन्स. सो ये जो डिफ़ॉल्ट मोड नेटवर्क है, अगर ये शांत हो जाए तो हमारी आउटपुट जिसे हम पॉजिटिव डायमेट्रिक एक्टिविटी कहते हैं ये बढ़ जाती है. तो काम का तो 5% है, हमें 95% को कम करना है, 5 को बढ़ाना नहीं है. तो ये वेस्टर्न स्टडीज़ हैं जिसमें देखा गया कि मेडिटेशन एंड म्यूज़िक, वेदर एक्सटर्नल इम्पल्स दैट इज़ म्यूज़िक और इंटरनल मेडिटेशन, दोनों से ही ये पॉजिटिव डायमेट्रिक एक्टिविटी बहुत ज़्यादा बढ़ जाती है और इम्यून रिएक्शंस कम हो जाते हैं. डॉक्टर मनचंदा ने स्लीप की बात की, सर्केडियन बायोलॉजी, दीज सो एवरी सेल. आई थिंक आई विल स्टॉप हियर. Basically, Geeta teaches us about a lot of things, and adopting a sattvic way of life helps in healing. So we have published on all these things. Thank you very much. These are the molecular things behind breathing, exercise, and all that. India has given a lot more than what West has given to us. This is a summary. This is from Vishnu Puran that Bharat has been defined. People say it's a new concept. These are the things which we gave to the world, and these are publications on haldi, no relation between piles and spices, keeping your knife away from the umbilicus, yoga after post-operative convalescence covered by American media, music published in Journal of American College of Surgeons helps in post-operative healing. So aim is to make the patient healthy in 48 hours. So thank you very much.
Thank you, sir, for this really unique and beautiful lecture. And it's our loss that due to lack of time, we could not hear the whole of it. Any one or two really exciting questions? So now, after these extremely exciting talk, we come on to medicine. And the first... Okay. So in the Hall B, Gulmohar, also the sessions are started. So whichever topic you're most interested in, all of you are welcome to attend that. So for the first session in this hall, I'd like to invite Dr. Neeraj Jain, sir, who's a senior consultant in rheumatology, Gangaram Hospital, and Dr. Richa Diwan, ma'am, who's the head of the department Family Medicine and senior consultant in medicine at Gangaram Hospital. And our speaker, Dr. Sujata ma'am, who is the senior consultant and head in Paediatric Rheumatology. Today, ma'am will speak on 10 essentials and take-homes of pediatric rheumatology for the pediatrician.
A very warm welcome to everyone for this session. And we have got an first talk on actual medical sciences. We have got Dr. Sujata Shawney. She's a pediatric rheumatologist, one of the few in her specialty. Very few pediatric rheumatologists we have in our country. And she's going to talk about 10 essentials of pediatric rheumatology for the practitioner. And you know that rheumatic diseases are a bit difficult to diagnose in children because symptoms are vague, they are unable to express, and there are not too many diagnostic tests available. So let's learn from the master, Dr. Sujata.
Thank you so much, and good morning, everybody. It's a cold, wintry morning, and it's heartening to see so many in the hall this morning. So who are pediatric rheumatologists? So pediatric rheumatologists are really musculoskeletal specialists who look after a wide variety of diseases. In addition to childhood arthritis, we look after several connective tissue diseases. Prototype is lupus. We look after vasculitis, commonest Henoch-Schönlein purpura. We look after many autoinflammatory diseases that many of you may not be familiar with. Many children with overuse disorders of the bones come to us. We have children who have psychosomatic disorders and come to us with chronic pain. We can also help you to diagnose several heritable disorders of the connective tissue, and then we can help you to identify patients who have musculoskeletal complaints that belong to many specialties. So we diagnose children with leukemias, primary immunodeficiencies, storage disorders, tuberculosis, and endocrine disorders, to name a few. And of course, the longer a child has fever, the less is the likelihood of the child having an infectious etiology driving that clinical phenotype. So from the practitioner point of view, the most important thing that we need to understand is the concept of the window of opportunity. So in rheumatic diseases, whatever organ is involved, we have to understand the concept of disease activity and damage. So it's very important to pick up these children early on in their disease so that they do not have any damage. And therein comes your role, where you can identify a patient who has a rheumatic disease and get that child to the appropriate team so that they have the best possible outcome. When we look at laboratory in pediatric rheumatology, it's again essential for us to understand what is the pre-test probability of the test you're ordering in the given clinical context. So I'll take an example of a very abused test, that is the ANA. So if I run the ANA on 50 people sitting here, you might find that it's positive in 10 of the 50 here. Does that mean those 10 have a rheumatic disease which is being missed? No, because the sensitivity of the ANA is very high, but the specificity for any particular disease is low. And therefore, you must think about what test am I going to order for this patient in the clinical context of the patient. So simple message, choose the right test for the right patient by the right method, and very important is choose the right laboratory that you know is going to run this test appropriately. So if you ask for tests willy-nilly, you often run into trouble because something will come positive. So we often have patients who come to us with families which are very anxious. Child has swollen joints and the family says, but doctor, the rheumatoid factor is negative. But then the rheumatoid factor is negative in 95 out of 100 children with juvenile arthritis. So there's no single test that can rule in or rule out a rheumatic disease. It's the pattern recognition that helps us. The other very important thing from the practitioner point of view is the awareness about biological response modifiers. These are becoming mainline medications where the body's cytokines and particular biologic immune cell types are being targeted. And in the Western world, 7 out of 10 children with juvenile arthritis are on biologics. So you need to know that when a patient is on biologic and comes to you with a febrile illness, how are you going to manage that child? Are you going to stop the biologic? Are you going to screen for infections? Is a biologic going to mask very important features that you may think should come positive? So for example, if I have a patient who has Still's disease, who's on a biologic medication called tocilizumab or Actemra, and that patient has enteric fever, you may find that the C-reactive protein is negative. So as an initial point of contact with the child and family, you have to be aware about the widespread use of biologics. In our own center, 4 out of 10 children with juvenile arthritis are currently on biologics. When we come to childhood lupus, this is the prototypic connective tissue disease, and this disease management has changed dramatically. So from carpet bombing these patients with a lot of severe immunosuppression, there are now many designer drugs available with a lowered side effect profile and excellent outcomes for these patients. Regrettably, we don't have many of the mainline drugs in our country, so we do not have access to drugs such as belimumab, anifrolumab, and the other drug which is voclosporin, but they will come. And again, we need to be aware that we must use steroids for the shortest possible period of time. So treating pediatric rheumatic diseases is not good if in case long-term open-ended steroids are given, because we know they have many side effects. When we come to another common vasculitis that is called Kawasaki disease, the outcomes of children are improving very nicely because pediatricians and general practitioners are now easily able to recognize the incomplete disease, and because of early use of intravenous immunoglobulin, these patients have very good outcomes. Of note, except for the child who has a very minor coronary artery lesion, that is to say only a mild dilatation and no large aneurysm, it's become important for us to look at the morphology of the vessels of the heart and also at the function, such that these children, it is now suggested that they have coronary CT angios to make sure that we are not missing any lesion. And in our hospital, we have developed with the CT department a protocol where we are able to use low dose radiation and identify lesions that have been missed by 2D echo. So there are tremendous advances in the area of pediatric rheumatic diseases, and we need to update ourselves with international guidelines that come every few years for these rare pediatric vasculitides. Another very important thing, you're aware that for children with rheumatic diseases, these conditions are not yet curable. So there are many children who progress into adulthood carrying that disease with them. And therefore, for continuity of care, we need to develop a transition program for these patients. We are very lucky to have a very vibrant and large adult rheumatology division in our hospital, and we often transition our patients to our adult rheumatology colleagues. And the advantage is that we can initially offer joint care, and the child and family don't feel abandoned as they move on to the adult models of care. So that's very, very important, that we need to focus on transition care for children with chronic diseases as they become older. What about imaging? There's been a dramatic advance for the use of POCUS, that is point of care ultrasound in practice. And we are so happy to tell you that we are one of the few units in the country where we use the ultrasound machine for day-to-day scanning for the joints of the children. Why is this important? Because the ultrasound is very sensitive to pick up a joint disease that our hands may miss. It can tell us how much of synovial proliferation is there versus fluid. It can guide us with disease activity because we can study the power Doppler. And also it's very important to do accurate intervention when we want to inject these patients. So POCUS has become a big part of pediatric rheumatic diseases. So we are aware of patients who have autoimmune disease such as lupus, but there's a whole genre of diseases where the innate immune system is abnormal, and these are called auto-inflammatory conditions. They are becoming more diagnosed in our country now, and that's because of availability of whole exome sequencing, and there are targeted therapies available for these patients. And finally, it's very important for us not to only do a clinical care for the child, but take into consideration the child and the family's perception of disease. And this is called PROM, that is patient-reported outcome measure, and it's part and parcel of our day-to-day practice where we want to look at what the patient feels about their disease activity. And we don't willy-nilly treat patients, we treat the patients to particular targets. We define what is called remission for each disease, and then we calculate certain markers, such as in a child with lupus, we look at what is called SLEDAI, in myositis, we do CMAS, and so on and so forth. So I hope I've been able to convince you that pediatric rheumatologists are pattern recognizers. We can help you with differential diagnosis of children who have many, many MSK complaints. We have to evaluate these children carefully with few laboratory tests and treat them appropriately. We must talk to every child and family and look at patient-reported outcomes and objective assessment, appropriate management, individualized for the chair, for the particular child, and then transition as required are all pillars of good care for children with rheumatic diseases. So thank you very much.
Thank you, Dr. Sujata. I think really the 10 minutes were a little short for you. So we'll someday have a full day CME for you. I think we can invite one or two quick questions.
JAK inhibitors in rheumatic diseases?
Yes, JAK inhibitors are licensed for use. Currently, they are licensed in several subcategories of juvenile arthritis, and we have enough data on a drug called tofacitinib. As far as the other JAK-STAT inhibitor, that is baricitinib, is concerned, the trial work is still going on for resistant uveitis for patients who have failed anti-TNF.
Dr. Sujata, I will just ask one question for the audience actually. So what are in a patient, a child with PU, what are the clinical signs when they should ideally refer to a rheumatology opinion actually, a pediatric rheumatology opinion?
So again, it's a question of examining the child very carefully. So if a child with prolonged pyrexia has got photosensitive rashes, has got skin vasculitis, has got asymmetric pulses, is hypertensive, has features of multi-system disorder, and where your patient has failed an adequate course of antibiotics, screening for tuberculosis is negative, you must think of rheumatology, because the longer the fever, the less the chance of infection.
Thank you so much. Thank you, Dr. Sujata. I think we'll close this session.
Thank you, ma'am. I'd request the chairpersons to kindly be seated for the next session. And I'd like to also invite Dr. Satish Saluja, sir, who's the Vice Dean of GRIPMER and the Head of Neonatology at Sir Gangaram Hospital. And Dr. Anil Sachdev, sir, who's the Head of Pediatrics at Sir Gangaram Hospital. Chairpersons to please invite the next speaker. Dr. Pankaj Garg, sir.
Good morning, all of you. It's my pleasant duty to invite Dr. Pankaj Garg, who is Senior Consultant in Neonatology at Sir Gangaram Hospital and the Vice Chairperson in the department. I think and he's going to speak on a very vital subject, on very vital individuals, vulnerable individuals, our tiny premature neonates. So what he's going to speak about is on smartly managing extremely premature neonates for intact survival. Pankaj.
Good morning. Thank you, Dr. Saluja and Dr. Anil. So my topic is to discuss what we have done in our hospital to smartly manage extremely preterm babies for intact survival. Before I do that, two terminologies needs to be explained further. Extremely preterm babies are babies who are less than 28 weeks of gestation, and roughly you can say babies who are less than 1 kg. And intact survival means that they not only survive, but they survive without severe intraventricular hemorrhage, bronchopulmonary dysplasia, which is a condition of lung when they are not able to come out of ventilator, cerebral palsy, which is a very debilitating condition, cognitive deficits like autism, ADHD and others, and necrotizing enterocolitis. And neonatologists are those people who are specialized after doing pediatrics to take care of these babies. Now, all of us know that babies are being survived all over the world. This photograph is of a smallest ever baby born in the world who has survived 268 grams in Tokyo. Now, this is not something which is happening only in Japan or in Western countries. We are also able to match that type of survival. Even if you look at the lowest line, 500 to 750 grams, we are able to save around 50% or more of these babies. And what is also important is to know the gestations. Even at lower gestations and weight, babies are being survived today. The issue is whether we should be able to save them with intact survival. This is a baby who was 520 grams, stayed in our hospital for long period of time. Now this photograph is 1.5 years, 5 years, and then 8 years, and the baby is going to normal school and doing well. What can we do so that these stories are repeated? We have to start from the preconception time. The mother also have to enter the pregnancy at the right age, vaccinated against rubella, chickenpox, no alcohol smoking in pregnancy, folic acid, which is now called periconceptional tablet, 0.4 milligram per day, should enter pregnancy when the serum ferritin levels are optimum, iodine is optimum, and very important recent addition is DHA. DHA, deoxyhexaenoic acid of 200 milligram per day. If it is given in the pregnancy, not only the premature babies are born less, they are born with better IQ potentials. Now, second point is place of delivery. I think it is very important that preterm babies may be born any point of time, and there are a lot of units all around the country and in Delhi where preterm babies are born. But if the preterm baby is born which is less than 28 weeks, it is best to be born in a center who specializes in taking care of these babies. And this is not what I am saying. There is data to suggest that very small babies, if they are born somewhere else and transported to other center, there are more chances of IVH, there are more chances of complications, and more chances of mortality. So place of delivery matters for all, but especially for these group of babies when they should be born at a lesser gestation. Third option is to give these expected preterm mothers a dose of steroid. Here we are talking about dexamethasone, which is given to expectant preterm babies between 24 weeks and 34 weeks, 4 doses, 6 milligram, 12 hours apart. It has been shown that dexamethasone, which is such a low-cost strategy, helps them to have better lungs, their HMDs are lesser, their IVH, intraventricular hemorrhage, is lesser, and this is something which government has allowed even the ANMs to use at the time of referral. Fourth strategy is to use magnesium sulfate. Magnesium sulfate was being used by obstetricians in pre-eclampsia or threatening eclampsia, but now we want to use it for expectant preterm babies, especially babies who are expected to be delivered less than 32 weeks. Loading dose of 4 to 6 grams and then per hour 1 gram. And this short dose of 24 hours does not have any maternal side effects, but have benefit effect that if you give it to 25 these babies of less than 32 weeks, one cerebral palsy can be saved. Very low cost strategy to prevent preterm babies cerebral palsy. Delivery room management is an extensively important part of care of these babies, and one should be trained to take care of these babies. There are protocols that how to maintain temperature of these babies. We have special heated mattresses, plastic wraps, so that babies, as soon as they are born, they're kept in the plastic wrap, not even wiped. We do everything within the plastic wrap, which takes care of their temperature. And the babies reach in the NICU at a normal temperature, their chances of survival are better, their cognition is better. Very important strategy, which is very, very low cost strategy, is delayed cord clamping. What do you mean by that? There was a time when as soon as the baby was born, the cord were clamped. But now we know that if baby is breathing fine, then you delay the cord clamping at least for 60 seconds. And because the preterm baby may not be able to cry, if baby is not crying also and baby is more than 29 weeks, we do cord milking. That means from the placental end to the baby's end 4 times, we milk the cord so that baby gets extra blood, which has beneficial effects. Unfortunately, less than 29 weeks, this strategy of cord milking may have harmful effects, that it can increase risk of IVH. So less than 29 weeks, cord milking is not recommended. What is instead recommended is intact cord resuscitation. That means at the time of delivery, the baby is still connected to the placenta, and we are resuscitating the baby by the side of the delivery table. 7th strategy is giving CPAP births with neopuff. We all have been using self-inflating pugs before, but now we have self-inflating bags have been replaced by neopuff, which is a T-piece resuscitator. And in our hospital, we not only provide T-piece with this, we also have a humidifier attached to it, also have a blender attached to it. So we give measured oxygen, which is humidified oxygen right at birth for these babies. Respiratory distress management has been redefined. We have all the facilities for taking care of these babies, whether it is ECMO, whether it is INO, HFO, and ventilation. Another strategy which is very important is caffeine citrate. Preterm babies are known to forget to breathe. And the remedy lies in this caffeine, which is not the caffeine which we drink. It is a specialized caffeine which is called caffeine citrate, which is a drug of choice for apnea prematurity. And the credit goes to Barbara Smith, who brought this to the world. And now we are using caffeine for these babies to prevent apnea of prematurity and to facilitate extubations. And this is another aspect of DHA. We were part of this study when the role of DHA was defined for the country. And DHA is something which can really make a difference. You can see the photograph on the left side, a baby will see without DHA or DHA deficient baby, and on the right hand side, you can see the clear picture which baby can see baby is sufficient DHA in their body. 9th strategy is reducing infections. Preterm babies are born, but if they get infection, their morbidity is increasing. Despite increase of healthcare associated infection all over the world, in our hospital, in our NICU, we have been to show decline in the healthcare associated infection over last 20 years. The right now rate is only 3% of babies who are born in our hospital. So other is point of care. We have a lot of point of care facilities like flexible bronchoscopy, endoscopy, functional nasal endoscopy, functional echo, point of care ultrasound, point of care sampling, so that baby doesn't have to move from the NICU and remain in a stabilized condition. Very, very important is a cue-based family-centered developmental and supportive care of these preterm babies by stimulation. Simple things like eyes are covered under phototherapy, there are quiet times during each shift, baby is not disturbed, clustering of events, incubators are also covered. We write this, please see and observe me, but don't touch me if possible. Nesting of babies in incubator, which is being taught to all the mothers and all the parents in the NICU. co-bedding of twins. This humanized care is making a lot of difference, reduction of sounds, reduction of light to these babies. We know that too little stimulation is bad, and we are making sure that we are giving appropriate stimulation to these babies. Parental involvement is of paramount importance in cognitive improvement of these babies, whether it is kangaroo mother care, which we start right at birth, but there are specialized models also like COPE, creating opportunity for parent empowerment, premise start program and H-Hope program, when we train the parents to train inside the hospital so that once they go home, they're able to continue that type of optimum stimulation for these babies. So my key message is for smart survival of preterm babies is that we take care of their expectant mothers antenatally, in utero referral of expected preterm births, antenatal steroids and Maxelf, delayed cord clamping, respiratory distress management by surfactant and caffeine, optimized parental and enteral nutrition, better infection control strategies, developmentally supportive care in NICUs, parents' participation, and excellent follow-up program. Thank you so much.
Thank you, Pankaj, for summarizing the smart management of preterm neonates. If audience have a couple of questions, we can take them before we conclude the session.
Yeah, so there's a question which I am posting for the audience. Name the drug of choice for apnea or in premature infants. So they can poll it. I was told that to post a question to the audience. Yeah, so you can, so I've not put that way. I've just put the name, maybe. Right.
Okay. So I think the answer we'll give later on.
Right.
So if there are no questions, I think the one message which clearly comes out of this presentation is that in utero transport of expected preterm delivery, I think rather than transporting the newborn, it's a good idea to transfer the mother to a center where newborn care can be taken care of, because over the years, we have realized that the golden hour, 1 hour after birth, is the most important for stabilizing the child and improving outcomes. The rest all is a story which Dr. Pankaj has beautifully said. It's a multidisciplinary approach. A lot of specialities, subspecialties, and super specialities are involved. Fortunately, Gangaram has all of them. But yes, care at birth and the first hour is the most important thing, and we should be very careful to note about that. And very often it happens that delivery happens somewhere else, and we have to transport a tiny, extremely preterm, vulnerable neonate, and that creates more problems, and the outcomes are much worse in that kind of a scenario. I'll request Dr. Anil to conclude the session and give his final comments.
Thank you, Pankaj, for very lovely presentation. My only one question is that at what stage you screen them for the problems? You know, you have a lot of neonatology has a lot of screening program like ROP, you know. So how frequently and what all screening programs do you do to get the problem quickly?
So there are a lot of screening programs. ROP is done first screening at 3 weeks, and then depending on the maturity of retina, every 1 or 2 weeks. Hearing we do at the time of discharge in the form of autoacoustic emission and BARA. Metabolic screen we do at day 7 of life for all babies. Eye checkups is part of, eye reflux is part of RP program anyway. So we are skinning them so that when they go home, they know which areas need to be strengthened more. And before discharge, even detailed neurological examination is done. So they're able to pick up some tone abnormalities which needs to be modified by occupational therapy in the follow-up.
Okay. Thank you. Any question?
So I have one question. So you mentioned about delayed cord clamping. So are any exceptions to that, or are we following it for all?
Only exception to that if there is a abruptio placenta or there is a cord entanglement around the neck or the cord is ruptured. Except these three, our NRP program now says there is not a contraindication for RH sensitized, ICT positive, HIVs, Australia antigen, twins. Okay. It's not a contraindication.
Thank you.
Okay.
Thank you.
Thank you.
Thank you, Dr. Pankaj. We'll move on to the next session, and this session is...
sir, please, and sir, please, आप लोग wait करिए. Sir, आप लोग wait. Join the...
Yeah. So the next talk is by Dr. Lalit Duggal, and he will be speaking on Sjogrens disease cues and clues. Just to introduce Dr. Duggal is chairman in Department of Rheumatology at Sir Gangaram Hospital, and it's my privilege to be chairing his session, who is my mentor, and he will be speaking on Sjogrens. So normally you see a lot of people coming with dryness of eyes, dryness of mouth. So I think sir will highlight us like what we should do in such cases, or maybe something else.
So just before we start, you all have these voting meters. You have 4 options, A, B, C, and D. So sir will have a poll at the end. So please do vote. Thank you.
Thank you, and welcome to adulthood now after the 2 pediatric lectures. So let me begin with this 56-year-old female who presented with dryness of eyes and mouth along with dysphagia, and as you can see, she had dental caries and a very prominent fissuring of the tongue. So what is Sjogrens? It is a systemic heterogeneous autoimmune disorder which affects the lacrimal glands and the salivary glands, leading to all these conditions. However, one must forget it is a systemic disease, not confined only to the eyes and the mouth, and it is also more prevalent in females to the ratio of 9:10:1, of course, in the age group of more than 40 years. Why did we choose this topic? Because it is, we know, I think many of us are missing, it's one of the most common autoimmune conditions. It is dismissed as fibromyalgia by many. It can overlap with metabolic diseases such as diabetes, and of course, there are some systemic clues which may present before the actual disease. So the risk is at both ends. It is overdiagnosed and underdiagnosed condition. Now, as I mentioned, most of the effects are on the skin, on the mouth, on the eyes, vagina, etc. However, what we must also remember that about 40 to 50% patients may have extra glandular features such as muscle pains, fatigue, joint pains, and lung disease. Now, what I'm going to do now is do a case-based approach of the common presentations along with its association. Let's begin with this 42-year-old lady who came with recurrent non-periodic purpura over the limbs with history of dry eyes and mouth, and investigation showed high acute phase reactants, high immunoglobulins, along with a positive anti-SSA SSB. So biopsy was a leukocytoclastic vasculitis and a diagnosis of a Sjogrens with what is known as a hypergamma-globulinic benign purpura of Waldenström was made. Now, with this case, we know that 50% of the patients present with cutaneous involvement, of which the most common are this dryness, purpura that we've just shown. It can present as an overlap with lupus, or what is known as subacute cutaneous lupus, and in the more sinister form as lymphomas involving the skin and elsewhere. So this is one of the most common presentations. Coming on to the second one with a history of a symmetric inflammatory polyarthritis with a negative RF and CCP. There were no erosions on the X-rays, and the patient had ANA positivity and also an SSA positivity. So a diagnosis of Sjogrens disease, inflammatory polyarthritis was made. What is so important is absence of erosions in the X-rays, along with other features which would suggest a Sjogrens with a polyarthritis. Going on to the next case of a primary Sjogrens on hydroxychloroquine, presented with exertional dyspnea, had bibasilar creps on examination, and had a restricted pattern. A CT chest, as you can see here, showed an interstitial lung of the typical NSIP pattern. Now, pulmonary involvement can occur in about 30% of patients, of which the most common is the interstitial lung, and as you can see, it's the NSIP pattern. However, the most important specific pattern, which is not that common, is what is known as the LIP, or the lymphocytic interstitial pattern. As you can see, I don't have a marker. As you can see here, you have these cysts coming on here along with interstitial changes, which suggest an LIP, which is very specific for a Sjogrens in an autoimmune. Now, because of dryness, the airways can also be affected, as also one must not forget pulmonary hypertension. Going on to the third case of a 38-year-old woman who came with acute onset flaccid quadriparesis, had hypotonia in all limbs, was severely hypokalemic, and had an SSA 3+ positivity. So this patient had what is known as a hypokalemic periodic paralysis secondary to Sjogrens. In the kidney, that can occur in about 10% of patients, and the common areas that are involved are tubular interstitial nephritis. However, we see in clinical practice, we see more of renal tubular acidosis presenting as the case that I've just shown. Glomerular nephritis can occur, but is relatively rare. So this is the next system that can be involved with Sjogrens. Coming to the next case of a primary Sjogrens who presented with acute painful visual loss in one eye hypotonic followed by progressive bilateral lower limb weakness and having optic neuritis with spastic paraparesis. And the serum levels of aquaporin 4 antibody were positive. So this patient had what is known as an NMO or a neuromyelitis optica spectrum with the Sjogrens. This is the next case who had burning pain, tingling, and paresthesia in the limb for more than 1 year with dry eyes and mouth. Examination showed normal reflexes but reduced sensations in the glove and stocking distribution. A skin biopsy showed reduced intraepidermal nerve fiber density with a positive SSA. This is a small fiber neuropathy which is associated with Sjogren's disease, which we must always remember. Just don't pass on pains, aches, pains, and nerve symptoms as maybe non-specific. So this can occur in about 10 to 20% of patients. The clues are aseptic meningitis, multiple sclerosis type, or even an NMO that I've shown. Among the peripheral nervous system, small fiber sensory neuropathy is the most common. We do a sural nerve biopsy, but even a skin biopsy might help. The second most is the axonal sensory motor neuropathy. As would be expected, GI would be involved in the form of reflux disease and atrophic gastritis. But don't forget patients who got persistently high transaminitis and high alkaline phosphatase are probably having an underlying primary biliary cirrhosis or what is known as a cholangitis now, or an autoimmune hepatitis. Finally, red flag. We know that Sjogren's is the most common autoimmune disease associated with lymphoproliferative disorders. The prevalence could be as much as 5 to 10%, increases with the duration of the disease. The most common is what is known as a marginal zone lymphoma. The others come in behind this. And what are the cues and clues to it? A persistent parotid or a lymph node enlargement, persistent intractable purpura, presence of low complements which going down over a period of time, presence of cryoglobulins in the blood, or a kind of a monoglomal gammopathy. This should make one think that this patient could be having an underlying lymphoma. What are the specific investigations in a patient? ANA, which is present in 90%, don't forget, not in 100%, 90%, and an SSA RO, which is quite specific for this, of course, can occur in other CTDs also, along with the systemic features in 60 to 80%. Rheumatoid factor can be present in up to 50% of patients. And of course, objective assessment of dryness of eyes and mouth by these tests that we do. Shermer's is a very simple test, and doing an oral salivary gland, unstimulated salivary flow rate. Those cases where you are not very sure, you can do a very simple lower lip biopsy, which can show dense lymphocytic infiltration and is calculated by what is known as a focus score. Salivary gland ultrasound is an upcoming, non-invasive, very important test which helps in diagnosing, managing, and prognosticating a patient of Sjogren's by two important parameters: inhomogeneity and hypoechoic or anechoic areas. The higher the grading, the more the chances of systemic involvement as well as probability of a lymphoma down the line. This is the classification that is used in studies. However, as in our practice, simple things like excessive dryness of eyes, mouth, presence of an SSA antibody, presence of systemic features, which would probably go along with Sjogren's, like I've just described, would help more than these kind of classification criteria, which are used to classify, not diagnose. Finally, coming on to a brief overview of the treatment as per the latest guidelines. If, as far as the eyes and the mouth are concerned, local steroids, topical cyclosporin, using sugar-free gums. Pilocarpine helps certainly in patients with dry mouth. If you got involvement of the joints, NSAIDs don't work that well for a long period of time. You have to go on to some disease-modifying drug, of which hydroxychloroquine is the best drug. Cutaneous involvement, topical steroids, of course, don't help so much. Systemic steroid along with steroid-sparing drugs. And then going on to the rest of the systems where you need more aggressive treatments. Maybe you could start with drugs such as mycophenolate/azathioprine, going on to cyclophosphamide rituximab. In more recalcitrant diseases, IVIG, especially in the central nervous system or the peripheral nervous system involvement. And in very rare conditions, you can also offer a plasmapheresis. Having said that, let's go on to an audience poll. I don't know how much you understood. In a middle-aged woman with chronic fatigue, polyarthralgias, with mild dry eyes and mouth, what is the most likely answer when suspecting primary Sjogren's? Please have your voting pads on. Rare disease, severe Zika only. Positive SSA-RO in more than 90% of cases. 25 to 40% are seronegative, often requiring specialist input. Extraglandular features are rare in less than 10%. Time begins now. How many seconds, Veronica? Oh. Nobody's answered? Okay.
Voting bag? Only one of you vote me. It hasn't come been recorded. You can answer.
Anybody, just raise your hand. Anybody, what's the correct answer? Anybody, please? Okay. So, after this presentation, 25 to 40% of patients may be seronegative, often requiring specialist input. Right? That is the correct answer. So, what is the take-home message? This is... So, early days, I think, as far as voting is concerned. This is a truly systemic autoimmune disease where extraglandular manifestation can be up to 40 to 50%. Don't forget that of these patients, and they often drive presentation as well as prognosis. We should not forget that. Thank you very much. I acknowledge my postgraduate, Dr. Meghna, who's done a great deal in preparing this presentation. Thank you very much.
Thank you, Dr. Duggal. It was an excellent talk. I think what is important to remember is that Sjogren's disease is the new term which is now acceptable. Earlier it was called Sjogren's syndrome, and that has been replaced by the term Sjogren's disease because it's a distinct disease. It's not a cluster of few conditions or symptoms.
And also, it is now differentiated between primary and not secondary. It's called an associated.
Yes.
When you call a primary, it is just a primary shows, and the one that is associated with conditions such as rheumatoid, lupus, etc., is called an associated Sjogren's,
Yes.
not a secondary Sjogren's.
Yes. So that is what is important to remember is that it's Sjogren's disease, and it can be associated with other conditions like rheumatoid arthritis or anything else. Thank you, Dr. Lalit.
Thank you, chairpersons. Now we move on to the next session on one of the commonest complaints that we all face, reflux. For this session, I'd like to invite our chairpersons, Dr. B.B. Agarwal, sir. He is the head of the Department of General and Laparoscopic Surgery, and Dr. Anil Agarwal, sir, who's the senior consultant in the Department of GI Surgery. Can we please have... To talk, I'd like to invite Dr. Tarun Mittal, sir, who's the Senior Consultant and Unit Head in the Department of General and Laparoscopic Surgery, to speak on the topic Management of Reflux Disease.
BB sir must be outside, yeah. Good morning, everybody.
Sorry for the delay.
And Dr. Tarun is a pride for institution and our Department of Laparoscopic Surgery. He is a very curious and innovative surgeon and does the most recent work which becomes a standard for others to follow.
Thank you, sir. I bring greeting from Sir Gangaram Hospital. Chalniri. Yeah. So, gastroesophageal reflux disease is a very common problem which each of us face in our OPD. And sometimes we have doubt what is the diagnosis, what investigations are required, whether surgery is good or not. So these all things are there, and because it's a very common problem, and if it is not managed well, it can have a lot of lethal consequences also. So one should know when to refer, when to operate, and very important with this, our current lifestyle, it is increasing, obesity is increasing, so is our gastroesophageal reflux disease. Stress is more, so and lifestyle is changing. A lot of initial early to bed, early to rise concept is not there now. So that way lifestyle management are always sitting on the laptop, which has increased the incidence of gastroesophageal reflux disease. So what is that? It is basically, there is a sphincter and the acid is produced in the stomach and food is there in the stomach. If the sphincter is not working well, or if the more of acid is produced in the stomach, or if the esophageal peristalsis is not good, in all these three conditions, the acid can reflux into the esophagus and cause the symptoms, or the food later on can reflux and cause the symptoms of gastroesophageal reflux disease. So what are the most important symptoms? The most important and the most common is heartburn and food and acid regurgitation. So you will have retrosternal burning and sometime epigastric pain. Sometimes you can have dyspepsia, nausea also, or bloating. Dysphagia is a symptom which can sometimes be alarming, but in hiatus hernia with gastroesophageal reflux disease, you can have a commonly dysphagia as a symptoms. And very important, sometimes these patients have chronic cough, change of voice, if the acid reflux into the larynx or the trachea. So these are called the atypical symptoms, or the dental erosion. So you have to rule out a gastroesophageal reflux disease in a patient who has been recently diagnosed as asthma in a middle age time, or they are having chronic cough which is not getting relieved. So we have to investigate for gastroesophageal reflux disease in these patients. So what is the diagnosis? Most of the time based on clinical symptoms. And if the symptoms are there in your OPD, you will always prescribe them proton pump inhibitors. And the response to suppression is a very important thing, which is if they are having good response to suppression, then it means the diagnosis is same. And also if the patient does not want to have long-term proton pump inhibitors, then they will have good results with surgical management also. Sometimes you require endoscopy if they are not getting relieved with the proton pump inhibitors, or they are having complication like a dysphagia. And sometimes when they have atypical symptoms like chronic cough or change of voice, and your diagnosis is non-erosive, in which you have done the endoscopy and esophagitis is not there, then this role of esophageal pH monitoring comes in which you put a probe in the esophagus and the G junction, and it is monitored for 24 hours. And all the refluxes are monitored through this esophageal pH monitoring. As a routine, it is not required for the diagnosis of gastroesophageal reflux disease. So there can be a lot of complications, like it can be erosive esophagitis. There are grades of esophagitis from A to D. You can have A, B, C, D. C and D are more difficult to manage. They can have stricture. A Barrett's esophagus is a condition. It's a metaplasia in which the stomach columnar epithelium goes into the changes in the esophagus area, and it becomes columnar metaplasia. In that, later on, it can convert it into a dysplasia and then the malignancy. So that is a very lethal consequence which can happen if the GRD is not managed well. And these patients can have COPD as told, and dysphagia if they have strictures or they have a large hiatus hernia. So the treatment option, one of the most important thing, we describe all the patients the proton pump inhibitors, but the most important thing is lifestyle modification. They should have early to bed, early to rise, and then they should have minimum 2 to 3 hours gap between the last meal and when you sleep, and do not drink water with the meals. Avoid the things which trigger GRD, like a very fatty meal or a tea, coffee, juices, and cold drinks, chocolates. These all things should be avoided. And take lot of probiotics or curd, which is a very good. I myself was suffering from GRD, and after this lifestyle modification, I have stopped using proton pump inhibitors for past 7 years. Initially, I was having for 2 to 3 years continuous. Then, obviously, if these patients are obese, then you would have to manage the weight and control their weight. And if they lose weight, the most of the GRD will reduce. And then if these two things plus acid suppression drugs are good, you should prescribe them, but not long term. If you prescribe long-term PPI, we see, in all our prescription, we write proton pump inhibitors, but they have its own consequences, like B12 malabsorption is there, calcium bone health, calcium absorption is not there, bone health decreases. Then there are side effects like patient have had CKD also with if you are having long-term PPIs. So it is not without its side effect. So one should be cautious when you are using acid suppression drug for long-term. And give an option of surgical therapy or an intervention if they are, after they are stopping the drugs, they are again having the GRD. So endoscopy is a very simple procedure which will help us in diagnosis of GRD if there are erosions, and then it can diagnose the complications if there are like esophagitis, Barrett's esophagus, and any other disease we are missing. Sometimes the vague symptoms of GRD can be a malignancy also. So if the symptoms are not getting relieved with PPI, and in old age patient are on the side of having an endoscopy being done. So surgical therapy is a good option because you create a new valve from the fundus, and it's a one-time solution for a disease which is chronic. It is based on a lot of indications. If it's a patient choice, patient feels that does not want to have lifelong proton pump inhibitors and does not want to restrict his lifestyle, or intolerance to medical therapy, they have a side effect, or sometimes it's a very severe GRD, it's not responding so well to the medical therapy, or they are having complication like stricture or a severe esophagitis. Especially if you have an endoscopy with large hiatal hernia and esophagitis, then it is better, it's a primary indication you should offer these patients a surgery because they will not get better with medical management if it's a large hernia with the GRD symptoms. And then the side effects of the surgery. And if they are very obese, then you might have to give them a bariatric surgery as an option if they are not getting better with the medical management. So these are all indications. So if you have a GRD in obese patients, you can start them on weight loss plus your PPIs. And if they are very obese, like more than 40 BMI or 45 BMI, then you might consult these patients for a bariatric surgery and refer them to a bariatric surgeon. Or now newer drugs have come up, which are definitely very good and can have weight loss. And so you can start them with the GLP analogs, which have started coming up, Ozempic and Mounjaro, and it have good result. So it is based on patient's requirement. If patient is 50, 60 BMI, so that drugs will not affect. But 40 BMI and less, these drugs are useful. You can lose 10 to 15% of your weight loss, and it will help the patients and reduce the comorbidities. So just small videos, one minute, then I'm done. So this is, we do, all these surgeries are done laparoscopically by small incision and now also robotically. So one is able to move and ambulate the same day, is discharged the next day. So patients, the patient compliance and patient pain is less. So they are refer these other patients also to us so that they don't have to have lifelong medications. We have to have, because this is done laparoscopically, the vision is very good. It's 8 to 10 times magnified, and you have to have good endoscopic suturing so that you can do a good job. We have now good energy sources because of which we are able to do this surgery in less than 1 hour, and sometimes we do it just as a daycare surgery and discharge them next morning. And with this, initially, they will have some amount of bloating and some amount of dysphagia because new valve has been created, but over a 3 to 4 weeks, this will get better, and they will, after that, they can eat their normal life and eat normal food. So this is a patient who had hiatus hernia and was very obese. So in this, we did a bariatric surgery in which we did a sleeve with a hiatus hernia repair. So this is the hiatus, which is hernia, it's there at the GE junction. We close that hiatus, and then with the help of good staplers which are there, we can just staple the stomach and come out. In this surgery also takes 1.5 hours. And now 90% of our bariatric surgery also, we are doing it as a daycare surgery, and we are not keeping them for more than 1 day. And in the end, it's the team. You have to have a good assistant. You have to have a good, your physician care has to be good. Your anesthetist has to be good. You work as a team and progress. Thank you.
Thank you. Thank you, Tarun, for very nicely covering the topic and also excellent display of the surgical skills into managing these patients if the, as he said, that when the medical management or the endoscopist management fails. So any topic is open for any questions or comments? Quick 1 or 2 questions or comments? Anything? Yes.
Yes, sir. Tranquilizers. So many of these patients are have anxiety, and sometimes these patients require help of some taking medications, sometime, but not always. But you can give them.
Any preference of vanoprazone over PPI in GRD?
So vanoprazole, this is a new drug which has come in. You can have them, but see if PPI as such, any proton pump inhibitor is good, and they will suppress 90 to 95% of the time. Your acid suppression is there, so it is good. Newer drug we have not tried personally in our patients, but they literature-wise it is supposed to be good.
And role of prokinetics?
Prokinetic role is there. If a patient has a lot of bloating and patient has a lot of fullness post after the meals, so in then it means there is some motility disorder is also there, then you can have them. If on manometry, for example, there is a one investigation, there is a manometry also is there, in which you have absent esophageal peristalsis or low peristalsis, and then you can add these prokinetics in them.
In India, it is quite used a lot.
Yeah, it is used a common, yeah.
And in the West, they don't use it quite often.
Based on indication, it should be used. It has its own side effects also.
Either we have a diet like that.
Yeah. Because of our diet, because of obesity, because a lot of oil is there, aloo, puri, parathas, we are having these things. So that has, and tea also has its own issues which can create all problems. Lot of green tea people are having. That also causes a lot of GRD. Sometimes patients do not tolerate. They are having 4, 6 times green tea for weight loss. So maximum twice a day they should have it, not more than that.
Thank you, sir.
So prebiotic, probiotic in general is very good for us, and it increases our body digestion. And as Dr. Bibi sir also talked about, and there is lot of data available for all the diseases in the body, from metabolic syndrome to GRD to inflammatory bowel disease. The probiotic has role. There is lot of fecal transplants happening for bariatric patients also. Like you take the fecal of the good flora which is there. So that decreases the inflammations. So lot of papers are there now, and we should have good diet, have good probiotics, dahi and good food you should have, which will definitely decrease the inflammation which is there in the body.
I think some of the points that Tarun mentioned, and he mentioned that he himself was taking PPIs and others, and I think with the lifestyle change and other things. And I think that is very, very important what he emphasized, because I think you would agree, Tarun, that in the Western world, the surgeries conducted for this are much higher. But that is because the PPIs are very costly abroad, and the insurance companies wouldn't pay for the PPI and are happy to get a surgery done. So I think just keep that also in mind, because when we are advocating to the patient. So I think it's a stepwise approach, like as he very nicely mentioned about, that wherein the medical management, the endoscopist, and then the surgery. So, yeah.
Just line for prebiotics, since he mentioned, there are studies that fresh curd, 1 teaspoonful, and 1 teaspoonful of isabgol husk, because scientifically studied this typical empty stomach in the morning provides you the best prebiotic, that is from isabgol, and probiotic from the curd. The caution to be taken, do not put the curd in refrigerator. It should be fresh outside. Thank you, Tarun.
Thank you, sir. Thank you, sir.
Thank you for the refreshing session. And can we have a huge round of applause, please? Thank you. For the next session, can I please invite the chairperson, Dr. Satnam Chabra, sir, who's the head of the Department of Neurosurgery at Gangaram Hospital, and Dr. Sinha, sir, who's the unit head and senior consultant neurosurgery at Gangaram Hospital, for an interesting and advanced session on trembling hands no more, a new hope for Parkinson's disease.
So, good morning, everyone. So, next talk is by Dr. Shrey Jain on Parkinson's disease treatment. As you all know, Parkinson's disease is very common these days, and as the age average age is advancing, the incidence is also increases. And when medicines fail, then what options we have? Dr. Shrey Jain is going to talk about that. Yes, Dr. Shrey.
Thank you, sir. Good morning, everybody. Today, we are going to talk about trembling hands, no more, and new hope for Parkinson's. As Dr. Satnam just said, that with the rising age, a lot of new problems have started coming into picture, especially cases of dementia and some movement disorders, which have become quite common. So let's talk about movement disorders first. Movement disorders basically means that these are disorders of nervous system wherein there is abnormal movement. Now, these abnormal movement can affect your hands, your legs, your face, neck, head, voice. Primarily divided into two types of movement disorders. One is when there is increased movement, and other disorders where there is decreased movement. One thing that is common with all movement disorders is that all patients are mentally intact. A brief of type of movement disorders. We have something called as dystonia, where there is involuntary contraction or twisting movements which can affect your hands. You might have heard about writer's cramp. These are types of focal dystonias. Then tremors. In tremors, there is rhythmic shaking of the hands. Then there's something called as ataxia, which happens because of poor muscle control and resulting in clumsy movements. Then there is a very common movement disorder that we all know about, which is called Parkinson's disease. Parkinson's disease primarily comprises of three symptoms, which is bradykinesia, rigidity, and tremors. And then there is another movement disorder called chorea, whereas there is very irregular dance-like movements. In all these movement disorders, the diagnosis is paramount. Most of the patients can be diagnosed just on clinical history and examination. In other cases, we have to get certain investigations done to rule out any secondary causes, because if there is any cause that is responsible for movement disorder, then that needs to be corrected, for which we have various investigations, including MRI, autoimmune panel, genetic testing. A lot of movement disorders are drug-induced, blood tests, and CSF analysis to rule out encephalitis. Management of movement disorders is, first of all, we need to treat the underlying cause. If we are able to find that underlying cause in the prior investigations, there are certain medications that can also be used for tremors, bradykinesia, rigidity. Botulinum toxins can be used for dystonia, stick disorders. There is physical therapy, and then there are surgical options. Now, surgical options are primarily divided into two types of options. One is stimulation procedures, and the other is lesioning procedures. The basic difference between the two types of procedures are stimulation procedures. They work by supplying electric current, and they are non-destructive. Lesioning procedures are destructive in nature. They burn out the aberrant circuit that is responsible for such movement disorders. So first we are going to talk about stimulation procedure, which is deep brain stimulation. It's a neurosurgical procedure that involves implanting electrodes in specific areas of the brain. It comprises of an implanted electrode and a pulse generator. It acts by delivering electrical stimulation to the brain, and it can also be called as pacemaker of the brain. Indications include Parkinson's disease, essential tremors, dystonia. Off-label, it has also been used for OCD, Tourette's, and depression. Now, this procedure has been FDA approved for tremors since 1997, for Parkinson's since 2002, and for OCD since 2009. Stimulation targets depends upon the primary symptoms of the patient, because if a patient is having more of bradykinesia, then different target is selected. If the patient is having tremors, then we select a different target. So all this is clinically correlated. Mechanism of action is it alters the abnormal neural firing. So what happens is the basal ganglia that is responsible for modulation of movements, the circuits that are there, they become aberrant and they cause abnormal firing of electrical impulses. So by providing stimulation, we do neuromodulation of the electrical signals, and this causes symptom improvement. This procedure is performed under local anesthesia, and there are various safety guidelines that we follow. The three important safety measures that we take are, there is intra-op microelectrode recording, which basically means that during the procedure, we record the local field potentials of the nerve cells so that we are 100% sure that we are at the correct place. Then during the procedure, we stimulate those particular areas and we clinically examine to see if the patient is having resolution of symptoms and if there are any complications that are developing, so that these things can be corrected on table. So all in all, I can say that during the surgery only we know that the patient is going to improve 100%. The clinical impacts are, it reduces tremors, rigidity and bradykinesia. It decreases motor fluctuation. It allows medication reduction and dependence and improves quality of life. It has impact in other disorders also, like essential tremors. It causes major tremor reduction in dystonias. It is very effective in young onset generalized forms. This is a small video, wherein the first video we can see that the patient has a lot of tremors, and which is not visible in the video is that the patient had a lot of tremor and rigidity. And this is the second video, one day after the procedure, where the patient is able to drink water, which he hadn't done in a long time. Now, certain risks about the procedure. There's risk of surgical bleeding, infection, hardware issues. Very, very important is careful candidate selection, because surgery can be done in any patient, but we need to make sure that whoever we are operating on will benefit from the surgery. And another consideration is the cost of the procedure. Advantages, it can be done bilaterally and programming can be done through remote. There is no tissue destruction. If there are any complications, then the procedure is totally reversible. And it is very good for progressive disorders, because as the stimulation carries on, the aberrant pathways are reformed. So as the disease progresses, we can change the stimulation parameters to make sure that the patient is symptom-free for a very, very long time, for up to 10 to 20 years. Now we're going to talk about the lesioning procedures. Lesioning procedures are divided into two parts. One, we are going to talk about the stereotactic lesioning, which is a very, very old procedure which has been going on for last 80 years. The pros of such procedure is it is a one-time procedure. It has negligible cost, and it's also performed under local anesthesia, as is deep brain stimulation. Even in this procedure, on table we get to know whether the patient is having any kind of symptom improvement or not, or if there are any complications, so that the procedure can be modified accordingly. It's a minimally invasive procedure where we use 1.2 mm electrode, and there is no permanent implant available. No permanent implant in such patients. Cons are that it's a one-time procedure and it is irreversible, and it is not so good for progressive diseases. But these procedures are very good for tremors or dystonia, wherein one-time procedure can cause curative treatment for the patient. Then there is a newer technology that we have called MRI guided focused ultrasound. Gangaram Hospital is the first hospital in North India to have this machine. It does the same procedure as stereotactic lesioning, except it's non-invasive. There is no cut, we don't go inside the brain, but we are transmitting ultrasound waves through a helmet, as you can see in the picture. It's done in MRI machine, and there's a helmet that the patient wears. And through that helmet, we focus all the ultrasound waves to a particular target, which is monitored through an MRI. And here also, on table, we get to know what kind of improvement are we looking at. And the cons are the same as stereotactic lesioning, that it's a one-time procedure, and it's an irreversible procedure. And one of the cons is that it's slightly more expensive than stereotactic lesioning. So this was about the procedures that we have. There are newer techniques that are being developed. For example, in deep brain stimulation, there is something new which is upcoming, which is called as adaptive DBS. We are in an era of AI. So in adaptive DBS, what happens is that through those electrodes, they record the potentials, and the machine itself tries to decipher what kind of problem that the patient is having, and then they modulate the current. So you don't need even programming. Once the patient starts developing any other symptoms, then the currents are modulated through the machine so that the patient remains symptom-free even when the disease progresses. Now, combined approaches are more important than single approaches, because there are certain things for which lesioning is better, and there are other progressive diseases wherein the stimulation is better. So we should look for combined approaches. It's better to combine DBS and lesioning procedures for better patient outcome. Now, key takeaways here is these kind of surgeries are life-changing for selected movement disorder patients. Technology is rapidly evolving, and it should be given as a primary option for patients with progressive disorders. Thank you.
Thanks, Dr. Shrey, for a very nice presentation in a small time. And the topic is open for discussion. Any question from the audience?
So deep brain stimulation is it's very, very good and has been proven really good for Parkinson's disease because it's a progressive disease. So one-time procedure doesn't really help. We need to make sure that the patients remain symptom-free for a long time. Also, it causes less dependence on medication. So early morning stiffness, early morning rigidity and bradykinesia, all that is not there once the surgery is done. Cost depends upon the type of the implant that we are using. The electrode and the battery that we implant, the cost ranges from approximately 10 lakhs to 15 lakhs. One is a rechargeable battery, the other is a non-rechargeable battery. Then we can also control the direction in which the current is being delivered. So all that decides the cost of the implant.
It's quite expensive that way.
Yes.
And those patients who are not responding to the drug treatment, you select those patients in Parkinson's?
Sir, it depends. If the patients, they have good response, because we do a lot of UPDRS scoring before the procedure, wherein the patient is examined without any medication, then with medications, so that during the assessment we get a realistic idea what kind of improvement are we looking at after the procedure. Once we are 100% sure that the patient is going to benefit, then only we do the procedure.
Medicine is always the first line of management in initial patients. And accordingly, these procedures have to be used in a super selected patients where we are sure about improving the quality of life. And it definitely improves the quality of life. We have seen patients, we have come across patients known as well as few doctors also where it has made a remarkable difference in the quality of life.
Thank you.
So it's a combined team effort, but the assessment program is, the protocol has been set worldwide. So we follow the same scoring system, and based on the scoring system, we analyze and we decide whether the patient is going to benefit or not.
You see, all these treatments are not curative treatments. So medicines are tried first. When medicines fail as the disease advances, there these treatments come into role.
Any more question?
Okay.
Thank you so
much.
much for this very exciting session. Any question we have? Yes, ma'am.
Is there any food restriction for Parkinson's?
Ma'am?
Is there any food restriction?
For Parkinson's? No, ma'am.
Like tomatoes, very big tomatoes and all?
No restriction as such, ma'am.
Anything you'd like to add, sir?
So with that, we conclude this session. Thanks, Dr.
Thank you. Let's have a huge round of applause for this very new, exciting treatment for Parkinson's disease. Now we proceed to the next session on burning COPD with steam, bronchoscopic lung volume reduction. And for this session, I'd like to invite the chairperson, Dr. Ujjwal Parekh, sir, senior consultant in the Department of Pulmonology, Sir Gangaram Hospital, and Dr. Muhammad Wali, sir, Professor Emeritus and a very renowned physician. Dr. Abhinav, sir.
नहीं वॉल्यूम नहीं है वॉल्यूम बंद ही रखना अगर
Good morning, everyone. As we know, the incidence of respiratory illnesses are increasing because of various reasons. The incidence of COPD is also increasing. And with the increase of incidence of COPD, it's projected to be one of the most morbid and mortality-causing disease in the future. For last more than 2 decades, we do not have a new class of medicines which have come for the treatment of COPD. So we are just using the same medicines or better versions of the same group of medications. But for last 2-3 years, in our hospital, we have started a procedure which is helping those patients who are moderate to severe COPDs, who are having repeated exacerbations by the use of invasive technique, which is a bronchoscopy. And Dr. Abhinav Guliani, who is our senior consultant, is going to give you insight about that procedure.
Thank you so much, sir, for the lovely introduction. I am Dr. Abhinav Guliani, and I'll be talking about how we treat COPD by burning the lungs. So COPD, as we all know, is a common preventable and treatable disease which is characterized by airway or alveolar abnormalities. It is usually caused by significant exposure to noxious particles, gases, and infections like tuberculosis. It is a heterogeneous lung condition, which means the lung uniformly is not damaged as a whole in many cases. It is the third leading cause of death worldwide, and it is a major cause of chronic morbidity because of lung diseases. A lot of money is spent on treating and managing COPD patients. So this is what the structural abnormality in COPD is, what we call as emphysema. So emphysema is destruction of the alveoli or the major functional unit of the lung. If it is along the septae, around, these are the septae of the lung, if it is around that, it is called a paraseptal emphysema, which leaves this lung nearly normal in comparison to the rest. Or it can be a panlobular emphysema where the whole structure of the lobe is destroyed. If you can see the depictory photograph over here. So in cases of both these patients, what happens is emphysema. If it is classical emphysema, which is panlobular emphysema, patients will present differently. If it is chronic bronchitis, it will present differently. This is how we've been taught. But most patients have mixed features. Emphysema primarily leads to hyperinflation, which compromises respiratory mechanics, leading to persistent symptoms. And as you can see in this photograph, what is hyperinflation? Hyperinflation is when the lung is more in size. It is pushing the diaphragm below, it is compressing the heart, the vessels are pruned towards the periphery. This is a classical chest X-ray of a COPD patient with hyperinflation. You can also see the retrocardiac or the retrosternal airspace, which is increased. Otherwise, the heart is touching the sternum. Over here, you can see the chest to be a barrel shape, which is classical emphysema with hyperinflation. So how do we manage COPD? We all know this, the medical management: smoking cessation, multiple drugs, bronchodilators, rehabilitation, oxygen therapy, and ventilatory support in case the patient is not responding. But I'll be focusing on volume reduction. So if the lung is not uniformly damaged and you remove the most damaged part of the lung, it is called volume reduction. This can be done both surgically and now bronchoscopically as well. When everything fails, you have lung transplant, which is also now coming up as a treatment modality for advanced COPD. So this is a depictory photograph of, if you look on the right side of the screen, the red portion is the most damaged area which can be treated, and after treatment which is lung volume reduction, this reduces to a very small portion, and the orange part, which is the normal lung, gets a lot of more space for gas exchange and better ventilation. Also, the diaphragm comes up. You can see the comparative X-rays before and after lung volume reduction. You see the diaphragm beautifully coming up and the volume of the lung reducing to normal. With that, the symptoms definitely improve. So these are the various bronchoscopic methods available. Valves and coils are the commonest ones which were studied worldwide, and they are FDA approved, but they are not approved or available in India. They are very expensive, and they involve an implant like this to be left in the lung. And if such an implant is left, multiple of them, one, it will be more expensive. Second, it will cause more infections. So these modalities have this disadvantage. AeriSeal, which is basically a sclerosant, a chemical lung sealant which you can put in the lung, but did not stand the test of time because it caused more damage rather than benefit. Similarly, airway bypass procedures where such valves were inserted into the airway to let the air back into the airway and patient could exhale it out. But again, you are leaving an implant which causes possible damage and possible side effects. So coming to bronchoscopic thermal vapor ablation, this is a non-surgical, non-implant based treatment for severe COPDs. Heated vapor is instilled endobronchially in a controlled manner through a special catheter which causes injury. Steam would cause burns. So it basically burns the lung from the inside, causes inflammation and ischemia, which heals by fibrosis. And that fibrosis leads to shrinkage. And when the emphysematous lung shrinks, it causes lung volume reduction. So this is not affected by if the lobe is communicating with the other lobe through the alveoli or any implant being left inside. So potentially those side effects were less. This is the intervapor system. This is the steam generator, and this is the handheld device from which the steam comes out like this. And this steam is channelized through a catheter which has a tip and a tamponade balloon which occludes the airway, which can be let into the target segment. So how do you do it? You basically do a CT scan to determine the most diseased segment and plan the treatment. So by CT you would determine that this part of the lung is most hyperinflated, and by treating it you would reduce the volume by a certain percentage. The vapor is delivered through this dedicated catheter through a regular bronchoscope during a regular bronchoscopy, so it is not a very lengthy procedure. You put the catheter, you block the airway with the balloon, and you instill the steam in. I will demonstrate this in the video next. Gradually, the lung volume reduction happens over the next 6 weeks by natural apoptosis or natural cell death. So what is the target population? Severe, stable and symptomatic COPD patients who have heterogeneous emphysema were initially being taken up, and now it is being approved for homogeneous emphysema as well. The patients should not have an increased risk of bleeding. The patients usually included are patients with severe COPD with the FEV1 of 20 to 45%, a residual volume of more than 175%. They should be stable in the last 3 months with no hospitalizations and no major exacerbations in the last 3 months. They should not be on a very high oral dose of steroids. They should be symptomatic with a poor quality of life despite best or maximal medical therapy. They should always be a part of a rehab program and also be not smoking at that time. The CT should show heterogeneous emphysema, preferably in the upper lobes, ideally, but this is a relative indication now. The absolute contraindications would be any absolute contraindication to bronchoscopy, active infections, ABG showing a high CO2 level, and a very high pulmonary artery pressure, which may lead to high risk of bleeding. Patients who had had a major cardiovascular event in the last 12 months are also excluded. The relative contraindications are very severe patients in whom the pulmonary artery pressures are high, they are very low on BMI or very high on BMI, they are unable to walk more than 140 meters. So this is the typical PFT of that patient with a severe COPD, and this is what a classical heterogeneous emphysema would look like on the CT scan. So if you see, the emphysema is more peripheral, more in the upper lobes. And when you analyze this CT, you would find out that the upper lobe anterior segment has a volume of around 700 ml. So if you reduce this 700 ml, you are potentially reducing the total lung volume by 700 ml, which is quite significant. And this is how the treatment chart would look like. They will give you a virtual bronchoscopic image. You will insert the catheter, and once the catheter is inserted, you will block the airway. This is the catheter being inserted. And once the catheter is in, you would inflate a balloon to block the airway so that the steam does not pass through into the other normal lung tissue. Once this catheter is inflated, you can pass the steam, and you can very well see the steam flowing through this net over here. This is the window where you can see the steam passing through. Immediately post installation of steam, you can see good blanching of the mucosa. That means the mucosa has been treated. And this is how simple, short this procedure is. Post the procedure, you will definitely see a patch because you are creating inflammation. So it will look like a pneumonia or an exacerbation. A mild exacerbation will happen. The patient may have some hemoptysis, but these are all self-limiting and they come down in the next 1 week or so. You can give steroids and manage these patients. What does the data say? So this is a meta-analysis of 4 trials with 112 patients, wherein they demonstrated significant improvement at 6 months in FEV1, residual volume, the total lung volume, 6-minute walk distance, and the St. George's Respiratory Questionnaire. So symptomatically, the patients improved, and so did the PFT. The maximum benefit was at 3 months. The only side effects were a small exacerbation or a pneumonia. In our experience, we have dealt with 8 cases. We have treated 4 right upper lobes, 2 left upper lobes, and now we've also treated 1 lingular and 1 left lower lobe. That means the indications have increased. And this was done with discussion and with the prior approvals. 1 patient was on long-term oxygen and BiPAP and now is off oxygen, mobilizing well. The 6-minute walk distance was better in 7, the FEV1 improved in 4, and the symptomatic St. George's Respiratory Questionnaire improved in 7. So typically you require 1 sitting, but some patients would also require 2 sittings to treat more damaged areas of the lung. This is a classical CT demonstrating how effective the procedure is. This is the right upper lobe, which was after treatment showing a good apoptosis and shrinkage like this, and you can see the volume is definitely reduced even on a CT. You can compare the right side with the left side, which looks much more voluminous. The spirometry of this patient showed a good improvement in both the volume and the walk distance. If you compare it with the other modalities, it is equally effective with less side effects. And so the most studied being the valves and the coils, this modality of ours improves the FEV1 SGRQ score with least medical events after the outcome. So much so that the GOLD guidelines have now introduced this modality for treatment of COPD, either heterogeneous or homogeneous, when medical therapy has exhausted. To conclude, lung volume reduction is a viable option when medical therapy has exhausted. Many bronchoscopic options are available, but the cheapest and the safest is vapor ablation, and it is dependable. Thank you.
Thank you, Dr. Guliani, for bringing out this safer and smarter procedure. Are you seeing more such cases to be covered after COVID? Because there is a global initiative on chronic lung disease, and this procedure is part of that. So, are we seeing more cases, emphysema, post-COVID? Because the ground glassing and all the changes are persisting. In some of the cases, still we see.
So post-COVID, people are more aware. So they are getting screened, and we are picking up more COPD. But this modality is primarily reserved for obstructive airway disease. COVID leads to a restrictive lung disease. So possibly the target populations are different, and we are able to pick up more patients because of more awareness, and people are definitely now coming forward and they want more.
Thank you. Are there any questions?
Cool. No, ma'am, that does not happen. So we are treating the disease segment, which is pressing the normal lung. So this we are doing when it is heterogeneous. That means some part of normal lung tissue is available. We are not treating the normal or healthy lung. We are treating the most diseased segment, and we are not treating when the whole lung is damaged. Generally.
Yeah, I have a question.
Sir.
What is the exact follow-up protocol after the burning procedure?
So we follow up the patient. Initially, we would keep the patient in hospital for about 4 to 5 days. The patient is discharged and followed up weekly for about 2 to 3 weeks. And once they are stable, it is just like a regular COPD follow-up, which is maybe say once in 2 to 3 months, sir.
And what's the exact outcome?
See, the outcome is improvement in the symptoms, improvement in the walk distance. That is the main aim of the procedure, sir.
Thank you.
See, this procedure is to decrease the suffering and increase the quality of life. It has nothing to do with cure of the disease. Patient still needs to be on medications, but those medications are expected to come down with this procedure. And coming back to ma'am's question, yes, it does happen that the other side will increase. So exact increase in lung volume never happens. So he has also shown in that PFT that exact increase will never happen because some other areas will definitely overinflate. But it's an overall improvement in the symptoms, which is the target.
And you can treat these patients later on when they are having hyperinflation on the other side. So a couple of patients, we treated the right upper lobe, and later we treated the left lower lobe because the patient showed a significant improvement.
so far there is no experience of doing it after few years, repeating it after few years, but probably this procedure has the potential of doing later on also, because COPD is a progressive disease. So in a progressive disease, you expect that other areas will become disease and its symptoms will again become worse. So maybe in future, this procedure can itself be repeated. So that is the advantage of this.
Rightly put, sir.
So if there are no other questions, we'll end this session. Thank you.
Thank you, respected Chairperson, Dr. Abhinav, for a really interesting session. For the next session on refractory anemia in children, coming back to pediatrics, opening the mystery box, I'd like to invite Dr. Dinesh Kaul, sir, Senior Consultant, Department of Pediatrics, and Dr. Nitin Gupta, sir, Senior Consultant, Department of Rheumatology, and Dr. Manas Kalra, sir. Chairpersons, please kindly introduce the speaker.
Thanks for inviting us over here. Dr. Manas Kalra doesn't need really any introduction. With Dr. Nirupam Sajdev and they are the pillars over hemato-oncology division, which is well known over whole of North India, doing not anemias, thalassemias, refractory anemias, doing BMTs, treating all ALLs, AMLs. So today, as a part of for the general practitioners, I think he will discuss about refractory anemias in children. So let's see what is newer modalities, what are the genetic conditions. Dr. Kalra, go ahead.
So a very good morning to all of you and welcome to Gangaram CME. And it's really an honor to be here with this galaxy of speakers from Gangaram who are presenting the best of best. And I thought that we have a mixed crowd and there may not be many pediatricians here. So I thought I'll keep the tempo of my talk to a general anemia talk, which is relevant to a physician, a medicine specialist, a surgeon, or even if I'm lucky, maybe a pediatrician who's in the crowd. Dr. Nitin looks after adult hematology. Dr. Dinesh is involved in a huge amount of thalassemia work. And I look after pediatric hematology, oncology, bone marrow transplant, and children who are born with immunodeficiency disorders. And this is, the hospital where we work. And it's indeed a privilege to be a part of this hospital. So why anemia? Despite all the attempts of Government of India, the anemia assessment still shows that 70% of children, teenagers, pregnant women, lactating women, adolescent girls and boys, they are anemic. So isn't this sad that, we have had like around 15, 20 programs over so many years to look after anemia, but we are not able to fix this. And can you believe it that if you are anemic, and if you're a young child with iron deficiency anemia, your IQ may be less by 5-10 points as compared to others. So how do we expect India to be shining and to be at the top if all our young children are anemic and are iron deficient? So I think the focus has to be on anemia in this country, and the government with the Anemia Mukt Bharat Abhiyan is trying to, really make an impact which has not happened over the last 40-50 years, and we have started to see some trends of improvement of anemia in patients. The commonest is iron deficiency anemia, and you look after this all the time. You have a patient with low hemoglobin, MCV is low, RDW is high, RBC count is low. And you do basic blood tests, you find low iron, low ferritin, and all the other markers, and that this is iron deficiency anemia. And you treat these patients, the smear will show a microcytic hypochromic picture, and you do all the basic investigations, you treat them. But what happens, often we start them on iron, and then we forget, or we give them B12, folic acid, or whatever, and then we forget, is the patient responding appropriately or not? That is very important because, I understand that 70-80% of Indian population is nutritionally anemic in that category. But if they are not responding, we need a specialist opinion. Why? Because some of these conditions may mimic nutritional anemias, but are actually not nutritional anemias. And I'll show you some case vignettes. So this 7-year-old boy who came to us with lethargy, pallor for a few months, has got microcytic hypochromic anemia. It's not responded to iron, He's been taking iron for a long time. There are some joint pains, there are fevers. And you look at the picture and it looks like an anemia with microcytosis, and you think, oh, this is iron deficiency anemia. मैं iron का syrup बदल देता हूँ, मैं गोली बदल देता हूँ, आप iron ठीक से नहीं लेते होगे, दूध ज़्यादा पिला रहे होगे. And months and months are going on in that discussion, but the patient is not really responding. And once he comes to a hematologist, he listens about bone pains, joint pains, child with anemia. First thing is he does a bone marrow. Why? Because we are really scared of missing a leukemia. And leukemia is a big common problem that, a pediatric hematologist sees. But to his surprise, when he looks at the marrow is kind of iron overloaded. And that is when he starts wondering, what did I miss? What was this child actually having, and why is he or she not responding to treatment with iron? And then, a good, humble medical resident says, Sir, bachcha to bahut chota hai aur BP bahut high hai. So, the crux is in a good medical examination. You may be able to do fancy tests, but you miss certain subtle signs in children. And, this child actually had a CKD. It was asymptomatic. There was a chronic kidney disease which was presenting as anemia. And there are many conditions which can present as anemia of chronic disease. And we need to be aware. And, this child had CKD and is with the nephrologist and is doing okay. But, the focus was anemia here, but the condition was originating from kidney. This is a 2-year-old child who presents with wheezing for a few months. Again, iron deficiency. So, bacha doodhi doodh peeta hai. So, that's the typical story in India. We focus too much on milk. And when we think, okay, that history is compatible with what you are seeing on the bloods, you think it's iron deficiency anemia. You're treating iron deficiency anemia, but hang on, the child is not responding. That's the time when we need to go back and see, are we missing something? What is this asthma story going on? And these are all real cases that, we have seen. And you look at the blood picture, typically iron deficiency anemia. So, whenever there is anemia, think of these causes. क्या खून कम बन रहा है? क्या खून कहीं ज़्यादा रिस रहा है? यानी, is there a blood loss? और क्या खून ज़्यादा टूट रहा है? Is there hemolysis going on? And that is what was happening in this case. The child was actually losing blood. But where was the child losing blood? What is the story of asthma going on? The child was actually losing blood in the lungs. The child has a condition called idiopathic pulmonary hemosiderosis, where you keep losing blood in your lungs, and that is why, you are recurrently iron deficient and in an iron deficient anemic state, and you keep treating with iron. But what you really need is to prove this condition, which we did by doing a bronchoalveolar lavage, and you give them steroids and they get better, and your requirement for iron therapy goes really down. Don't forget lead poisoning, although the pipes in our homes are no more lead pipes, but this is an important condition, and we recently diagnosed a doctor with lead poisoning. She was anemic for a long time, and she was on this kind of a herbal therapy, and she actually had very high lead levels. And often we see children with hookworm infestation, which again can lead to anemia. Third case is that of a 4.5-year-old child who presents with fever, cough, there is pallor. Again, there is, the growth is very important. The growth was faltering in this child, the height was less, the weight was less, and a spleen tip was just palpable. CBC picture was very typically that of an iron deficiency anemia. The child was treated with iron, but look at the response, has finished 3 bottles, nothing is happening, no gut symptoms, nothing else, persistently anemic. So, whenever you have such a child with anemia which is not getting better, again, think of other causes. And in North India especially, celiac disease is an important cause for refractory anemia. It can be, it's typically microcytic iron deficient, but you can even have B12 folic acid deficiency. And a simple test, of TTG, you can pick this, and then you do a biopsy, and it's celiac, you give them gluten-free diet, and they are well. Sometimes we see inflammatory bowel disease, intestinal polyps, leading to anemia again and again in children. And trust me, it's not only iron therapy which is going to help them. Treating the local cause will improve their condition. This is a 2-year-old boy with history of recurrent blood transfusions and developmental delay. So, again, there are two systems involved. There is anemia, there is neurological symptoms. And, you typically see an iron deficiency picture, but what you look at, ferritin is very good. So ferritin is the most sensitive marker for iron deficiency. If a patient is unwell, the ferritin may be high because of the inflammatory process, but generally ferritin reflects your stores of iron. And in this case, we did a bone marrow and picked ringed sideroblasts. So this child has a sideroblastic anemia, and we just gave pyridoxine supplementation, and all the neurological complications in this child resolved. So again, you have to think out of the box when your child is not getting better. Alpha thalassemia, is very heavily underdiagnosed in our country. So if you have a microcytic anemia which is not getting better, you have ruled out beta thalassemia, we need to evaluate these patients for alpha thalassemia. And in Gangaram Hospital, we have got all the genetic backup to diagnose these conditions, and the treatment management is very different. This is a 4-year-old child with anemia, microcytosis. Again, lots and lots of iron therapy. Child is not getting better. There is no organomegaly. HPLC is normal. TTG is negative. Stool for occult blood is negative. Autoimmune workup is negative. Chest X-ray is also normal. So all the conditions that we talked about have been ruled out in this condition. And we found out a very rare condition. It is iron refractory iron deficiency anemia. And we did a genetic test which picked this kind of a mutation where you keep giving iron to these patients and it does not work. What happens is that they've got very high hepcidin level, and because of this high hepcidin, the iron is not able to go into the plasma, and what you need is parenteral iron therapy for these patients. Another case is interesting case. You look at a typical microcytic anemia here. The child has low MCV, high RDW, you diagnose iron deficiency, you give them iron, and the child gets better. But what happens? The hemoglobin stays around 11. You can see that the MCV is still 65. The RBC count is very high. So, in North India especially, around 4% of our population is thalassemia minor. So please don't forget this condition. If you are giving iron, the patient gets better, but the hemoglobin kind of is stuck at 10, 11, and you have microcytosis persisting, and your RBC count is high. Please think of thalassemia minor, because if two thalassemia minor get married, the baby can have thalassemia major, which will require a lifelong blood transfusion. So microcytic anemia can have a lot of DDs. And just a very quick mention about macrocytic anemias. We see these typical picture, and it's B12 deficiency. There are hypersegmented neutrophils. You see all the other findings, and it's B12 folic acid deficiency. Children may have knuckle hyperpigmentation. Marrow may confirm megaloblastic anemia. And in these cases, giving B12 folic acid supplementation is fine. And you are happy, and your patient will get better. But what if he or she does not? So I'll just show you a couple of cases. Like this patient, who came to us, has persistent macrocytosis. And you are treating this patient with B12 folic acid. He's not getting better. The child has short stature. The other cell lines are also getting down. And then we diagnose that this case has a Fanconi anemia. So these are inherited bone marrow failure syndromes where again your patient can have macrocytosis, but if your B12 folic acid is not helping these patients, please refer them to a specialist to find out the condition. And I'll not go in detail, just highlight that two other cases. One is hypothyroidism. Looks like macrocytic, you're treating macrocytic, not getting better. We did a TSH, we found that it was very high. And the last one is this little baby with macrocytic anemia, which actually had a diamond blackfen anemia. It's a pure red cell aplasia, again presents with macrocytosis, and giving B12 folic acid does not help these cases. And you can treat this and cure them by doing a stem cell transplant, which is routinely done at our center. So, Government of India is focusing on anemia and cancers more and more. These are conditions which are highly treatable. If you fix them in children, you can have very good outcome in your life. So, Gangaram Hospital, we are focusing on anemia. Regularly, we have anemia awareness and cancer awareness days. And these are just some of the pictures where our hospital and its management has supported us to create awareness for childhood cancer, to create awareness for anemia in children, and hopefully we will have Anemia Mukt Bharat very soon. Thank you.
So thank you, Manas. Very interesting cases, and I think anemia is such a common problem. So we should be careful about patients who are not responding to the routine hematinics and anemia is persisting. And one word of information that this also applies. All these cases are relevant for the adult population also. So here the mainly the physicians are. So I think differential diagnosis of anemias, as the cases shown by Manas, they're all very much relevant to the adult people as well. House is open for question.
So, ma'am, a refractory anemia is, opening a Pandora's box. These are usually complicated cases. I would not, really say one test, but I think for adults, I think doing stool for occult blood is very important, because that's an important screening test, because losing blood from gut is an important condition. When it comes to children and you have refractory anemia, a lot of genetic disorders, kidney disorders, gut disorders, those come into picture. So for iron deficiency, I would say go for serum ferritin, and peripheral smear. For B12 deficiency, I'll say, good peripheral smear, B12 folic acid level. But for refractory anemia, unfortunately, it's going to be a little difficult, and you'll have to go back into the history and do a detailed evaluation. So it's very, very important marker, ma'am, because it tells you whether your bone marrow is functioning or not. And when you give treatment, your retic count should go up. So it tells you that, your body is responding. So it's a very good investigation. So hemolytic anemias, the retic count is high. Bone marrow failures, your retic count is very low.
Just a short message that if your patient is not responding to iron after 4 to 6 weeks, there is no increase in the hemoglobin or change in the retic count, revise your diagnosis, think about other conditions and refractory anemia.
Thank you, sir.
And one for if the patient is suffering from a normal MCV anemia. So MCV is a very simple parameter in our CBC. Normal MCV anemia is always a kind of diagnostic challenge, so that needs more thorough evaluations. So we need to give a due consideration to our CBC values, especially consideration to MCVs and retic count as said before. Thank you.
Thank you.
Thank you. Thank you, Chairperson. Thank you, Dr. Manas, sir, for a wonderful, interesting session. Now moving from hematology to nephrology and talking about the pandemic that diabetes is, I would like to invite Dr. A.K. Bhalla, sir, the Honorary Secretary of Board of Management and Chairperson, Department of Nephrology, Gangaram Hospital, and Dr. Ashwini Gupta, sir, the Co-Chairperson of Department of Nephrology, Gangaram Hospital, and Dr. Tarun. I request the Chairperson to please introduce the speaker.
Thank you, Dr. Veronica. At the outset, I will like to congratulate the organizers, Dr. Manchanda, Dr. Neeraj, and others for excellent scientific program. Now we move on to the nephrology topic, that is how to slow down the progression of diabetes kidney disease. So diabetes is the commonest cause of chronic kidney disease globally, and in India also, diabetes followed by hypertension. And in diabetes, we all know that almost 30% of patients get chronic kidney disease. Chronic kidney disease incidence prevalence is 1 in 10. If you see that in general population, 1 out of 10 is having chronic kidney disease. So it is a huge problem, health problem. Epidemiologically also it is a huge problem. So lot of attempts have been done in last about 10-11 years how to slow down the progression of diabetic kidney disease. So to deliver this talk, we have Dr. Tarun Kumar. He is a consultant Department of Nephrology at Gangaram Hospital, and he is going to deliver this talk in next about 15 minutes. So, Dr. Tarun.
Good morning, all the esteemed faculty present here. First of all, I want to thank Sir Gangaram Hospital for giving me this opportunity to speak on such an important topic of how to slow down the progression of diabetic CKD. As Dr. Bhalla sir has already mentioned, according to the latest census of International Diabetes Federation in 2021, 537 million individuals are living with diabetes. Out of them, every fourth of them being type 2 diabetic, every third of them being type 1 diabetic, and half of them are having chronic kidney disease, 10% of them progressing to renal failure, and 90% of them dying of cardiovascular causes. And this is expected to rise in near future. The life expectancy is reduced by 6 years in diabetic, by 12 years in patients with cardiovascular disease, and by 16 years in patients with early diabetic kidney disease. So it all starts with the deposition of adipocytes along with the conventional risk factors like hypertension, metabolic syndrome, and diabetes, leading to inflammation, oxidative stress, vascular dysfunction, causing glomerulosclerosis, sympathetic activation, and then cardiac remodeling. So, as we can see, in a diseased diabetic glomeruli, the changes are occurring in the podocyte. There is an effacement, there is a thickening of glomerular basement membrane, there is a mesangial inflammation followed by glomerulosclerosis. So the diabetes involves all the compartments of a glomeruli. So coming to the strategies to prevent the diabetic kidney disease, it starts with early detection. Here we come at A, B, C, D, E approach. A is for detection of albuminuria, B is for BP, C is for cholesterol, D is for dysglycemia, and E is for estimation of eGFR. So in patients with type 1 diabetes, screening should be done yearly, starting 5 years after diagnosis, and in type 2 diabetes, immediately after the diagnosis. And on every visit, spot urine, albumin to creatinine ratio, and eGFR should be checked. So the KDIGO recommends a holistic approach for improving outcome in diabetes and CKD, starting right from the lifestyle management to pharmacotherapy. So the usual decline of eGFR after age of 45 is around 1 ml per minute per year. But in diabetic, this slope can be so steep that is up to 5 ml per minute per year. So our goal is to reduce the steepness of this slope and to make it to near normal as much as possible. So coming to the lifestyle management, healthy diet. The ADA recommends healthy diet containing fruits, vegetables, whole grain, avoiding saturated and trans fat, minimizing added sugar, and keeping the dietary sodium intake to less than 2.3 gram per day, which brings the concept of healthy eating plate. So in a study done in Spain, in individuals who were at high cardiovascular risk were given Mediterranean diet and controlled diet. When they followed up for 5 years, the patients who were on Mediterranean diet have reduction of primary cardiovascular events and mortality by almost 35%. So the KDIGO recommends the dietary protein intake of 0.8 gram per kg per day for stage 3 to 5 CKD. So patients who were placed on plant-based diet have a very good control of HbA1c. So the ADA also recommends 6S of physical behavior, which is not sitting for more than 30 minutes, stepping, taking at least 6,000 to 8,000 steps per day, sweating, doing at least 150 minutes of exercise per week, avoiding sarcopenia, and taking around 6 to 8 hours of good sleep. As we can see from the graph, as the number of steps have increased beyond 6,000, there is a reduction of overall mortality. So at least 6,000 to 8,000 steps should be taken daily. Now, in a look-ahead trial, when the patients were placed on intensive lifestyle control, there was a very good reduction of body weight plus stabilization of glycated hemoglobin, which resulted in overall improvement of cardiovascular outcomes. So, to prevent the smoking, we should ask, advise, and refer. We should advise the patient for behavior counseling and pharmacotherapy as and when required. The third strategy is the intensive BP control. So in a UK prospective diabetes study group trial, which included newly diagnosed patients of diabetes, the intensive BP control resulted in improvement of overall renal and cardiovascular outcome. In a meta-analysis, which included SPRINT, STEP, and ACCORD trial, the intensive BP control resulted in significant reduction of cardiovascular mortality and non-significant reduction in renal outcomes. So the KDIGO recommend that the BP should be maintained at less than 120 mmHg of systolic in patients with CKD. So herein comes the role of RAS inhibitor, which along with the good BP control provides the additional benefit through acting on angiotensin 1 receptors which are present in efferent arteriole, thereby causing vasodilatation and reducing intraglomerular hypertension. The trials which have been done earlier, like Benedict trial, Roadmap trial, IDNT and Renal trial, all have shown that beyond the BP control, the RAS inhibitors also provide benefit by reducing renal outcomes. The fourth strategy is the intensive glycemic control. So in diabetes control and complication trial, the patients who were newly diagnosed with diabetes were put on intensive therapy for sugar control, and it showed that it slowed down the progression of decline of eGFR and albuminuria. In UK PDS study, the intensive glycemic control resulted in the reduction of micro and macrovascular complication associated with diabetes. As we all know, CKD patients are more prone to hypoglycemia. Recurrent episodes of hypoglycemia may lead to stroke or arrhythmias. Hence, KDIGO recommends HbA1c target of 6.5 to 8% in patients who are not treated with dialysis and less stringent target for the patient who are on dialysis. So now coming to the pharmacotherapy, in 2015, the entire narrative changed with entry of empagliflozin. So in EMPA-REC trial, the empagliflozin showed that it causes the stabilization of the eGFR and even causes the improvement over the long-term use with reduction of cardiovascular mortality. So these fluoresceins are isolated from bark of apple tree and causes the reduction of HbA1c by 0.6%. Now how do they act? As we can see, the small triangle, blue triangles which are present in proximal convoluted tubule are the locations of SGLT2 inhibitors, which causes the absorption of the leaking glucose along with the sodium, causing the decrease in the distal delivery of sodium to these macula densa, which are shown here in brown. So it causes decrease in utilization of ATP, decrease in production of adenosine, which causes the afferent arteriolar vasodilatation, causes glomerular hyperfiltration. So SGLT2 inhibitor restore this tubuloglomerular feedback, except that they also causes the mild ketosis, which provides a fuel for the heart. They causes diuresis, causes the reduction of the BP, and hence cardiovascular mortality. So in the Credence trial in 2019, canagliflozin, it included the patients who were having moderate to severe albuminuria, and it showed that it causes the decline of the eGFR slope by almost 3 times as compared to the standard of care therapy. And it also delays the progression of the disease by almost 15 years. Similarly, the dapagliflozin and empagliflozin in respective trials have shown that it provides a benefit to the heart and kidney, both in patients with and without diabetes. Now the catch here is starting the SGLT2 inhibitors as earlier as possible. When they are being started at a higher eGFR, they delays the progression of the disease by almost 26 years, which is quite huge. So they also have adverse effect and are included in list of sick day medications. Now, in spite of giving the RAS inhibitors and SGLT2 inhibitor, still there is some residual risk. Hence, come in name of Finrenone, which is a non-steroidal mineralocorticoid receptor antagonist. In landmark trials of Fidelio DKD to study the renal outcome, Figaro DKD to study the cardiovascular outcome, and the meta-analysis combining the both, the Fidelity trial, which included the patient with stages 1 to 4 CKD and moderate to severe albuminuria, showed 23% reduction in CKD progression. How it is different from conventional steroidal MRAs? It is a bulky molecule with very high affinity for mineralocorticoid receptor with equal distribution between heart and kidney, hence less of the side effect and more of the cardiovascular benefits. Then came the dawn of new era, the GLP-1 receptor agonist. The semaglutide in SUSTAIN 6 and PIONEER 6 trials have already shown that it reduces the decline of eGFR. Then in the FLOW trial, when it was given at a dosage of 1 mg subcutaneous once a week, it showed reduction of major adverse kidney event and death from any cause. The semaglutide, even in non-CKD patient, overweight patient, when it was given at a higher doses of 2.4 mg, it showed reduction in renal outcome by 22%. So how does they act? Acting on the glomeruli, plus the receptors are also present on infiltrating cells like macrophages and T lymphocyte. Hence, it causes the reduction of release of cytokines, chemokines, thereby reducing tubulointerstitial inflammation. The next generation dual incretin agonists are coming up, which are combination of GIP and GLP-1 analogs, which increases the coverage of these GLP-1 analogs and augment glycemic and weight management. So tirzepatide already has shown in preliminary analysis that it slows down the decline of eGFR and reduces the onset of microalbuminuria. The maximum benefit to the patient can be provided when they are given in combination with each other. So that brings me to the end of this presentation. My take-home message will be a multidisciplinary strategy is needed to mitigate the cardiovascular kidney metabolic complications of diabetic kidney disease, starting right from the lifestyle modification to pharmacotherapy. These patients are at risk of hypoglycemia. SGLT2 inhibitor reduces cardiorenal risk independent of effects on glycemic and BP control. So the first line of therapy remains the metformin and SGLT2 inhibitor. The GLP analogs and non-steroidal MRA have demonstrated efficacy in reducing cardio-kidney metabolic risk. So the 4 pillars of guideline-directed medical therapy for diabetic kidney disease remains RAS inhibitor, SGLT2 inhibitor, non-steroidal MRAs, and GLP-1 analogs. Thank you.
Thank you, Dr. Tarun, for a wonderful presentation. And you have summarized in a very small time, with simplicity, that how to slow down the progression of diabetic kidney disease. As Dr. Bhalla has mentioned, that 1 out of 10 people are suffering from any stage of CKD in India or even worldwide. And this is the 5th most common cause of death all over the world. And every year, 2.5 to 2.7 lakh new patients of end-stage renal disease requiring renal replacement therapy are diagnosed, and almost 30 to 40% of them are due to diabetes. So, and if we see the economic burden, government under the mission of National Health Mission, Pradhan Mantri Dialysis Program for underprivileged people is spending almost 4.5 thousand crores of rupees on the dialysis for underprivileged people. And you can see that this is such a huge economic burden on the government. And as doctors, we have to see that this burden needs to be decreased. So this can be done by first, primary prevention, second, early detection, and third is slowing down the progression. And early detection, all of you are the pillars of medical health care, and everybody is a nephrologist actually. All diabetic patients should be assessed, or hypertensive patients should be assessed for microproteinuria. That is the earliest sign of renal damage. And if patient is picked up at the microproteinuria stage, you can even reverse the process with all these medicines which Dr. Tarun has mentioned. And I will just again mention that under the dynamic vision of Dr. A.K. Bhalla, he has made a full draft of Indian Society of Preventive Nephrology, because our aim will be to prevent the renal disease or slow down the progression of renal disease. And we are making it, and we will get back to you all so that you should start working in that manner so that this burden is decreased. And any questions from the house?
Can we have 2 burning questions?
For adequate BP control in diabetics with hypertension, ARBs are mostly preferred. Is there any difference in the different ARBs we are having in the market, like Losartan, Telmisartan, or is it the same?
Actually, in the studies which are being done, which are done for AAC inhibitors and ARB, they have shown the similar outcome. But as we can see for the BP control, it is being seen that ARBs have been slightly better than ACE inhibitors, plus less of the side effects which are seen with ARBs as compared to ACE inhibitor.
You see, all are similar. Losartan is more helpful for even treating uric acid also. So otherwise, this ARB is better than ACE inhibitors, and all ARBs are similar. Because he has mentioned about various trials. They are with valsartan, losartan, telmisartan. So all are similar.
Yes, sir, they definitely help. Yes, sir. Even the new trials that are coming up with drugs like ACE inhibitors, ARB plus SGLT2 inhibitor, like in case of the DAPA CKD trial, about 67% population was CKD, but rest of the population was even non-diabetic CKD was also there. They have a predominant population of the glomerular disease involving IgA nephropathy, and using the dapagliflozin has shown that it reduces the proteinuria even in non-diabetic CKD, plus it also delays the progression of the disease. So these new drugs which are coming up, even in the KDIGO guidelines, it has been provided that if the patient is not diabetic, then ACE inhibitors, ARB and SGLT2 inhibitor, if he is having significant proteinuria, then they should be advised for the patient. They have.
This will be the last question in the interest of
yes,
time.
ma'am. They have the definitive role in glomerular disease. They are being considered as the first line of the therapy in treatment of FSGS and other glomerular disease in IgA nephropathy. They have been advocated.
So with this, we close this session. Thank you, Dr. Tarun, for a wonderful presentation.
Thank you, Chairperson. Let's have a huge round of applause, please. Now, we move on to an interesting topic in vitro fertilization, single embryo transfer in IVF, improving safety without compromising success. To chair the session, I'd like to invite Dr. Shweta Mittal, ma'am, who is the co-director of IVF at Gangaram Hospital, and Dr. Neeti Tiwari, who's the senior consultant, and Dr. Gaurav Majumdar to please come to the stage. Ma'am, to please introduce the topic.
Good morning, everyone. Such keen august gathering with us, and it's a complete pleasure for us to introduce the Chief Embryologist of Center of IVF and Human Reproduction, Dr. Gaurav Majumdar, and he's also the Vice President of a very prestigious society of India called Association of Clinical Embryologists, ACE. With a vast experience of 25 years in the field of embryology, I can assertively say that he is the pillar in our lab to bring the highest pregnancy rates in our country. And we feel very proud that when we work in Center of IVF under the leadership of the embryology team led by Dr. Gaurav Majumdar. So Gaurav, the forum is all yours, and he's going to talk about that how even a single embryo transfer can bring highest level of success rate.
Thank you very much for the kind words and this opportunity, but I think we need to change the, it's the wrong lecture. I think it's the one, it's the one after this. Can we do a slideshow for this? Right. So why this topic of single embryo transfer in IVF, where we are trying to improve safety without compromising success? Because now IVF has more or less become a household name where everyone has been touched in some way or the other, where some family member or friend has undergone IVF. And when we think of IVF, one common notion is that IVF leads to twins and triplets. And that's what patients say, and that's what, everyone we come across say that, कि IVF से तो सिर्फ twins or triplets होते हैं. So, all right, now this has to move. So we know that the primary goal of any IVF cycle is to have a healthy baby, right? That is what we all strive for. But such are the market pressures in today's day and age that we also understand that everybody is gunning for the maximum possible success rates. And one way of doing so is that IVF centers, they tend to transfer multiple embryos, right, in order to boost their chances of success. But the flip side of doing this is that almost 40% of the transfers will result in multiple pregnancies, or in twins or triplets. Now, in the Indian context, this might seem like a lucrative deal, that you're getting 2 or 3 in the price of one, and you're completing your family in one shot. However, in the bargain, what we did not sign up for are the complications. And there are a huge list of complications, both for the babies, where there's a lot of premature delivery with low birth weights and a much higher risk of infant mortality. Admission to NICU is a very, very common thing with twins and triplets. And not just the babies, the mothers are at a heightened risk of gestational diabetes, preterm labor, and a lot of placental and postpartum hemorrhage abnormalities. So this is a choice. Now which becomes, after looking at the complications involved, we see that obviously one has to strive for safety in a single pregnancy. But does that mean that we need to compromise on our chances of a pregnancy? Well, this is a simple choice determined by the number of embryos that we transfer in the IVF lab, and can be achieved by transferring single embryos. However, world over, electively transferring single embryo in an IVF cycle is big deal. And this is because all clinicians across the board are very worried that transferring one embryo will lower the chance of pregnancy. And nobody wants to compromise their success. Secondly, it's also a task to select single embryo from within a cohort of multiple embryos, because one always wants to strive for a faster time to pregnancy. Also means that because nowadays we tend to freeze embryos and transfer them in non-stimulated cycles, so your freezing program has to be absolutely top class, ensuring 100% survival rates. Not just that, most patients will come in with a preference of twins, right? And that basically stems from a lack of knowledge about risks and complications associated with multiple pregnancies. And then there's always a risk of patient dropout if there is a failure. So it's important to know first, to address this question, that does really transfer of a single embryo lower the chance of pregnancy? And so here I present to you some of our data from our SDRH laboratory, where I'd like to highlight that when we transferred single embryos on day 5, known as blastocysts, we ended up with a live birth rate of 46%. And in contrast to this, when 2 embryos were transferred, there was only a marginal increase in the live birth rate from 46% to 49%. But in contrast, what happened to the multiples was that with single embryo transfer, we basically had only a less than 1% chance of, these are all monochromatic twins, the MCDAs. But when we transferred 2 embryos, the multiple live birth rate went up to 33%. Now a bit about these babies that were born, and there were about 337 babies from that year, where the mean birth rate was about 2.8 kgs, Whereas you see that the 46 children that were born as twins, they had a much lower mean birth weight of about 2.1 kgs. The mean gestational age for the singleton babies was 38 weeks, whereas all the twins were delivered before 37 weeks, almost comprising 90% of all deliveries. So this is what we are talking about, and many of these children need neonatal care in the ICU. So another challenge now with single embryo transfer is selection of embryos, because basically embryos are there are only very nuanced differences between different types of embryos. And with single embryo transfer, what we've been able to achieve is assign live birth rates with these different nuances of embryos so that we can accurately select embryos and at the same time, we have embryos where we know which will not result in a very high pregnancy rate. So those are the cases where we can counsel the patient to get 2 embryos transferred without compromising the chance of success. So it's very important for us to recognize which embryos make a good candidate for single embryo transfer, because we also are striving for the highest possibility of success. So yes, elective single embryo transfer is a reality, and it works, and one can achieve very high pregnancy rates without having to end up with twins and triplets and all the associated complications. But the only prerequisite to be able to transfer single embryos for IVF lab is a very high proficiency IVF lab. And we are proud to say that more than 90% of all our transfers are now electively single embryo transfers, and we've been able to achieve a clinical pregnancy rate of about 55% and a live birth rate of about 45% per embryo transfer. And it also gives us one advantage, that when we have multiple embryos, rather than transferring them all together, we transfer them sequentially, individually. So that gives us more attempts. So you can have more embryo transfers out of one egg pickup, and that's the only way to improve the cumulative success that can be derived out of an IVF cycle. So this is the best way to optimize IVF, is to transfer single embryos in multiple attempts. And this is a gradual process. It has taken many years for us to achieve this. It requires a lot of aligning the physicians, the staff with this whole concept of transferring embryos individually. Then obviously it requires a lot of patient counseling, and the crux of the whole problem is to improve embryo culture, improve the nuances of embryo selection, optimizing your freezing program, because that has to be rock solid for you to be able to transfer embryos individually, and a huge amount of data analysis that will allow you to select embryos appropriately. Now, we were not always doing single embryo transfer. Back in 2015, you see that only 33% of our transfers were single embryo, but then we as a unit took this conscious decision that we will improve our systems, we will work on the IVF laboratory, and we will not end up with twins and triplets, because our clinicians were having a nightmare, handling all these cases. So you see in 2016, we gradually went up to 59%, and then 61%, then 70%, and now gradually we have now reached a stage where perhaps we are the only center in the entire country which is performing 90% of all our embryo transfers are single embryo transfers. And what this has resulted in is that from 2015, gradually our implantation rates have improved, and now they are around 55% per embryo. And we are proud to say that our multiple pregnancy rate is now below 5%, which is a huge feat to achieve in the field of IVF. So here then I'd like to conclude saying that transferring 2 or 3 embryos, it leads to a huge number of multiple pregnancies and the associated comorbidities and problems later for the child as well as the mother. And transferring more embryos can never compensate for poor embryo quality or poor laboratory. So you know that any lab which is transferring multiple embryos, they definitely have poorer implantation rates, and any laboratory which is actually performing single embryo transfers is a top-class laboratory. And finally, elective single embryo transfer, it gives you a chance to perform multiple frozen embryo transfers and therefore resulting in a much higher cumulative chance of achieving a live birth. Thank you for your attention and greetings from our team at the IVF laboratory at Sir Gangaram Hospital.
Thank you, Gaurav. Wonderful talk. And you have been able to drive your point home that IVF is not equivalent to twins, which was a notion long time back. But a lot of counseling goes into that because still patients have this, thought in mind, especially when they come from other centers where 2 or 3 embryos were being transferred. The doctor, will you be able to give us the same result when you will transfer 1 embryo? So a lot of counseling goes, but we always show them our data and we tell them about the horror stories of what can happen wrong when you transfer 2 or 3 embryos. So they are able to take a conscious decision with us. Thank you so much.
Thank you so much, Dr. Gaurav and respected chairperson. Any quick question we have? Thank you so much. So before we move on to the next session, we have the privilege of having between us Dr. Rajiv Sood. Sir is a Vice Chancellor, Punjab Health University. Sir would like to speak a few words to the
Thank you. I acknowledge the presence of all the dignitaries, my teacher, Dr. P.S. Gupta, Dr. S.C.L. Gupta, and Balla, my colleague in Delhi Medical Council. I bring greetings from Baba Farid University, that is the State Health University of Punjab, and I am Vice Chancellor coming back to Delhi in June. And I was earlier in, you all know, in RML Hospital for 40 years. Dean there. I'm also, incidentally, you all are here, so I must share that I'm contesting for the President of Delhi Medical Association, and your all wishes and cooperation is required, your friends and colleagues, and have a great conference, and sorry for interrupting in between. 8th February is the voting, that is the Sunday. Dr. S.C.L. Gupta, please. When venues are different, depending on the Karol Bagh venue is different. That is the Delhi Medical Association Hall for South. It is the Lajpat Bhavan. For you will get the menus. We will communicate, but need your support and vote also. Thank you very much. And I am Molanian otherwise, but in Amsonian also, and Lohian also, and Nam Punjabi also. So all the universities I have served, Dr. S.L. Gupta.
सॉरी आज सुबह इस समय आपके इसमें सीएमई में डिस्टर्ब किया, उसके लिए क्षमा चाहते हैं, पर एक अच्छे व्यक्ति को चुनने के लिए आपकी आवाज़ दिल्ली मेडिकल एसोसिएशन से दिल्ली सरकार तक जाने के लिए एक अच्छा व्यक्ति का चुनना ज़रूरी है। और आपके सामने एक एक्सपीरियंस्ड पर्सन है जिन्होंने लीडरशिप में अपने आप को लीड किया है। आपको लीड करने के लिए डॉक्टर राजीव सूद फॉर द प्रेसिडेंट, डॉक्टर जीपीएस गिरेवाल पास्ट प्रेसिडेंट ऑफ दिल्ली मेडिकल एसोसिएशन फॉर वाइस प्रेसिडेंट, एंड डॉक्टर दीपमाला लालचंदानी फॉर द अनदर वाइस प्रेसिडेंट. So is my request on 8th of February morning 9 a.m. to 5 p.m. in the respective centers. Please vote and support and bless Dr. Rajiv Sood. Thank you very much. Thank you, sir.
Sorry for interruption. Thank you.
Moving on, next we have an exciting session on pediatric cardiology, and for that we'd like to invite our respected chairpersons, the power couple, Dr. Reena Joshi ma'am and Dr. Raja Joshi sir. Reena ma'am is a senior anesthetist and sir is a senior pediatric cardiosurgeon at Gangaram Hospital. And Dr. Siddharth, please. Respect, please.
Very good afternoon to all of you. I first would like to clarify this topic deals with anybody with a bad lung and a support that we can offer to patients who have a bad lung, pediatric, adolescent or adult. Anybody can have ARDS, and that ARDS goes through an initial phase of stabilization, but when that fails, becomes the topic of this, this deliberation. I take the pleasure of introducing Dr. Siddharth, who is an accomplished cardiac surgeon trained at SGPGI Lucknow. Then he went on to train at the famous Great Ormond Street Hospital, and he brings with him a myriad of experience of extracorporeal circulation for pediatrics, adolescents, and whatever age you can offer. So fire away, please, Dr. Siddharth.
Thank you, sir. Warm good afternoon, I guess. So, how do I move this? So, okay, just to introduce what is acute respiratory distress syndrome. It is a culmination of a lot of causes which affect the lung, and the list of causes are actually very innumerable here. So fundamentally what it causes is damage to the lung. It is an acute diffuse parenchymal lung failure where there is poor oxygenation and non-compliant and stiff lungs, which are very difficult to ventilate. So depending upon the degree of severity of impairment in oxygenation, it has been classified into mild, moderate, and severe. Our interest more lies with the severe variety where extracorporeal circulation is needed. So when you look at the severe ARDS progression, so I need you to focus on the green line here. So in the first 5 days, there is almost a 40% mortality even in hospitalized intensive care patients. So once the diagnosis of severe ARDS is made, we are always running against time, and it is a race for survival. So what is the traditional management? It is usually, as it should be, the treatment of the cause. And because the problem is in impairment in systemic oxygen delivery, we try to maintain it as much as possible. And the fundamental goal is to protect the lung as much as possible. So the general goals was to prevent volutrauma, where you restrict the tidal volume given to the patient, and also at what pressure it has been given. But sometimes this doesn't always work. So when you see at the diseased lungs, it is not always homogeneous. There are some regions which are more affected, some regions which are less affected. So the lungs which are less affected usually take in more volume and get the beating. So eventually they become a punching bag. So let us look at some of the examples. We have a 3-year-old child, 3-year-old child with a very acute history of fever. And again, she presented to the hospital with a left lung patch, as we can see here. Within 12 hours, the patch has actually involved the whole of the left lung and requiring mechanical ventilation. And once ventilation, there is no limit. We keep increasing the pressures, and eventually the lung bursts. And in the last X-ray, you can see there is bilateral pneumothorax requiring bilateral chest drain insertion. There is extensive subcutaneous emphysema, and the child is no longer being able to ventilate it. So if you sorry for the poor quality of the image here. So when we look at the ventilator pressures, the peak pressures are already 42, which is already supraphysiological. We have prone the child, and everything has been done, and the cycle still continues. So how to break it? So this is where ECMO comes into picture. So ECMO basically has got two configurations. ECMO fundamentally what it does is increases the oxygen level in the blood. If you take the blood from the venous system and return it back into the venous system, it becomes a venous ECMO. And if you do the same for an arterial system, it becomes a veno-arterial ECMO. The advantage of a veno-arterial ECMO is you can support the heart and the lung at the same time. For a veno-venous ECMO, it is most oftenly preserved for a respiratory function abnormality. So what are the indications for an ECMO? So obviously when the conventional therapy is failing, and although I like to iterate that there is no single number or criteria which helps in making a clinical decision, we have a lot of indices where we use oxygen index and PF ratio, but it is more how rapid the child progresses or the patient progresses and how quickly we are not able to gain the control on the disease pathology. That is where the indication for ECMO comes in. So for this child, what we did do? We initiated the venous ECMO in the bedside. Nowadays, we have access to the special kind of cannula. So if you if we go back to the previous image here, on a venous ECMO, there were two veins which were used, one for retrieving the blood and one for giving the blood. So with the advent of technology, we have a single cannula it is a dual lumen cannula where with the single access we can take in blood, and in the same access we can give back blood into the heart. So we have initiated ECMO on this child in the bedside on an emergency basis, and we were able to rest the lungs. We were able to ventilate the lungs in physiological pressures. So the lung gradually recovered, and eventually the child went back to being as playful as before. Again, a case 2 with this now a 6-month-old child, again a very similar X-ray where both the lungs are blown out with subcutaneous emphysema and bilateral pneumothorax. Again, we have initiated a bedside venous ECMO, and the child gradually became better. A different age group. This is a different scenario where a 24-year-old, he was a weightlifter. He underwent post-left pneumonectomy for hemopsis. But the other lung had got ARDS because of the residual glue. And his lung became worse, and eventually we could not ventilate. Again, we initiated ECMO on him, and he also became better. So nowadays we have concept of ECMO retrieval. So some children are too sick to be shifted to any peripheral, to many main ICUs. So this is one child where the child was sick in Ludhiana. The whole team went in there. We initiated ECMO in the bedside of the DMC Ludhiana ICU, and we road transported the child from Ludhiana to Delhi overnight. So there are no pediatric trials as such, but ECMO for ARDS has been evaluated in adult population, and basically the data emphasizes what we already know. There is significant mortality reduction at patients who go on ECMO, and sooner the ECMO is initiated, the better are the outcomes. So what are our experience? Even though we started initially doing ECMO for cardiac centers like most of the people do, our first respiratory case happened in 2016. Since then, we have supported 29 children on ECMO for respiratory physiology, for pathology, and our youngest survivor for ECMO was a 1-day-old child. So when you look at the outcomes for ARDS, for 21 patients with ARDS, out of them 76% survivors were there, otherwise who wouldn't have made it. So to conclude, ARDS again is of the severe variety, has got a rapid progression with a very high mortality, and early intervention actually improves their outcomes. And ECMO is definitely the last line of defense, but it's not a last-ditch effort, and timing is everything in its initiation. And nowadays, transport on ECMO is also feasible, and thank you.
Well said, Dr. Siddhartha. So the important thing to emphasize is what you said is the earlier we think about initiation of ECMO, the better are the results. Because most of the units or most of the clinicians, they think about ECMO or they introduce the topic of ECMO to parents when things are actually slipping away from their hands and lung has actually taken the brunt of it. So I think we all need to emphasize on the timing of ECMO, it seems. Thank you.
I think one message that definitely we wish to transfer from the podium to the audience is that every hospital which deals with sick patients having ARDS which can rapidly worsen should have a ECMO collaboration with a setup which does ECMO on a regular basis. Once you start communication at the right time, very important time gets saved. And time is of essence when you're saving lives in such situations. That's very important to have an ECMO center which is your pal. It should be your friend. You should be able to communicate with that very easily so that transfers and ECMO initiations can happen sooner than later. That should save life. Thank you.
Any one burning question?
Just be fired there, sir.
So, yes, I'll take that fiery question. Cost is always a brunt with ECMO. I think initiation costs are somewhere in the tune of 5 to 7 lakhs. And maintaining cost is maybe if any ICU has got a running cost of 50,000, the ECMO added on cost for maintenance will be by 20,000 rupees. So you initiate by adding 5 lakh, 7 lakh rupees roughly depending on whether you require a VA ECMO or a VB ECMO. And maintaining cost goes up in your ICU by 20,000 rupees per day. So that most of the ECMOs that we have run are between 15 to 20 lakhs total bill. 15 to 20 lakhs in a patient who is most likely to die. And if we can save 76% of them, I think that's an effort worth making.
Thank you, respected Chairperson. Thank you, Dr. Siddharth. Now we move on to the session on genetics, and to chair it, it is my pleasure to invite the head of the Department of Medical Genetics at Sir Gangaram Hospital, Dr. Ratna Duapuri ma'am, and the co-director of IVF at Gangaram Hospital, Dr. Shweta Mittal ma'am.
Continuing with our academics at the Prime, now we would be hearing, I think, yet another one of the most important departments. I don't think there is any discipline where we don't need some kind of an opinion or consultation from the genetics department. We'll be hearing two speakers, Dr. Veronica Arora, who's the consultant at the Center of Genetics, and Dr. Swasti Pal, who is the associate consultant at Center of Genetics at Sir Gangaram Hospital. We are very eagerly waiting to hear very important take-home messages from you.
Thank you, ma'am. Good afternoon, everyone. You've all been a wonderful audience, and it has been a great pleasure for me to be emceeing this audience today. So we'd talk about the top 10 red flags in the clinic, in genetics clinic. So the evolution of genetic has been immense. 150 years back, when Gregor Mendel sat in a monastery counting peas, for us to today coming and seeing that we can change genetics and provide the children with therapies we never imagined before. So it is our responsibility to pick up genetic disorders at the earliest, because picking them up can actually immensely transform their lives. So genetic disorders do lay hidden in plain sight. They're not recognized easily, and not only in the genetic clinic. You see people moving around with cleft lip and palate, that is of a genetic origin. You see minor defects in the heart, like a ventricular septal defect, they may be of genetic origin, and underlying may be a genetic defect which can actually in later life have major outcomes and major problems in the child. So we need to identify accurately to prevent these disorders to not occur in their family later. So the common consultations in the genetic clinic that we see are in the obstetrics background, in the pediatric clinic, and also in the adult clinic, virtually covering all the aspects. So I'll be talking about the obstetric indications of genetic testing, and my colleague Dr. Swasti will take over the other two. So unexplained infertility, unexplained recurrent pregnancy losses, malformation, and family history of any genetic disorder. The one most crucial thing in picking up a genetic disorder is just that one sentence you ask your patient: is there any history of similar affected family member, be it autism, deafness, blindness, cancer, anything, you think genetic. So let's talk about infertility. We know that the commonest cause of primary amenorrhea in girls is Turner syndrome. That is a cause for infertility. It's easy to pick up a small test called karyotype, and we can pick it up. Klinefelter syndrome is a cause of male infertility. As we can see here, there is an extra X chromosome which causes some sort of learning difficulty and primarily infertility in males. Picking this up gives answers to the family, also helps them in looking for other reproductive options and preventing the same disorder in other members of the family. The other disorder is definitely Turner syndrome. Turner syndrome girls do well. It is not a stigma. We don't identify genetic disorders to give a label, but really as a starting point to treatment, to management, and to help the family. So infertility in males can also be caused by other disorders like Y chromosomal microdeletion, which we can order a different test also. So for infertile males, we just don't stick to saying that you go and go ahead with IVF. IVF may not work also if they are suffering with these conditions. Another important disorder for infertility is cystic fibrosis. Patients who have mutation in the CFTR genes and whose offspring may have severe cystic fibrosis with recurrent infections are also infertile. Recurrent pregnancy loss is a topic really close to my heart, which causes women to have recurrent abortions. They fail to have a healthy baby. The people become exhausted, tired of recurrently losing pregnancies, and after doing the obstetric workup, routine obstetric workup, still there is no help, but we give them hope by genetic testing, finding a cause, and thus therefore helping them in finding out that what went wrong and how we can really help them. We have a protocol in our hospital, which ma'am also will later talk about. We give certain treatments like IVIG intralipid, which helps in these pregnancies. Then we come on to malformations. We have women who come to us with fetal malformations, be it malformations in the brain, be it malformations in the kidneys, polycystic kidney diseases, or ventricular septal defect, tetralogy of Fallot. Any defect in the fetus, any malformation in the fetus deserves a genetic workup, so that maybe not in this pregnancy, in next pregnancy, we can give the fetus a healthy outcome. Another important aspect is skeletal malformations, that is abnormalities of bone, severe short stature, severe tall stature. All of these are genetic disorders, and now we have more and more clinical trials and treatments for disorders of short stature, including achondroplasia. So the diagnosis of genetic abnormalities and fetal malformation at SGRH, the overall diagnostic yield of tests that we have performed was 5.4% by a test, the conventional test karyotyping, and approximately 10% by a test chromosomal microarray, both of which we perform in-house. As I mentioned, positive family history is the most important criteria to diagnose and pick up a genetic disorder. This is something known as a pedigree. That is, it gives us a graphical representation of all affected family members. So this couple came to us that there is a person in our family who has a genetic disorder called cystic fibrosis, and there are multiple deaths in the family. So that means this was a consultation for a positive family history. We need to do the genetic testing of the person with the disorder, followed by later we can test the the fetus. So in a genetic pedigree, it's always important to test the person with the genetic disorder. So now I'd like to give Dr. Swasti to present about adults.
So coming to the clinics for adults, it doesn't have to be limited to any one system. It can be across all the systems, and the biggest red flags are when seemingly non-genetic conditions like Parkinsonism, cancer, etc. happen in young onset individuals, happen in multiple family members, when the cause is unexplained, like kidney failure, liver failure, heart disease, sudden death, and familial cases such as hypercholesterolemia all give a hint that this could be genetic. So in a family where a member has adenocarcinoma colon, his father also had the same, and his aunt had endometrial. Looks similar yet different, and this family actually is suffering from Lynch syndrome. The importance is to identify other at-risk family members as well, where we found that his own sister was carrying the same mutation, and we know for cancer, better outcomes only come out of early screening and early detection. Coming to pediatrics, which is perhaps the most closely linked with genetics, as majority of the genetic disorders do present early in life. Going through the red flags quickly, so we've already seen that birth defects may present in the fetal life itself. Sometimes they are not caught and may be present at birth, and they are treated as well as diagnosed with genetic testing. Abnormalities of growth can include short stature, overgrowth, as well as obesity, all of which have a genetic background.
Most importantly, developmental delay, intellectual disability, autism. It is important to consult a geneticist early, as many underlying genetic causes get missed when the symptoms are not very apparent to the common physician, and to understand the cause and to get an early diagnosis and management as well as to prevent recurrence. Some dysmorphic cases can be easily picked up. However, some subtle ones do require a trained eye to catch these disorders. Finally, unexplained encephalopathy, recurrent seizures, recurrent hospitalizations, which may be due to infections or just unexplained collapse, cerebral palsy, which does not have a documented history of birth asphyxia, and previous unexplained infant deaths, all can be due to genetic disorders. The most important red flag in any clinic is a positive family history, whether it's of a similar disorder or a different disorder. One must always think of a genetic disorder. So this is an important pedigree where the family actually came when the man was 76 years old with tremors and ataxia. And the clue to finding the diagnosis was not just his condition, but the family, where his daughter had premature ovarian failure and his cousins had intellectual disability. While they all look different, we know that these conditions are actually linked by an X chromosome inherited condition called Fragile X syndrome and related disorders. And this X chromosome, which is carrying the mutation, can actually be traced across all the affected individuals, and they all come from the same background mutation. The next biggest red flag is consanguinity, where we have a family where they had one child with congenital adrenal hyperplasia, took all the precautions, got the test done, but they came to us with their second child, who they thought is going to be a healthy child. However, he had completely different symptoms. The boy developed seizures, developmental delay, and the reason for two different disorders was that the parents were consanguineous and at risk for more than just one disorder. So wrapping up, the genetic testing is not one test, but a big spectrum of tests. All of these technologies and tests are available at Sir Gangaram Hospital, and depending on the disorder you want to catch, we do these tests. The center at Sir Gangaram Hospital was established in 1997, one of the oldest genetic centers. We aid all the diagnoses as well as the newer treatments are offered here, as well as prenatal diagnosis. And before we end the talk, we have a short poll. If everybody can please use their poll meters.
We look forward to active participation, and I won't talk after this. The talk is all here in the polls. So go back to the question.
The question, it's not being displayed.
Oh.
The presentation, can you please?
Yeah, this is the first question.
Okay, so the first question is, which parent determines the biological sex of the baby? The mother, the father, both equally, or neither? I can hear the answers coming from the first row.
It's the dominating society in our country. Okay, next.
So the answer to this is actually the father. So everybody who thinks that the mother determines the sex of the baby is not correct. The father decides. The mother only has the X chromosome to give. The father decides. The next question, both parents' blood group is A positive. What can be the blood group of their child? B positive, AB positive, O positive, or none of the above?
Excellent.
So while this actually looks like neither could be the right option, it is true.
1 second. You can all vote. We have a timer.
Yeah. Oh, so everybody's got the right one. Yay. It is O positive. Many times parents actually come with such simple queries to the genetic clinic that our blood group is different, our child's blood group is different. Is this not my child? There is no need to go to such extremes. It is your child. You just need a little genetic knowledge. And last, when will you suspect a genetic disorder? Multiple family members with cancer, 2 siblings with congenital heart defect, if there is a child with congenital deafness, or all of the above.
Please vote, please vote.
So everybody was listening, that means.
Yeah. So I think just to cover up in time, thank you so much for being such an attentive audience.
Well done, congratulations.
In the last decade, genetics has gone through the whole life cycle, and that's what our 2 young bright stars have presented. Thank you so much.
Thank you, ma'am. Thank you for a really interesting session. Now, without further ado, we will move on to the next session on joint replacement. And for that, I'd like to invite our chairpersons, Dr. Sudhil Kalhan sir, who's the head of the Department of Paediatric Surgery, Gangaram Hospital, and Dr. Anant Tiwari sir, who's heading the joint replacement at Sir Gangaram Hospital, and Dr. Gagan Chadha sir, who's the senior consultant in orthopedics at Gangaram Hospital. So Dr. Nipun Rana is the vice chairperson joint replacement at Gangaram Hospital, and he'd be talking on robotics and AI in joint replacement. Over to you, sir.
A very good afternoon to everyone. I'm Dr. Nipun, so I'll try to make this as short as possible. Robotics and AI. So robotics is nothing but a machine. I'll be talking on machines, and AI is nothing but the brain behind that machine, right? So conventional technique of doing a TKR is a technique. It is the gold standard of how we perform a total knee replacement, and robotics is a new thing in the market, and it's been a decade now, but it has a future ahead. So conventional is an analog thing where it depends on a lot of conviction, anticipation, and some gut feeling by the surgeon while he's doing the surgery. Well, robotics provides us digital numbers, scoring system, by which we can always fall upon something which helps us know that our surgery is going right or no. But it is a combination and amalgamation of a human and the robot which will bring about the change and brings about superpowers of monotony, of doing the surgery in a similar fashion all the time, in a personalized way for the patient, and having a singular or a reproducible result for everyone. It is an enhancer, enabler, and these are various kinds of adjectives which can be used for a robot. So surgery consists of doing a soft tissue release, taking bone cuts, the second part, and finally putting in the implant. But what robot does is only 33.3% of the entire surgery, that is only taking the bone cuts. Okay, so one should be clear about that. It is conventional surgery is performed with the help of jigs, and the surgeon holds the cutting saw in his hand, and the hand control over the saw by the surgeon is the deciding factor on how the cuts are going to be. So this is the saw, the power system, which is used by the surgeons in a conventional surgery. So what is robot? A robot is basically a power system. It's a special form of power system which comes in a form of a big machine. One is a computer, the other is a machine. If you see on the right figure, and have a pointer, so the right figure, at the end of the arm, there is a cutting saw attached to it. The cutting saw takes up all the information from the computer, which is fed by the surgeon, by the doctor, pre-operatively, intraoperatively, and it follows the command of the surgeon. Coming directly to what we are here for. So what does the literature say? The robot is not providing any good results in longevity or long-term clinical functional outcome. It is only for the early functional scores, for early results of the surgery. That is the early satisfaction, and it does help in reduction of some of the complications, so it has a safety margin attached to it. But definitely, having said that, the potential of reducing the complication, the potential of providing a good satisfaction does provide a potential for improvement in longevity and clinical outcome. So take home is that this surgery will provide us with a safe and a satisfactory surgery, especially in the early phase of the surgery. The patient has less pain, a better rehab, and safety margin, which we'll see further. So two major surgical offers which the robot will provide is, it is a predictive tool, it is a precision tool. It predicts the surgery even before we are executing the cuts, we are executing the releases. It tells us how to put the implant, where to put the implant, and what is the alignment and balance. Let us not go in details, but if we do conventionally, measuring the size of the implant, only 50% of the time, as per literature, we can actually know the size of the implant with the help of a robot. Pre-operatively, even without touching the patient, we know the size of the implant, we know any defects are there in the tibia, any major osteophytes or any bone problem with the impingement of the implant. So this is how the surgery goes about. There's multiple points of registration which are there over the femur, which we have to make. At the end of putting all these various points, we are able to, on multiple points over tibia and femur. Finally, we get to see the virtual image of the femur and the tibia with the implanted bone on the screen, with which we can play about even before touching the patient, before taking the cuts in. It has a predictive value and alignment. I think we'll skip these slides. So the whole idea of doing a surgery is that there's a deformed knee, and we are trying to correct the deformity by taking some bone cuts and doing some soft tissue releases. So such a fatty patient, having the analysis of the landmarks like hip joint or the ankle joint is a difficult task. So these instruments, a robotic definitely has a role in such patients. Again, prediction of the accuracy and the balance is that is how it happens in once we have the bone model onto us. Right now, we are not taking any cuts, and we are just balancing the joint with the help of the robot. So by mere placing the implant in different scenarios, we are able to balance the joint and give a better results. Finally, this is how the bone cut happens. The power system aligns itself in 3 dimensions in a very fixed fashion, and one is able to take cuts very accurately. So the ultimate indication of this robotic TKR is patient desire, I would feel. There are certain 3 common indications which are specific indication for robotics. So the final take home is that what are we offering to the patient is singularity and secularity. Singularity for the purpose of safety of the patient, that this tool provides, all the time provides the similar results, consistent, reproducible results. Secularity in the sense that every time we have to choose a surgeon, like who is an experienced surgeon among us, there's no question because every time the robot behaves in the same way. Every time we do a less superficial release, a minimal amount of intramedullary invasion, less bleeding, less pain. So the early satisfaction is always there. But it's not the ultimate game changer. I would say the patient selection, the timing of surgery, expectation of the patients, and a well-performed total knee replacement, whether robotically or conventionally, is important. And the post-operative rehabilitation is the key whole. Thank you for everyone. So the most of the complications do occur when you don't understand this fact that you don't know what you don't know. You should understand this fact. Thank you.
Thank you, Nipun. I think you have come across with a very important point that robo is a tool which is available to the surgeon. And the experience of the surgeon is paramount. Because as they say, a fool with a tool is still a fool.
Yes, sir.
So I think that is very, very important message that you have said, that the robot is just a tool which is available to improve your precision. But ultimately, the experience of the surgeon is the most important factor.
Sure.
And in a country like ours, where cost is a very important factor, robots should also be used with some amount of wisdom. Now today, you will find that people are using robot for almost everything and increasing the cost of surgery, which I think a lot of wisdom will be required for that.
That's true.
If anybody from the hall wants to ask Nipun any questions about robotic surgery for the knee, he would be happy to address that.
Pricing.
Dr. P.S. Gupta is asking the price.
There's always a cost to it. So for every surgery, we have to add up for the disposables and whatever instruments are being used. So it's nearly around 50,000 extra for every knee surgery we do.
So as you've said, when the deformity is more, where the precision is really required more, probably those must be the cases where the help of a robo should be used. But do you think robo should be used for even straightforward knee replacements?
It is not really mandatory for those cases, but I have seen patients who come to us, they are really a theme that they have this knowledge from all surrounding patients and their relatives that they want the surgery for all the cases. But it is definitely meant for the severe deformity cases when there are implants within the bones, the marrow, a nail or a plate, and in severe extra-articular deformity. These are the only 3 major indications.
So definitely it should be a part of the armamentarium of the tools available to a good surgeon. Thank you so much, Nipun. Thank you so much.
Thank you.
Thank you, Nipun. So we'll quickly move on to the debate which we have here, an exciting debate on weight loss medications, a miracle breakthrough or misguided shortcut. May I call upon the people for this debate, Dr. Ajay Agarwal, Dr. Setu Gupta, Dr. Sudhir Gulani is already sitting, and Mrs. Vandana, and it will be moderated by Dr. Anil Roda. Kindly come. I think we'll have one by one presentation by all of them and then a final takeaway by Dr. Arora. So, to start with, may I please invite Dr. Ajay Agarwal without wasting any time so that we can have quickly what it is there in today's scenario for weight loss management.
Thank you, Neeraj. Weight loss medications, which is a flavor of the day, miracle, breakthrough, or misguided shortcut? First of all, let us see the obesity and its
Dr.
prevalence
Vandana,
in
please
India.
join us.
4 out of 10 women in India are affected by abdominal obesity. If you go by prevalence of obesity by region, northern states, Delhi and Punjab, they are leading in obesity, whereas southern states, Kerala and Tamil Nadu, they are leading in obesity across India. Whereas the middle part of India is relatively obesity-free. So these are the drugs which are approved by FDA for obesity management. We'll be talking about these drugs, which are the breakthrough, we say, liraglutide, semaglutide, and tirzepatide, and more of semaglutide and tirzepatide. You know, these drugs, they have undergone a very robust clinical trial program. For Mounjaro or tirzepatide, the program is SURMOUNT-1, SURPASS program, whereas for semaglutide, it's STEP trials and Pioneer program. They have evaluated these drugs across all the spectrums. In SURMOUNT-1, the trial was for weight loss against placebo, but without diabetes. SURMOUNT-2 was weight management with diabetes. SURMOUNT-3 was after lifestyle modification. SURMOUNT-4 was what happens when you stop the medication. And SURMOUNT-5, they compared head-to-head Mounjaro tirzepatide versus semaglutide. So if you talk about Mounjaro or tirzepatide, this was very powerful weight reduction. You know, at 5 milligram, the weight loss was 16% at 72 weeks. Whereas at 72 weeks, with 15 milligram, weight loss was 22.5%. And weight loss started as early as 4 weeks. You know, in our practice, we say if you lose more than 5% body weight, it is good for a lot of cardiovascular risk factors. Whereas it was seen more than 10% weight loss was seen in majority of patients with 5 milligram tirzepatide, whereas 2/3 patients on 15 milligram Mounjaro lost more than 20% weight. So not only weight loss, but there was also improvement in the body composition. There's greater reduction in the fat mass than in the lean body mass. And also fat mass reduction was accompanied by reduction in the visceral fat. So if we talk about other benefits, not only weight loss or diabetes management, one is STRIDE trial, which showed, it was a dedicated trial with GLP-1 receptor analog, which examined functional outcome in patients with peripheral artery disease and type 2 diabetes. You see, it improved maximum walking distance by 13% in those patients with peripheral arterial disease as compared to placebo. Then another very important complication or the patient we are seeing in our practice every day now is those with liver fibrosis or MASH. It is the first and only GLP-1 receptor analog, that is semaglutide, which showed benefit for patients with MASH and advanced to moderate to advanced liver fibrosis. And this is ESSENCE trial. You see, with 2.5 milligram Wegovy, 37% patient had improved fibrosis as compared to 23% with placebo. Whereas MASH resolution was seen in 63% patients with Wegovy 2.4 milligram as compared to placebo 34%. Another trial, that is SELECT trial, a largest CV outcome trial, it showed semaglutide 2.4 milligram had proven MACE reduction in patients with overweight or obesity and CVD without diabetes. The MACE reduction was 20%. And MACE means major adverse cardiovascular events. So seeing this result, European Society of Endocrinology has recommended GLP-1 receptor agonist semaglutide should be considered in patients with overweight or obesity and chronic cardiac syndrome without diabetes to reduce CV mortality, MI or stroke. Now, another benefit, more than half of the patients who were pre-diabetics, they reverse to normal glycemia at 104 weeks with semaglutide 2.4 milligram, whereas those on placebo, their glycemic level worsened. Another important trial, FLOW trial, the results were so good the trial was stopped in between prematurely. It indicated that semaglutide significantly improved kidney and cardiovascular outcome in patients with type 2 diabetes and CKD. The key findings include 24% reduction in risk of major kidney events like kidney failure and CV death, 18% reduction in MACE, 20% reduction in all-cause mortality, and also it slowed the decline in EGFR and 32% reduction in UACR. So we have got other benefits also, like in proven benefit in OSA, osteoarthritis, and there are some benefit and studies are going on. Maybe we get the results in the future in patients with Parkinsons, neuroendocrine tumors, and polycystic ovarian syndrome. So if we go about how miracle, this or breakthrough miracle which occurs with these drugs, we've got all the drugs, and its slide shows mean weight changes in major trial with FDA-approved anti-obesity medicine. You see, all other available drugs, the weight loss around 5 to 6%, 7%. But these drugs, like semaglutide and tirzepatide, has shown weight loss to the tune of 15 to 20%. Thank you very much.
Thank you, Ajay sir, for taking us through how good these drugs seems to be. But then I'm going to show you the other side of these drugs and how I believe that this is not the miracle that Ajay sir has talked about, but rather maybe a misguided shortcut. Can I have my slides, please? आपने टाइम पहले ऑन कर दिया, स्लाइड्स ऑन नहीं करी. All right then. So taking you through what I feel that this is just going to be a stairways that are going to break soon. So it's nothing but just a misguided shortcut. So, you know, the sir talked about that we've been losing 15 to 20% of body weight, how it's a miracle drug. And it's true, the market has risen more than 700. But he did not talk about that there is an environmental issue and that this kind of is going to be a lifelong subscription model that he is selling. And I think that we are mistaking a symptoms that needs to be suppressed for a cure. And I'll take you through the cycles of shortcuts. In 1900, the first anti-obesity drug that we had was tape form. Can you believe it? It used to come into a small bottle and the salesman would go from house to house and say, if you want to lose form, take tape form. And whatever you eat, it's not going to get absorbed. Then in 1920s, we had cigarettes. The first FDA-approved anti-obesity drug was nicotine. In 2026, we are laughing at that idea. In 1930, it was dinitrothenol. Can you believe it? Something that is used as pesticides was marketed as weight loss drug. Fatal hypothermias and cataracts were there. There was, you know, explosions in the industry, so-called. Then we had the fen-phen, the famous drug in the 1990s, and which led to valvular heart damage and so many cardiac surgeries. Then we had lorcaserin. I remember that when I was reading my MBBS book, one of the only two drugs approved at that time was lorcaserin and orlistat. And then again, it was FDA withdraw it, apologize for it publicly, and said that it increased cancer risk. And now in 2020, we are still debating if this is going to be a miracle drug, really, after 1 century. Look at the advertisement that we had. Mounjaro, weight loss, Wegovy, you can choose your weight. Do you know what these advertisements remind me of? If you want to lose weight, reach for Lucky. Lucky was the cigarette brand. If, you know, the girl in the last slide is telling us that I know an easy way to keep from getting fat. Light a Lucky instead of eating sweets. That's it. We are back to 1920s and we are still selling cigarettes. All of this is just an illusion of safety. And why I'm saying that? Because safety has always been a lagging indicator. We can't say in 5 years or 6 years that this is going to be the safe drug. That is what FDA approval has told us, that after a decade, they inevitably have to withdraw the drugs because of something or the other. I mean, look at lorcaserin, a case study in reality. In 2012, approved. 2022, 20 withdrawn. It took 8 years for them to accept that the signals that they were generating were real. And that is the question. I mean, there are cancer signals that are still being generated by GLP-1s, you know, thyroid C cells. There are signals. I understand that statistically data does not say that, but let's not ignore the signals that are there. Lorcaserin has taught us that. And then why are we paying roulette with our GI systems? I mean, paralysis is not a side effect. It's the mechanism by which this drug works. At least it's one of the major mechanisms. Causes gastroparesis, wow, patient's not gonna eat. Bowel obstruction, patient's not gonna eat. Pancreatitis, patient's not gonna eat. I mean, obviously the weight loss is gonna be there. So we are causing pathological organ dysfunction and saying that it's gonna lead to cosmetic results and that's how it works. Whom are we kidding? And it's not just the gut. The new anti-obesity drugs even work at the level of the brain. It suppresses the reward system. You don't feel like eating. You don't enjoy eating. And you stop eating. And we are happy that the hedonic pathways are suppressed. Nobody's eating. Everybody's losing weight. But what about the side effects? People stop enjoying life per se. And this is not me who's saying that. Recent study from the Canada published in 2024 where these drugs are paid by the insurance. They found that at 2 years, the continuation rate is just 20 to 25%, despite the NHS paying for them because people leave it. They say that we have stopped enjoying life once we've been on this drug. That's the thing. And because it increases the incentive gap. So because the drugs are so effective, patients don't build a behavioral modification that they want. They stop exercising. They stop thinking about portion control because they're not having that much portion control. So once the drugs are taken off, there is no behavioral change that have been adapted and there is a rebound weight gain. That is what Dr. Sam West said, that when the treatment stopped, the coping skills that we needed were not there and there is a rebound weight gain. And it's going to happen along with the fact that there is going to be a muscle loss, which Dr. Rajay did not talk about. He just said that it's going to be a predominantly fat loss. I agree, it's going to be predominantly fat loss, but there's going to be a muscle loss. And Indians, we are anyway low in muscles. So, we have to be much more careful. And when we lose muscle, we lose our BMR and we are not able to increase the thermic effect of food. And what happens when the chemical that had been silencing our desires to eat is taken off? Ghrelin, which is the hunger hormone, it spikes. Leptin, which is a satiety hormone, it crashes. Metabolic rate drops because there is no muscle and there is no coping skills, and suddenly there is gonna be a rebound weight gain. And that is what all the trials have shown. If we look at the step 1 follow-up trial, so the step 1, up till the person was on treatment, very effective. As soon as the treatment stopped, there was a rebound weight gain and everybody returns to their baseline at 2 years after stopping the drug. Cardiometabolic markers, whatever benefits we see, every marker returns to baseline at 1.5 years. And there is going to be a rebound effect because adherence is not there. Either it may be because of the cost, because of the fact that there are side effects, because they stop losing weight, because they stop enjoying life, whatever they may be. Scientific evidence shows that at 1 year, 50% discontinuation rate, and this is what even I've seen in my clinical practice. It's been 10 months since we've had these drugs. Not more than 70% continuation is happening. So if you stop the drugs, there is a rebound gain. That means you are subscribing for life to these drugs. You're gonna be dependent. There is no cure. So let's stop selling the cure and let's not ignore the system. We are gaining weight because of the environment where there is an ultra-processed food, there is high sugar content, and these drugs do not change that. And the surprising thing, because once people were on tirzepatide and semaglutide, they stopped eating. So in markets, in supermarkets, the food, they suddenly were not selling as well as they could. So what people have started doing, they've started cut down the portion of the food and they're marketing it as GLP-1 friendly. Instead of giving 2 burritos, they're giving 1 burrito, marketing it as GLP-1 friendly, but still the person is eating a burrito. It's not eating a healthy food. So what we need structural and behavioral reform. We need like the Chilean model where we start having sugar tax and fat tax, or we need an Amsterdam model where the society takes it upon themselves to start being more active, eating food with the family and going out for walks. So this is the era that I'm talking about. We had the fad era. Right now we are in the pharma era, but if we want to progress and sustain this, we need to have a systemic era where the policies and family values are taken and they are the drivers of the weight loss. So my last slide, we need to not get confused with the GLP-1s as a I believe that it's a misguided shortcut because true health cannot be injected. It requires metabolic repair, not chemical suppression. We need to reject the shortcut. Thank you.
Can I have the slide, please? Slide. Hello. Can I have the first slide? Yes. Without wasting any time, I think I'll give you a very balanced approach. The most important slide. Why are we having this debate today? Because obesity kills. I'm not mincing my words. Obesity kills. And as obesity rises, there's a direct link between obesity and mortality. So it is very important to control the obesity. So today I'm going to present my perspective. And that is a surgeon's perspective, the role of bariatric surgery in the era of GLP-1 agonists. Today we have so many. So first of all, let me reiterate that bariatric surgery or any other is nothing is a quick fix solution. Obesity is a lifestyle disorder. The compliance of the patient is paramount, and surgery itself or GLP-1 itself is not going to produce any. So weight regain is going to happen unless you modify your own lifestyle. So counsel the patient that he is part of the treatment, and unless he wants to change himself, nobody can change him. No injection. So it is very important. As a surgeon, I would say that we must choose our patients very well. Primum non nocere. First, don't harm the patient. You go ahead with bariatric surgery, sometimes you make your patient worse than what he was. So choose your patient well, choose the surgery very well. And again, it is very important to understand that our Indian patient is a little different from the Caucasian counterpart because the metabolic syndrome is occurring at a lower BMI. These patients are more prone to diabetes. They are low in carbohydrates. Their protein content is low. So they cannot be treated in the same parameter as a Caucasian counterpart. So if you see the evolution of diabesity, which is obesity and diabetes combined, as I think my previous speakers have said, that the shift has changed from pharmacy to metabolic surgery, which happened around 2005, and now this boom of GLP-1 agonist era, where everybody is being injected for the purpose of weight loss. So the GLP-1 revolution is a powerful tool in our arsenal, but it has to be taken with a lot of responsibility. If you see the consensus meet of 2009, they have treated the Asian population different from the Caucasian population and said that for the Asian population, bariatric surgery can be offered at a lower BMI, as much as 32.5 if the patient has comorbidity. Well, how does surgery help? How is surgery better from pharmacotherapy or injection? Because surgery changes both the physics and chemistry of the body. I mean, I would just say physics because it changes the amount of food that you can take. It restricts, produces some amount of gastric emptying, and changes the chemistry of the body. So all the good hormones which are there in the body become. So there is a shift in the set point. Every patient has a set point. That is why you are not able to lose weight. You gain weight, you do a little dieting, you lose weight, you start eating something and you come back to that set point. So surgery does is changes the set point. Your energy expenditure increases, your calorie intake decreases. So your set point changes, shifted to the left, and that is why you are able to lose weight and maintain that weight loss that is there. So bariatric surgery is actually the opposite of restricted dieting. When a person is dieting or taking GLP-1 agonists, as Setu was saying, they are under stress because they are not able to eat very well. And that is the reason that they are not very happy. As we say that they become human after some time. You stick to diets, you stick to plans, but after some time you lose patience and then go back to your normal. So bariatric surgery gives you that you can eat whatever you want, only the quantity restriction is there, and the quality of life is better, and you lose weight, and almost all these metabolic complications of obesity can be lost with bariatric surgery. And you see the enterohormones, all these enterohormones which are good for the body, improve insulin resistance, they improve after bariatric surgery. And if you compare all these therapies, still bariatric surgery produces 50 to 85% of the excess weight loss, and weight loss is maintained. That is the most important. If you compare this with metabolic surgery with GLP-1, what important is that GLP-1 agonists, you need to take them lifelong. So there is a cost involved. If you see the comparisons which have been done in US and other countries, still metabolic surgery is still cheaper because it is a one-time cost and it is not a repetitive cost and you don't regain weight. Also, if you see the adherence challenge, that GLP-1, the studies have now shown that after 2 years, the discontinuation rate is as high as 72.2%. So that means only 20 to 25% of the patient continue with the medication, rest get fed up with the side effects or the cost or whatever and stop. But don't they have any role? Yes, GLP-1 and again they have a role, metabolic de-risking, they help in the liver shrinkage, improve the fatty liver. For surgeons, the initial that weight loss which happens after GLP-1 helps us in surgery because the left lobe of the liver becomes lighter and we can operate better in super obese patients. And also sometimes when we have this post-operative regain of the weight after 5 or 6 years, when patients start misbehaving or I would say become non-compliant, these GLP-1 agonists can be used. So if you ask for surgeon's perspective, yes, GLP-1 has a role, a phenomenal medical tool, but it has to be taken with a lot of responsibility. These are medicines which have a strong effect, so they have strong side effects also. And if you monitor them well, for example, one of these rare side effects is loss of vision. So all our patients, before starting GLP-1, we send them to an ophthalmologist to examine their cup size, and we find their cup size is small. We will not put them on GLP-1. Also, it is very important that we must counsel these patients that they have to do regular exercises. First of all, daily walks, 30 minutes. Next step, at least 2 days of yoga. Next step, 2 days of weight training. Weight training is the most important thing because these patients become sarcopenic, they lose muscle. So we must monitor on all their visits that are they losing fat or are they losing muscles. So if you do a very monitored, structured weight loss program, combining Dr. Setu and Dr. Ajay Agarwal and the nutritionist is very important, and the surgeon whenever he is required, because he is required for the morbidly obese and the super obese, because medicine alone is not going to affect. So I think together we can all great. And quickly I'll just share the results of Gangaram Hospital. Last 2 decades of metabolic surgery, you find that great resolution, diabetic parameters improve, anthropometric indices used, insulin resistance improve, C-peptides improve, gut hormones improve, the quality of life index improves dramatically, physical quality, mental quality, sleep quality, everything improves. But this is possible only with teamwork. I don't think alone a surgeon can achieve anything, alone an endocrinologist can achieve everything, and we have to hold the hand of the nutritionist first to get what we really want to decide. Thank you so much.
Good afternoon, everyone. I'm Vandana. Today I will be taking you to newer options for weight loss. Where are we heading? Humans were designed to move to survive, just like other living beings. Today, food has changed. Movement is minimal and stress is high. Our biology hasn't changed, but our environment has. The body responds by storing energy and leading to obesity. That is why obesity is chronic, progressive, and relapsing. It is not a failure of willpower, but a disease that needs long-term care. As our respected daughters have just discussed, we have very newer options for weight loss like dietary supplements, fat diets, pharmacotherapy, digital tools, and even bariatric surgery. But the key question is these tools replacing lifestyle and nutrition? No matter which intervention we use, the patients are at the center, and the patient is at the center. The success of any method depends upon the patient's engages. Many patients use trendy diets like L-carnitine, fiber supplements, meal replacements for weight loss. Majority of them are marketing gimmicks. Medical nutrition therapy and lifestyle modification remain the cornerstone of obesity prevention and long-term management. This slide highlights the fat diets, following fat diets such as intermittent fasting, ketogenic diet, detox diet, etc. Evidence shows that intermittent fasting and calorie restrictions produces similar short-term weight losses, but most studies being small and of limited durations. Diet like keto may cause rapid initial loss, but mainly due to the fluid loss and have important contraindications in chronic diseases. Many fat diets, they may worsen outcomes in individuals with chronic conditions. These diets are often designed for disease-specific management and not for long-term weight loss. Sustainable weight management requires balance, individualized nutrition, and restrictive diet results. App-based, they help to track daily routines, meals, and calories, increasing awareness of what and how much we eat. These apps should be used to assist and complement, but not replace dietitian-led advice for safe, effective, and sustainable outcomes. Our parents and grandparents stayed healthier, not because of gyms or supplements, but because life naturally included movement, home foods, sunlight, and sleep. Today, we replace the basics with the screens, sitting, and processed foods. Health isn't lost overnight. It is lost when simple daily habits disappear. Reclaim them. India is facing a metabolic mismatch. Our plates are high in refined carbohydrates, low in proteins, and quality fats. Study shows that calorie intake may be adequate, but yet nutrient balance is not. The fix isn't eating less, but eating right. Fewer refined carbohydrates, more proteins, fibers, and real food. Solution to the problem is diet. Weight control targets should be smart. S stands for specific, a balanced diet planned as per individual needs, measurable, portion control, and measurable changes such as plate waste, achievable, goals reached in a smooth and sustainable manner, no crash diets. Rewarding, you feel rewarded as weight loss happens gradually. This improves motivation. Timely, meal timing is maintained, 6 frequent meals, 2 snacks, small snacks. So we should eat less crap and more food. Calories drive weight loss, but precision nutrition drives health. Precision nutrients goes beyond calories to gut microbiome, inflammation, physical activity, mental well-being, and sleep quality, leading to better metabolic improvement. Targeted nutrition improves metabolic outcome and quality of life. Key strategies for weight management includes choosing whole and minimally processed foods, reading food labels to identify excess sugar, salt, and healthy fats, practicing portion controls to avoid overconsumption. Prevention should begin early in life with regular physical activity, balanced meal, adequate sleep, and reduced screen time. A balanced diet should include carbohydrates from 40 to 60% of total calories, 15 to 20 of proteins from total calories, and 30% from fats. And enjoying your favorite foods doesn't have to mean compromising health. Simple swaps can significantly enhance nutrition content while keeping the taste intact. For example, even a pav bhaji can be made healthier by avoiding butter, use whole wheat, ragi pavs, consume lots of salads. Burgers, pizzas, sandwiches, Mughlai, and Italian foods can also be modified by opting whole grains, grilled preparations, minimal oil, and lighter sauces. Obesity should be a multidisciplinary team approach. Integrated care delivers better outcomes than isolated interventions. As we conclude, remember that nutrition is never about one food or one meal. It's about understanding what, when, where, why, and ways to eat. Every individual is unique, and a dietitian looks beyond calories to your lifestyle, habits, culture, healthy needs, and mindset. Small mindful choices practiced consistently, right proportions, balanced meals, healthy cooking, and active living creates lasting health. Eat well, live well, and let food support your body, not burden it. Thank you.
Let me thank all the speakers for very nice elucidation of the recent concepts in management of obesity. What Dr. Ajay Agarwal has told us, he has surpassed and surmounted all the trials available in the world literature, which tell us how the weight loss has been very well controlled. But he didn't mention to us that every 30% of the weight which we lose, we tend to lose in the form of muscle. And muscle is the most important organ in the body to maintain a physiological homeostasis. We had an excellent counter argument by his colleague, Dr. Setu, who navigated us through the GI Roulette, in which he showed that we are trying to tread a path of misguided shortcut. But maybe, Setu, we can have a guided shortcut. There is no doubt. It is a misguided because, the type of the money the pharmaceutical companies are earning, you'll be surprised to know this company called Eli Lilly, which has come up with this wonder molecule called tirzepatide, which is a dual GIP and GLP agonist, has surpassed 1 trillion economy, which is economy which is more than 100 countries clubbed together. So first pharma company ever have to amass that much of the wealth. So Setu, I think we can have a guided, this is a wonder drug, no doubt, because it has a pan-GI effect, it has a central effect, it has an effect on the lipid metabolism and glucose metabolism. So we can have a guided rather than a misguided shortcut. Finally, and as Dr. Sudhir Kalan has told us, surgery is the answer, and surgeons are always the savior of all adventurists like gastroenterologists, nephrologists. Whenever you want to go and do something, some misadventure occurs, and surgeons are always saviors. Similarly, in a person who has a BMI of more than 40 or more than 35 plus comorbidities, surgeons are there always. So we do not challenge their need for being in this multi-team speciality homework. But the problem is patients are not willing to undergo surgery for different reasons. Maybe it is reluctance on our part to explain to them. For me, when we see the patient with fatty liver disease, you tell them you are 2 Bs, nothing will happen with medicine, go and get operated. वो कहते हैं डॉक्टर साहब हम तो फैटी लिवर के लिए आप आए आप तो सर्जरी की बात करें. They are not interested in getting operated. So it's high time we take consideration of everybody's aspects into one single stream rolling and try to give best to what is available to the patient. If you look at the trajectory of obesity, this is the burgeoning epidemic, and this is a price which we are paying for our increasing GDP. This is a price which we are paying our economic independence, and this is the price we are paying for our green revolution of excessive food. As Dr. Vandana said, we were born by the God, we were given the birth for the God to eat food. At a time when there was a scarcity of the food, there was something called hunter syndrome, in which the naked man would hunt for ages to get a prey to catch hold of it. At that time, there was no food which was available. So our genes are something called thrifty genes, which still keep looking forward to eating more. When our energy expenditure is decreasing, we are shifting over from a labor-intensive work to a white-collar work. We are shifting over from a field work to a desk work. And now even that desk work is also decreasing with advent of the AI, which was recently presented as robotics. It is high time we take less calories and try to exercise more, something which has not been really taken into account. If you look at the trajectory of weight loss, lifestyle management and exercise are the hallmark, irrespective of whether you take Dr. Ajay Agarwal's Monjaro or you take a diet of Dr. Vandana or you get operated by Dr. Sudhir. It doesn't matter. You have to stick to the basics of lifestyle modification and exercise, because the problem does not lie in the gut, it lies in the brain. So as Dr. Setu very rightly said, if you trample with the GI tract every time by either doing GI surgery or trying to put in different type of denudation of the duodenum, it never helps you. So you have to come back to the basic lifestyle. It is a teamwork which has to start with lifestyle changes, restriction of the calories, having a healthy diet, take a guided trip with Dr. Ajay Agarwal to have some reduction of your weight and finally maintain it if at a lower level by continuous exercise and restriction of the calories. I think that teamwork is what everybody has, I think, specified and as everybody has stressed upon it. Without teamwork, we are going to land up in the same. And coming to the last point which I want to make, Dr. Setu did show a very good slide of Chile's articles and the Amsterdam's modification. And finally he said what you need is a good planning, good health education. But that is not in our hand. When the towns are planned, it is a nexus between, say, politicians and bureaucrats in which the scientists are never involved. Nobody talks of healthy lifestyle or healthy food. Why should everybody be going on to Dr. Vandana for the diet? It should be a part and parcel of your own self. If that is inculcated, then only we can have a real dreamy stage which you have mentioned. Till then, I think we'll have to fall back upon Vandana's diet, Ajay Agarwal's Manjaro, and finally the surgery. Thank you.
Sir, can I make a comment? So we have got all the 4 talks. One thing I would like to say, the situation is not so grim. We can't outrightly reject these medicines. The only thing we need is person who prescribes this medicine and to whom it is prescribed. And with all the consent and with all the benefits, you have to tell the patient, and then we should be going ahead with the medicine. No medicine in the world is without side effects. So we have to balance what the benefit and what the risks are. Thank you very much.
Any questions from the floor? Otherwise,
Yes,
we can
please question, last question. We can take one question. You don't need this. You don't need this. इसको नीचे कर देते ना, मुंह छुपता है.
So, first of all, it should be used by the proper people under proper supervision and proper pre-screening whether it is died. 7 से 10,000 के केस में 10 स्टडी में पाया गया है कि there is one case of operator problem. Australia में there are cases of suicide. So question is they have to be properly and used.
Sir, that is how I think very proudly I can say that Gangaram Hospital is different from other centers. So we have a very structured program. Every patient who has to be started on GLP-1 gets an eye checkup done. And every patient who has under a weight loss program, whether it is medical or surgical, visits a pediatric nutritionist regularly. A BFA is done. We monitor their weight loss, whether the weight loss is visceral loss or muscle loss. And we tell them to go to our yoga center. We send them to the physiotherapy center so that, a very holistic attitude is. See, it has to be a healthy weight loss. So that's our motto in Gangaram Hospital, that please aim for a healthy weight loss.
So nobody has done a conference like this. So compliment to Gangaram Hospital for taking it up with this.
Thank you.
Thank you for such a scintillating session. I request everyone to please be seated for the inaugural ceremony.
So, can you have your attention, please? Now we'll have the inauguration ceremony. I'll request the Gulmohar coordinators to please stop the Gulmohar hall so that we can proceed with the single hall inauguration ceremony here. Start.
So we can start? Yeah. The capacity to learn is a gift, the ability to learn is a skill, and the willingness to learn is a choice. Good afternoon, everyone. On behalf of Sir Gangaram Hospital, it gives me immense pleasure to welcome you all to the annual SGRH CME, which is a platform that reflects our shared commitment to excellence, ethical practice, and continuous medical education. It is because of all of you that we are gathered here today, and we continue to strive for the same. We are honored to have all of you with us, and also an eminent panel of dignitaries who have significantly contributed to clinical practice, academics, and leadership in medicine. We thank you all again. May I now request our respected dignitaries to kindly take their seats on the dais. Our chief guest, Dr. Girish Tyagi, sir. Please, sir. The President, DMA. Next, I'd like to invite Dr. Rana, sir, who is the Chairman, Board of Management, Sir Gangaram Chairman, Trust, Sir Gangaram Hospital. Dr. Ajay Swaroop, sir, who is the Chairman, Board of Management, Sir Gangaram Hospital. And Dr. Sanjay Manchanda, sir, who is the organizing chairperson of this CME. We also warmly acknowledge our dignitaries of the dais, Dr. Bhalla, sir, who is the Honorary Secretary, Board of Management, Gangaram Hospital, Dr. Jaya Sood, ma'am, who is the Vice Chairperson, Board of Management, Gangaram Hospital, Dr. Ashwini, let's have the applause coming, please. Dr. Ashwini Dalmia, who is the past President of DMA, and ma'am Neelam Lekhi, ma'am, who is the President-elect DMA. Now, we'd like to proceed with the felicitation of dignitaries as a mark of our respect and gratitude for their invaluable contribution and time today, and of course, their continuous guidance to all of us. So to start with, I'd like to invite Dr. Shweta Mittal, ma'am, to please felicitate Dr. Girish Tyagi, sir. Dr. Neeti Tiwari, ma'am, to please felicitate Dr. Rana, sir. Dr. Tinku, ma'am, to please felicitate Dr. Swaroop, sir. And Dr. Sunita Bijarnia, ma'am, to please felicitate Dr. Sanjay Manchanda, sir. Next, I'd request Shweta ma'am to please felicitate Jaya ma'am.
Jaya ma'am. Jaya ma'am. वहीं पे
Dr. Neeti ma'am to please felicitate Bhalla sir. Dr. Sunita ma'am to please felicitate Ashwini Dalmia sir. And Shweta ma'am to please felicitate Neelam Lekhi ma'am. To invoke the blessings for wisdom, knowledge, and learning, we begin this academic journey with Saraswati Vandana. And also, I'd request our dignitaries to please proceed for lamp lighting, symbolizing enlightenment, learning, and the pursuit of excellence. I'd invite all seniors in the audience to please come for lamp lighting, please, sir. Jaya ma'am, Bhalla sir, Neelam ma'am, Satnam sir, Johari sir, Dr. Anil Arora, please. P.S. Gupta sir. Beotra sir is also here. Beotra sir, please come for lamp lighting. Sharda Jain ma'am, if please come. Dr. Anil Agarwal sir, please join. We now like to invite our esteemed dignitaries to share their thoughts and guidance. Can we have a huge round of applause for Dr. Manchanda sir, who has worked day in, day out for organizing this conference. So please come and address the esteemed gathering.
Thank you, ladies and gentlemen. Honorable Chief Guest, Dr. Girish Tyagi, Dr. D.S. Rana sir, esteemed Chairman of the Trust Board, Sir Gangaram Hospital, Dr. Ajay Swaroop, respected Chairman of the Board of Management, Sir Gangaram Hospital, our special guests, Dr. Neelam Lekhi and Dr. Ashwin Dalmia, and Dr. Neelam Lekhi is the President-elect of the DMA, distinguished faculty, dear colleagues, and fellow delegates. On behalf of the CME committee, it gives me immense pleasure to privilege to welcome you all to this continuing medical education program. We are extremely thankful to Dr. D.S. Rana and Dr. Ajay Swaroop, because the thing is, without their support, this was not possible. And all our chairmen, and especially Dr. Rana and Dr. Swaroop, they have always been forthcoming and have always helped us do whatever we wanted to do. Thank you very much for that, sir. Now, continuing medical education is not merely an academic formality. It is a professional responsibility. Medicine is a constantly evolving science, and as a general medical practitioners, you remain the backbone of the healthcare system, the first point of contact, the first healer, and often the most trusted advisor to the patients and their families. Programs like the CME are designed to bridge knowledge gaps, update clinical practices, and translate evidence into day-to-day practice of the patient care. Today's scientific session has been carefully curated to be practical, relevant, and applicable to the real-world clinic scenarios. I encourage all the delegates to actively participate, ask questions, share experiences, because learning is most meaningful when it is interactive. I would like to place on record my sincere appreciation to the faculty, through the organizers and volunteers who have worked tireless to make the CME a reality. And I need to specially thank my fellow colleague, that is Dr. Neeraj Dhamija, who is the secretary of our CME organization, who has been standing like a rock with me and has helped me realize my vision for the CME. With these words, I once again welcome all the dignitaries and delegates and wish everyone a stimulating, enriching, and successful academic experience. Thank you, ladies and gentlemen.
So, as you all know that this has been 15th annual CME, I would now call upon organizing co-chairperson Dr. Tinku Bali, who has been part of the last 14 from the beginning of inception of this CME concept. Dr. Tinku, please.
Good afternoon, everyone. All the dignitaries on the dais, seniors in front, and all my dear friends and colleagues. So it's such a pleasure to see you all once again. And the CME started way back 17 years ago. We didn't have CMEs during the COVID time. That was the only time we didn't have. And over the years, the CME has grown from strength to strength. So every year, it's so good to see old familiar faces amongst the audience. You all have become almost like family to us. And this time, I also see a lot of new faces. So welcome to the Gangaram family. This CME not only aspires to give you an update of new cutting-edge technology, give you a lot of practical pearls for your practice, but also help you to forge new bonds of comradeship with all the doctors in Gangaram Hospital. So I do hope that this is a very fruitful CME for you all. I hope you get to learn a lot of new things and also to make new connections that will endure through times. So welcome and thank you all for your presence here this afternoon. Thank you so much.
Thank you, ma'am. Next, we'd like to invite our leading light, Dr. Ajay Swaroop sir, who's the Chairman Board of Management, Gangaram Hospital, for his words.
Honorable Dr. Girish Tyagi, President of DMA, and a very, very close friend, personally as well as a close friend of Gangaram Hospital. Dr. D.S. Rana, he needs no introduction, Chairman, Sir Gangaram Trust Society, and a guiding force for the hospital since many, many years and is going to continue for many, many years, I hope. Dr. Sanjay Manchanda, there was a need to change the organizing committee, and the first name that came to our mind was Dr. Manchanda. He is a very well-read person. He's a all-rounder, and if you give him a responsibility, this is the result. And I'm very thankful to him and to Dr. Dhamija and his team. They have organized this in a beautiful way. And of course, ultimately, any conference or any depends on the participants, on the delegates. This CME, as you have heard, is the 15th. And it's been going on for the last 17 years. And I'm sure there are people sitting in the audience who have been attending all the CMEs. And this is what we aim for. This is basically a family outreach. We have always tried to involve all our practicing physicians, specialists in and around Gangaram to interact with us, to know what we are doing, how we are doing, what sort of ethical work we practice, and to keep abreast of what is happening in medicine. As you are all aware, Gangaram has been there for more than 7 decades, and we've successively tried to maintain our reputation as one of the most ethical healthcare giving facility. And it gives me great pride when people say that Gangaram continues to be a hospital and not a healthcare industry. And that is what we aim. That is our aim, that we continue to be a hospital, and we only continue and be successful as a hospital if we have the support of all of you. And this CME is basically an interaction. All of us learn from each other. We know something, you know many more things, because you are, as has been said, you have the first contact with the patient, and that is the most important contact. Later on, things get diluted, when the patient, by the time he reaches us, we know what exactly is to be done. But it is your job which is most difficult when you first initially interact with the patient. So that was the reason when it was planned 17 years ago that we should have an interaction, so that we learn from you what are the problems that you face, and we try to impart some technical knowledge which we have. So again, I welcome all of you to the 17th CME. I hope you appreciate the efforts that have gone in curating this scientific program, and I'm sure there'll be a hearty meal after this. So welcome again. Thank you very much.
Thank you, sir, for your encouraging words as always. Now I'd like to invite Dr. D.S. Rana, sir, the mentor of mentors and who always helps us to see hope within ourselves. Welcome, sir.
Today, chief guest and our dear friend, Dr. Grish Tyagi, my dear colleagues, and Chairman Board of Management, Dr. Rajesh Swoop, the Dr. Sanjay Manchanda, my friend, who has created this program, and all delegates, many, I can see my teachers, we must say compliment of so many people must be knowing Professor P.S. Gupta, and he has got third generation sitting here actually. A lot of senior friends from Gangaram and outside Gangaram sitting. My regards to all of you and best wishes to all of you. I am very happy that when you are waiting for lunch, still the hall is packed, And so that only shows a zeal to learn, to teach. Everything has been said about CMEs. A little bit about Sir Gangaram Hospital. No, all of you know, but there are some young people also. You must know that Gangaram Hospital is it is a trust-run hospital. Sir Gangaram Trust Society runs the hospital. They are the custodian of the hospital. But Trust Society is just a custodian and provide guidance and support. The hospital is run by Board of Management. Dr. Rajesh Swoop, who was the head of ENT department and had been secretary with me for the last 12 years. Now he had taken up the responsibility of running the hospital. So he's the main person, and other three people are sitting in the front row. So it is Board of Management which run the hospital. It's a very doctor-friendly hospital, the patient-friendly hospital. And it is, as Dr. I just told you, that we feel very happy when people say that this is the hospital, and we are compared with AIMS, and rightly so. It is not only that we pay importance for providing ethical and quality health care with cutting-edge technology. We are the almost first to acquire every technology in non-government sector, But we equally emphasize our emphasis on medical education and research. You'll be glad to know that our hospital is now 930-bedded hospital. And we have got 150 more beds outside in two hospitals, And we have got our DNB program in as many, probably 51 or 52 specialties. Many of the programs on national board have been devised by our faculty, And we are the largest #1 center of the country as far as DNB program is concerned. And we have got 300 plus DNB students in various specialties. Not only that, you learn to, very young ladies from genetics department. We invest very heavily on our genetics, labs, and these academics, And hopefully, if everything goes well, then in the coming years, you will see that Gangaram will be having either medical, postgraduate medical institution, duly recognized for MDMS, or we will be having at least medical college, That is our aim, our next aim, So, with these few words, this is just small introduction about Gangaram Hospital. I just thought just to give a little introduction about Gangaram also to many people, though you may not be knowing about this, With these few words, all people have talked about CMEs, and CME is a very, very important part, because learning today especially, they have become very important when patients are very, they expect a lot from you, and they expect everything latest from you. So and in CMEs, people, though you're listening, they learn. The people, though you're speaking, they're also learning. It's both ways they are learning. With these few words, thank you very much, but must congratulate. Now, this program being run by Dr. Harvans Lal, who just recently retired, and Dr. Tinku Rajdan and other people. They have been running very successfully. And now Dr. Sanjay Manchanda has taken over. He's a very creative person, and he's aided by Dr. Dhamija, who is a very energetic person. And I was very impressed to see the slides and everything what they have devised. Heartiest congratulations to you, and heartiest congratulations to the Board of Management and his chairman. Thank you much.
Thank you, sir, for your inspiring words, as always. Last but not the least, we'll invite our chief guest for today, Dr. Girish Tyagi, sir, whose role in DMA we all know about. He's a prominent person. He also is a staunch advocate for patient rights, ethical practices, and has been involved in taking a lot of action against quackery. Welcome, sir, and we are honored to have you here today. Please, sir.
Thank you very much. Dr. D.S. Rana, Dr. Ajay Sarup, our close friends. Dr. Sanjay Manchanda, Dr. Dhamija, who are heading the CM committee. The experience of Dr. Sanjay Manchanda and the youth of Dr. Dhamija will take care of CME, which is, of course, Gangaram CME is much awaited CME. People wait for the date when this is going to be held, and for the months together, they are waiting for that CME because of the content, because of the speaker, because of the latest development, and of course, we know that. Dr. Bhalla, Dr. Jayashree, Dr. Beutra, and all other senior faculty, which is of the Gangaram Hospital, which is very close to us. And I'm assessed whenever I come to Gangaram Hospital or to any hospital for a lecture or something like that, I always say that Gangaram Hospital is the only hospital which is doing purely a service. As Dr. Joseph told that it is not a healthcare industry, it is a hospital. And it is a hospital which is doctor friendly. Faculty of the Gangaram Hospital, we rarely see that faculty of a hospital, corporate hospital हम देखते हैं कि आज इस hospital में थोड़ा सा increment मिला, दूसरे hospital में भाग गए. Gangaram Hospital, the faculty which is there, rarely we have seen that the faculty of the Gangaram Hospital going to for another hospital, because they are convinced safety is there of the doctors also, and of course the patients are much more satisfied, as we have seen that the 1,000 beds are there Gangaram Hospital. Every time जब DS राणा से या अजय स्वरूप से सिफारिश करनी होती है बेड के लिए कि सर बेड दिला दो सर, एक बड़ा पेशेंट है, नीडी है, चाहे वो all over India, we have seen that people are waiting for the bed. They are waiting for days कि हमारे को ऑपरेशन तो गंगाराम हॉस्पिटल में कराना है, चाहे वो डॉक्टर जोहरी हैं, चाहे अनिल अग्रवाल हैं, चाहे वो हमारे ऑर्थोपेडिक सर्जन और के हैं, या CAD के लिए स्टेंट भी वहीं पे. So we have seen that people are waiting and they just don't want to go to any other hospital except the Gangaram Hospital because of their satisfaction, because they know that the patient safety is there, patient's role is there. So I must compliment Dr. DS Rana, Dr. Ajay Swaroop, and all the faculty who has taken the Gangaram to so much heights for that matter. My request to Dr. DS Rana, Ajay Swaroop कि सर इसको तो मेडिकल कॉलेज में काफ़ी टाइम पहले ही हो जाना चाहिए था. बिल्कुल सर, हम तो बिल्कुल आपके साथ हैं, बिल्कुल, बिकॉज द कंटेंट इज़ देयर. इतना अच्छा बेड्स वहाँ पर है, फुल बेड है, और रिसर्च यहाँ पर हो रही है, एवरीथिंग इज़ देयर. वी हैव सीन दैट 52 DNB courses are there, and first priority of the any DNB student is to approach the Gangaram Hospital. कि मेरा hospital Gangaram, first priority is the Gangaram Hospital. So such is the fate of Gangaram Hospital. नहीं चलो, maybe the government should think over it कि इसको एक मेडिकल कॉलेज में कन्वर्ट करें, नॉट फॉर गंगाराम हॉस्पिटल की उसके लिए, बट फॉर द पेशेंट रोल, पेशेंट सेफ्टी के लिए, पेशेंट सेटिस्फेक्शन के लिए, पब्लिक सोसाइटी के लिए, फॉर एवरीथिंग इज देयर दैट इतनी अच्छी फैकल्टी कहीं मिलेगी नहीं, इतना लोड कहीं नहीं मिलेगा. बिल्कुल बिल्कुल बिल्कुल. डॉक्टर DS राणा ने ट्राई कर रहे थे, डॉक्टर अजय स्वरूप कर रहे थे, एंड वी फ्रॉम द दिल्ली मेडिकल एसोसिएशन, डॉक्टर नीलम लेखी इज देयर, डॉक्टर पोदार इज देयर, एंड पूनम गोयल इज देयर. सो वी विल थिंक दैट all Delhi medical fraternity should support Gangaram Hospital in achieving that medical college is being run by the Gangaram Hospital. We support you, and we will pray for it that it comes soon, sir. And of course, we have seen that CMEs nowadays, the patients are more aware ones. They came prepared whenever they're going to the hospital, and treatments are going costly. Because of that, litigations are more, so we have to be very careful about the consent and the documentation. Dr. A.K. Bhalla was there with Delhi Medical Council. We have seen that the complaints are being filed against the doctors and the hospital for silly issues like communication. We as doctors are not able to communicate with our patients or the society, and sometimes we are not documenting. So but we have seen that Delhi Medical Council was there for 17-18 years against Gangaram Hospitals. Very minimal number of complaints. Of course, you cannot avoid the patients or the relatives to file a complaint, but there is no conviction against the government hospital, Gangaram Hospital, whether a license was removed for a doctor for that matter. So it is a compliment to Gangaram Hospital that they have done so much of things. And my best wishes to Gangaram Hospital, Dr. Manchanda, who is our from the same medical college. I know him so many years. He was few years junior to us. And my best compliment to Dr. Manchanda and the other team members, so that they continue that work which the previous team was doing. Once again, thank you very much, sir.
Good afternoon. Before we commence with the award ceremony, I would like to request Dr. DS Rana and Dr. Swaroop to felicitate our guest of honor, Dr. Girish Tyagi. Chief guest. Our chief guest, Dr. Girish Tyagi. Now I would like to request Dr. Rana and Dr. Swaroop to felicitate our guest of honor, Dr. Neelam Lekhi. Please join us on stage.
Please, can we have a round of applause?
A big round of applause for our esteemed guests.
स्क्रीन पे डाल के दिखाइए एक बारी. हाँ please. Oh, good practice award.
Now I would like to request Dr. Sanjay Manchanda sir to felicitate Dr. Rana. And Dr. Manchanda will felicitate Dr. Swaroop.
Now for a special award ceremony.
Now, as we begin our special award ceremony, general practitioners are the backbone of our healthcare system, the first point of contact, steady hand, and often silent problem solvers. Today, these Good Practice Awards recognize clinicians who go beyond routine care, showing consistency, competence, and clinical excellence in everyday practice. This award is a tribute to dedication that may not always make headlines, but makes profound difference in patient levels. It is our honor to acknowledge and celebrate such exceptional work. I would like to invite all our dignitaries on the dais to felicitate our first recipient, Dr. Ajay Dhawan. Sir, please could you join us on stage? Alphabetical.
Next one.
Next. दे दो डॉक्टर अजय ठीक है दे दो अवार्ड दे दो लाइन्स वाला ठीक है हाँ MM आनंद
Doctor.
हाँ डॉक्टर MM आनंद Dr. MM Anand, sir, please could you join us on stage? Let's have a round of applause. Please keep the applause going. We have a lot of awards. Next is Dr. Gaurav Nijhara. Sir, please join us on stage.
Dr. Gaurav Nijhara.
Dr. S.K. Podar. The applause mustn't die down. Louder, please. Dr. S.K. Podar. Dr. B.B. Mittal. Dr. B.B. Mittal. I think he's not there.
ठीक है डॉक्टर एसके नागरानी अभी ये बोलेंगे कुछ कह रहे थे हाँ प्लीज सर यू वांट टू से समथिंग
Sir, with your permission, I would like to say a few things. First, I am attending this Gangaram annual CME 14th time in last 14 years. I have attended all the CMEs because I am from the grassroots worker of the IMA and I am contesting for the post of President-elect this year. This platform should not have been used for this purpose, but because my opponent has used it, so I have to say it. I am past president of IMA South Delhi branch. I am past secretary of DMA and past senior vice president of DMA, grassroots worker. I seek your support. And sir, one thing more. I must praise Gangaram Hospital. I am not because you are giving me an award. I have attended all the CMEs. I have seen all 14 CME full of delegates. And when we talk of ethical practice, we always feel Gangaram Hospital is an example. Thank you very much.
Thank you, sir. Thank you.
Okay. Coming back to the award ceremony, next is Dr. S.K. Nagrani. Sir, please join us on stage. A huge round of applause, please. The applause mustn't die down.
I request Dr. S.K. Dr. Rakesh Julka to be ready next.
I request Dr. Rakesh Julka to be ready next. Dr. Rakesh Julka? नहीं है. Dr. G.S. Kohli, sir, I would like you to come near the stage. Dr. G.S. Kohli, sir, please join us on stage. Dr. Sushil Kumar Taneja. Dr. Sushil Kumar Taneja. Dr. S.K. Tyagi. Dr. S.K. Tyagi. Dr. Shamik Chakravarti.
Please.
Dr. Dr. S.K. Tyagi का दे दो.
Dr. Shamik Chakravarti.
Dr. Shamik Chakravarti and S.K. Tyagi. हाँ. Dr. Kshitij Bali. Dr. Kshitij Bali. Sir, please join us. Dr. J.K. Sharma. Next, J.K. Sharma.
Sandeep Datta.
Dr. Sandeep Datta. Next, we have Dr. J.K. Sharma. Please, a hard round of applause. Dr. Sandeep Datta. Dr. Sharda Jain.
Prakash Chandra ji last.
Oh, ye last. Dr. Sharda Jain.
Dr. Prakash Chandra.
Dr. Prakash Chandra Gira. Dr. Prakash Chandra Gira. Early birds. Dr. Shama Batra. इधर से. Dr. Shama Batra.
Dr. Shama Batra, please.
A round of applause, please. Okay, so this commences our Good Practice Awards. I would like to congratulate all the awardees. And now we move on to the early birds after this.
Early bird prizes.
So the first was Dr. A.K. Kapoor, who came in at 7:45 a.m. Dr. A.K. Kapoor, who joined in at 7:45 a.m. He's our early bird, truly. Then we have Dr. Amit Kumar Saha, who was just a minute behind at 7:46. Very close call. Dr. Amit Kumar Saha. Sir, please join us. And he was closely followed by Dr. G.S. Bansal, who came in at 7:50. I think the enthusiasm for the CME was quite high. But let's have some enthusiasm in the round of applauses as well. A huge clapping. Then we have Dr. Satish Gupta, who came in at the same time, so it's a tie for 7:50. Dr. Satish Gupta. Then we have Dr. P.H. Diwan at 8 a.m., sharp dot at 8 a.m., along with Dr. Pinto Kumar. and Dr. A.K. Rastogi at 8:01. So please join us.
Thank you all for coming right in time so that we can start our scientific program in time, which is absolutely necessary for such kind of forums. So we decided to have lucky draws. I believe everyone has already put their names for the lucky draw. No? No one? So it was digital. As soon as you entry, it is here in my phone. So we have some artificial intelligence in this also. So this year we're going to have a digital lucky draw, and it's there on your screen, right behind. So we'll be having 2 draws, 10 lucky draws first, and 10 at the end of the session. So we'll be commencing with first 10 lucky draws.
Dr. Vikram Chitoda. Dr. Vikram Chitoda, he's our first lucky draw winner.
We'll save the name, even if they're not here, they have attended, they are going to get the draw. Very good, sir. Dr. Sushil Kumar Garg.
Dr. Sushil Kumar Garg, sir, are you here? Dr. Rabia. Rabia, oh yes, she's here. 3rd time's a charm. Ajay, Ajay.
We have the first physical lucky draw in digital world. Price law, lucky draw, beto. Aajo. Please, ma'am.
Dr. Congratulations. You are the lucky
Dr. Somdat Sharma. Sir, are you here? Dr. T. Naresh Kumar. Dr. P.C. Pava. Dr. Saket Bihari. Dr. Nikhil Shaw. Dr. Sneh Mahajan. Dr. Kamal Dhingra.
These are the first 10 lucky winners. The next 10 lucky winners will be at the end of this session. So now it's time to have vote of thanks from my side. And I sincerely thank all of you for coming here and making this CME a grand success. Without the possible leadership like Dr. Rana, Dr. Swaroop, it has not been possible. Thanks, Dr. Girish Tyagi, for accepting our invite. And the man behind every planning and every execution, Dr. Manchanda. I don't think if he was not there, we would not have been able to do this better. And I thank all the organizing team members at the back-end staff, Madhuri, Anjali, and everyone, executives, Dr. Karan, who have helped us in organizing this event. Thank you all. Yeah, special thanks to Veronica and Koppel for holding the conference and making it like a flow of events very smooth. And now we'll break for lunch and we will reassemble in the hall in half an hour to resume our scientific session. So there are 2 lunch places which is there, one outside and one in the Mahogany, which is just across behind Gulmohar, there are two places where the lunch is served. So you can divide yourself so that everybody does not move ahead in the same direction. So one buffet is outside and the other is near the Mahogany. Thank you. Are here. This is a very important panel discussion on organ transplant. And I believe Gangaram Hospital has always been very actively involved in organ transplantation. All good? So we all know that Gangaram Hospital from the beginning has been involved in all kinds of transplant, and it was a mastermind of Dr. Manchanda to include this transplant session where we can keep on stage every possible organ which we can think of getting transplant done into a human body. And as you can see, there are so many people involved in this panel. And with the king of transplant surgery at Gangaram Hospital, Dr. Harsha Johri. So we have a very elite panel here. I would request everyone, if they have finished their lunch, they can just join in. We are starting in 1 minute. Dr. Johri. So first I will invite the panelists and then the moderator. So I would like to request Dr. Anita Ganger. Dr. Anita, please. Dr. Vipin Tyagi. Anita is ophthalmologist. Dr. Vipin Tyagi is main urologist here with us. Dr. Ushas Dheer, liver transplant surgeon. Dr. Sujay Shah, the most difficult heart transplant. Dr. Sujay Shah, can someone call Dr. Sujay Shah? Manas, can you call him? Karan, can you call Dr. Sujay Shah? He was there outside. Dr. Manas. Dr. Bhim Nanda. Dr. Manas, you have already heard, he's a hemato-oncologist for bone marrow transplant. Dr. Bhim Nanda was an active part in hand transplant. Dr. Kanav Anand, our pediatric nephrologist. Dr. Sudhir Chaddaji, one of the earliest person who was there with Dr. Johari to start the kidney transplant, one of the most successful transplant program across India. And we'll wait for Dr. Sujay Sir and none other than Dr. Harsha Johari. May I kindly invite you, sir, to start the proceeding of this transplant panel. बैक साइड रख दे डॉक्टर सुजय साहब आएंगे और कौन आ रहा है डॉक्टर अनिल अरोड़ा जी ही इज द मॉडरेटर आल्सो आ जाइए सर डॉक्टर सुजय साहब जी प्लीज इधर आ जाइए सर डॉक्टर अनिल अरोड़ा इज आवर चीफ ऑफ गैस्ट्रोएंटरोलॉजी and he is involved in all liver transplant patients. Over to Dr. Harsha Johari.
Good afternoon, everyone.
Close the door.
See, most surgeons have very small brains. They work on spinal level. And after a meal like this, most of the blood is diverted to the stomach. Dr. Roman Datta also, please. Yeah. So most of the blood is diverted to the stomach. So the brain becomes a bit lethargic. So I'll try to make it a little more awake. Right? Now the question is, I've been given 30 minutes and less. And I've got to go through this wonderful panel of people. Now, Gangaram Hospital has been in the forefront of transplantation for the past almost 4 decades. And we are now known as the nursery of not only transplant surgery, but for all kinds of medicine. As Dr. Rana must have told you, 52 disciplines in which we have got postgraduate degrees. So people grow up here, they become stars, they become superstars, and then they go and shine in other places as well. And we glory in that fact. But transplantation, again, we have trained people in all kinds of transplantation, and they have gone to various shores beyond India, and they have done very well. So I'm just going to start now with the first. Tamsoma Jyotir Gamaya, lead kindly light. So we start with Anita Ji Gangar. She is a corneal transplant surgeon. I have just 2 questions from you. What are the causes and the load of corneal transplant, blindness, and what is the range of our work and what is the success? 2 minutes each, and then for questions from the audience.
Sir, as we say, first of all, thank you for this opportunity to speak about it. In India, sir, corneal blindness is estimated around 1.1 to 1.3 million for bilaterally corneal blind people. And if we add unilateral blindness also to this, there would be further millions. Like around 9 millions of people are blind in India due to corneal blindness. So it is the most common cause. So commonly corneal blindness caused due to infections, traumas, any disease, degenerative disease like keratoconus, and diseases like, it can occur iatrogenic also after cataract surgery. So with the scenario of good surgeries now from the last decade, it has decreased, but definitely infections in rural areas still persist. So there is a very high load of corneal blindness in India. And unfortunately, every year it needs at least 1 to 2 lakh of transplants, which we are doing only around 25 to 30,000. So it's lack of corneas is the main reason. But there is a shortage, and there is again burden of corneal blindness, which is adding up every year. And in our institutes, we are doing the corneal transplantations. We have our own eye bank, which is associated with Rotary Center. And here we are doing all type of corneal transplants, like full thickness keratoplasties as well as the partial thickness keratoplasties, because as we have less corneas, we want to use every portion of it. So each layer, if the interior layer is involved, we transplant only that. And in any patient, if the posterior layer of cornea is involved, we transplant only the posterior layer. So that's how we use one cornea for at least 2-3 patients as per the need of the patient. So we are trying our best, but still we need to create further awareness for the donation of eyes so that we get the corneas and we transplant it more.
How do we get our students to get involved in cornea transplant? Because they are very easily led into other kinds of ophthalmology surgery. How do we promote this as a national program?
So at basic level, the main promotion is needed at the level of grassroots to increase the awareness. So every year we have fortnight, which is just held for this to create the awareness. In those, we create the various presentations, the walk, awareness walk, and the various cultural programs to create the awareness. So that is the first step we need to do, and we can incorporate children in the, students in that.
Okay, from the eye to the hand, the coordination.
Thank you, sir.
India is the largest center for doing India is the largest country for doing hand transplants. Last count is, I think, almost 200. And cadavers is where you get your hands from. Every cadaver is a potential hand donor. Unfortunately, it is not translating into numbers. But you have done a whole lot of experience gained from other centers, and we have also done our own hand transplant. So what is your experience regarding the reluctance to donate, and what is the functional outcome once we have done the transplant?
As sir, you told that now India is the leading hand transplant center in the world. Taken together, the whole world, one side, and India is leading, as you said, more than 200 hand transplant in India. So the main problem is like public awareness, because if you see the other solid organ donations, like body is not disfiguring. But as soon as you explain the relatives that yes, we will be harvesting or we will be taking the hand at various levels, the relatives get, sir, like the body will be deformed. So what we do is we try to explain them that yes, we have processes made at all the levels. Once we harvest the upper limb at whatever level we required, we fit the processes to give the respect to the body. But still, in our scenario, it's very difficult for relatives to accept that the body will be disfigured and patient will have a plastic hands at the time of cremation. So this is the main problem. Secondly, regarding function, like once we transplant the hand, apart from the immunosuppression, which is like other solid organ immunosuppression, the results are pretty good because the tacrolimus or the immunosuppressions cause nerve regeneration better than the normal reimplantation. Like people also come with the people like who have amputation of finger or hand, we reimplant. So if you compare the transplant, the result of transplant are better because nerve regeneration is better, so motor function is pretty early. So if we compare with even a normal reimplantation part which is reimplanted back to the same person, transplant has a better prognosis function-wise, sir.
Will you be able to have a grip? That is what is important.
So it depends on the level of the transplant. Like if we're doing a mid-arm level, yes, the grip will be there, but it will be little weak. So as we go distal, almost at the wrist level or the mid-forearm level, the function almost 100%, sir. 100% patient will be able to have sensation and full motor function, sir.
So we require more governmental and institutional support.
Yes, sir. And
for awareness.
Public awareness, sir, that yes, it will be disfiguring for the patient, but just imagine a life of a bilateral amputee, sir. He cannot even eat his food. He has to eat like an animal, or just imagine a person without both hands. So it's same as a life-saving transplant, sir, for that patient.
So now we have straight from the hand to the child, right? Now, again, Gangaram Hospital is the leading center for pediatric transplant, and a vast percentage of the credit should go to this young gentleman sitting over here, Kanavanand, because he brought in that dedication and effort to convince parents. Because before that, I remember when we used to try to tell them, they were not prepared to have dialysis. It was, sorry to say, it was cheaper to have a new child than to have dialysis. Forget about transplant. He has managed to convince. We have done almost 200 transplants. One of the largest centers in the country, if not beyond. So I would like to ask you, what is your experience over the past so many years, and how does pediatric transplant differ from adult transplantation?
Thank you very much, sir. So basically, as sir has already told, that we have done many transplants in pediatric age group, right from the youngest being a 3-year-old child and weighing just 10 kgs to almost like 18 years and beyond. And usually we, as per the age, we have already told you, then secondary, we are also doing ABO incompatible kidney transplants. If the blood group is not matching, because half the time, if the blood group is not matching, that becomes, usually used to become an indication for not doing a transplant. But then now we have facilities like plasmapheresis, where we can change the child's blood group, or we can say, you can say the antibody titer can be reduced so that the child is able to accept the kidney from another blood group. And the risk of rejection is almost on a similar standard as to ABO compatible transplants. So the outcomes are also good. Second thing is, in pediatrics, how is it different from adult transplantation is, one, that you have to prepare the child for a transplant. It's not like you come, I do a transplant and he goes back home. The child has to be optimally managed, both from terms of your CKD management, to the nutrition management, to the vaccination status, because these children are more prone to get infected. And not even the child, the family has to be vaccinated. Because if there's another sibling who catches some infection and comes back to the home, again, the infection goes to this transplanted kid. So the whole family has to be motivated and start dialysis early so that the outcomes are better, they are better metabolically controlled, and then we go for the transplant. During the OT, what we have to see is like it's an adult kidney being transplanted into a child. And most of the times the donors are parents. So you have to ensure that the surgical expertise has to be good, as seen by our unit. And so for that, it's a small vessels being, you can say, anastomosed to the bigger vessels of the donor. Secondly, the moment the kidney is put in, it will suck in a lot of blood from the child's circulation. So the BPs have to be optimized so that you don't have a graft thrombosis later on. And then you have to see the outcomes as well in the post-transplant time period. The urine output also for a small child post-transplant is almost to the tune of 10 liters a day. That's a huge urine output. So that also has to be adequately optimized. Subsequently, when we discharge this patient, is usually on a higher immunosuppression compared to adult counterparts. And secondly, you have to ensure that the compliance is taken care of. Because once the compliance is not there, in case the child misses a couple of drugs, definitely you'll have troubles later on. And then once this child becomes into that 18 and 20 age group, then transition to the adult care also has to be done. So it's not like you just leave the child, you also keep seeing, the adult nephrologist also keeps seeing. So this is a whole gamut that needs to be taken care of. And then they will require a lot of psychological support because of ups and downs. The financial support also has to be taken care of.
One more factor, that a child receiving a transplant at the age of less than 5, less than 10 or 11, less than 16, 17, there will be a catch-up growth, which normally is missed if they're on dialysis. You have a transplant, the child will have that spurt of growth, which again makes it very psychologically satisfying for everybody. He may not grow to the entire height, but he will definitely grow quite a lot. So I think that is also...
So basically we prefer doing the transplant in the pre-pubertal age group because the pubertal catch-up is maintained. So we have a child whom we did transplant almost say around about 15 years back. He was this much height and now he's 5'5". So that is the satisfaction that you get. Yeah.
Now Dr. Manas Kaldara, I don't know where he puts them, but he's got more feathers in his cap, right, than most of us put together. He has got tremendous work in bone marrow transplant and he's recognized internationally. I just want to know what are the indications which we have in India generally, and what is it that makes it different from solid organs, and what is our experience?
So bone marrow transplant is very different from solid organ transplant because first of all, the common myth is that it's a type of a surgery. It is not. So what you do is that you either do an autologous stem cell transplant or an allogenic stem cell transplant. What do you mean by autologous? So suppose, say, I have some form of a cancer, which is, say, lymphoma, and I want to kill that lymphoma. I can give only this much chemotherapy. If I have to give very, very high dose of chemotherapy, my own stem cells will be killed and I will become like an aplastic anemia patient. So what do? We harvest the stem cells from the donor, that is the patient himself, store them, give very high doses of chemotherapy. That high dose chemotherapy will kill the cancer, and then you put his own stem cells back. And this is an autologous stem cell transplant, so there is no surgery involved. We just take out the stem cells from the patient by a peripheral blood, like how you do a platelet donation, something like that. Now, the other type of transplant is an allogenic stem cell transplant. What is this? So suppose your own bone marrow or your own stem cells are diseased. So say diseases like thalassemia major, your bone marrow is gone. You know, you have thalassemia. You have immunodeficiency, primary immunodeficiency. You have bone marrow cancer, which is leukemia. So if you take your own stem cells, they will have that disease. So there is no point. So what you do is that you find a donor, which preferably is a matched brother or sister, HLA matched, not blood group matched, HLA matched donor. We give this patient high dose of chemotherapy or radiation, kill their bone marrow, and then put in a new graft from the brother or sister, and this fixes the problem. It's not as easy as it sounds. It's quite intense. This patient has to be in a single room, which is HEPA filtered, cannot meet anyone for 4 to 6 weeks. And you know, there are a whole lot of infections that a normal human being never gets. They get all those, say, adenovirus, CMV, all sorts of rare infections. So transplant is either allogenic, autologous, and depending on the disease, which is either a hematological, immune disease, or cancer, we use it for the patient.
Thank you. Now, we will go from here to what we are going to be doing very shortly. We are prepared for it. That is for lung transplant. And Dr. Roman Datta is going to tell us a bit about what are the patient selection criteria and what is the load of patients which we have got and what is our state of preparedness and how can the hospital support you further.
So, thank you for giving me the opportunity to speak on this forum. At our SGRAs, the management has recently created a lung transplant facility using the existing clinical expertise which is available in-house, like thoracic surgery, cardiology, pulmonary medicine, anesthesiology department, critical care department, and physiotherapy department, and all the allied branches which are available under the roof. And they are all aligned and prepared to carry out our first lung transplantation procedures at our center. At administrative level, our hospital has done a memorandum of understanding with an external lung transplant surgery facility, which is a high-volume center from Hyderabad. And they are prepared to handhold us during the first few surgeries and so that they can go an event-free way. That is what we are doing. And lots of people from our hospital has also been trained as an observership in their facility. And they are all geared up and prepared to do the first lung transplant at our facility very soon. So from the clinical expertise from the side, and we have started our lung failure clinic, where we are identifying the patients who are suitable for lung transplantation in the near future. And whenever we get a patient with end-stage lung disease, then we refer the patient to our pulmonary department. They admit the patients and they evaluate for the suitability for lung transplantation as well as risk assessment. And once they are found to be suitable candidate, then they are notified according to the government and legal protocols that whatever is available with us. And right now we have around 3 patients who are waiting to have a lung transplant at our center. And to be honest, right now we have gone for a organ harvesting using our in-house facilities where a surgical team, pulmonary medicine team, our OT staffs, they all go and assess the lung in the nearby facilities, and if they are found to be suitable, then we'll harvest and we'll implant them into suitable patients very soon, sir.
So you're like a full-term pregnant lady waiting to deliver.
Sir.
Yeah?
So we are
eagerly waiting to
yes,
see
yes,
how you produce.
as we are all up in arms. All the departments are eager to do the first lung transplant in
All the
near
best to
future.
you.
Thank
Now
you.
from there we go to the heart. Dr. Sujata Shawney was the first person outside the government in northern India to put in a heart. And I would like to ask you your difficulties in convincing people to have heart transplant and what are the experiences you had and what is your achievement, where would you like this to go?
As to the achievements, we have had an initial period when we did a lot of transplants. We did 5 transplants in a matter of about 4 years. And then came a sudden cessation of activity. And thereafter, we've just had 1 more transplant recently and 2 more referrals. So initially, there was a lot of excitement about doing the heart transplant. And then it so happened that while we started in Delhi and in Chennai together, the Chennai people were much more aggressive, and they were taking on borderline donors and borderline recipients. And I was a bit worried that this is such an expensive procedure that you should not be taking borderline hearts and borderline recipients. So there came a time when the Chennai group, it suddenly exploded, and that has gone to 100 patients a year, and we've lagged behind there. Second thing was that during this last 4-5 years, there were new medical treatments that came in. The medical treatments optimized a fair number of patients out of heart failure who were able to lead productive lives. And now we are again getting to see those patients who have had productive life for 4-5 years now failing those medical treatments and then requiring transplant. But this is a 5-year addition to a patient's quality life is actually a big thing. So whatever we did not harm too many patients in the beginning. It's a slightly more complicated work than living related, because there is limited time available during which you need to stop the heart in the donor, retrieve it, pack it, transfer it to our facility, implant it in the patient, and then get it working. So because that time is limited, you can't fly these organs from all around the country, and there's only local, regional transfers that you can achieve. So that is one big problem. Otherwise, we have not had a problem even after getting a 3-hour-long flight, 3.5-hour-long flight from Madurai for a very desperate patient. We did that, and we did not have any problem with
Green
that.
corridors set up by the police. They are very helpful. You can shoot across from the airport to the hospital in virtually no time. It goes faster than any VIP movement because they clear the roads in front of you very fast. And people have traveled in south also from one state to the other by road, and very good timings. So that's very good. Now I'm descending, you see, because when the cadaver is available, we go in all directions. You go from above downwards, and then we go to the liver. So Ushas, he is one of our sparkling and shining liver transplant surgeons. So I want to ask you, what is your current success rate? What is life after transplant, and what is the risk to the donor? Especially in India, we are doing a lot of live liver donations. So people don't talk much about the donor, but I think the life of the donor is also very important. So what is your current success rate, and what is life after transplant for a patient, and what is the risk to the donor?
So our current, we've over the last decade, the success rate in liver transplants overall has improved, but our current success rate at our institution with a good one graft allograft survival is over 90%. And in fact, last year, we'd like to share, we've had over a 95% success rate. The 5% mortality that we have faced is because these patients have been extremely sick, like Dr. Shad was saying, borderline recipients. We get a fair share of our patients who are extremely sick, high MELD scores, and very sarcopenic by the time they say yes and accept that they are transplant candidates. We try to optimize these patients to the best we can. Some don't give us a window, but some give us a window. To sum up, we've achieved over last year 95% success rate in living donor liver transplantation, and a close to 100% success rate in deceased donors, which we have done. Life after liver transplant, actually, the liver transplant recipients require way less immunosuppression than the other solid organ transplants like kidney. So within 3 months, our patients, more than 90% of these patients are off steroids. So we have an early corticosteroid withdrawal protocol at Gangaram Hospital. Within 90 days, most of all stop steroids, and they are on dual drug for first 2 years. And after 2 years, if they are doing well, they are on single tacrolimus-based immunosuppression. So within 3 months, most of them are back to their normal life, whether it is professional or social. There is a myth that they would be, enclosed in a room, or they won't be able to see relatives, they won't be able to go out. That's totally a myth. Most of these patients are going back professionally to their work, attending weddings, going to social occasions, whether it is temples or gurudwaras. They pretty much come back to what their life is. And in honor of these patients, in fact, a couple of years ago, under Sir's leadership, we had organized what is called Berok Zindagi, and we celebrated all these patients. And all of these patients performed. Some sang, some played guitar, and majority of did a ramp walk there. So it's very good. As far as risk to donor is concerned, at Gangaram Hospital, we are very, very careful about selecting our live donors. And we do not take any borderline live donor, and the overall risk rate that we tell the donors is less than 0.5%. Knock on the wood, we've had excellent donor outcomes at our institution, and we are proud of it. We, along with our hepatology team led by Dr. Arora, we don't compromise on any donor, whether it's a future liver remnant or any abnormal anatomy which may compromise donor safety. We have been very much sticking to our ethics.
Thank you very much. This is not part of the program, but Dr. Anil Arora has been spearheading a lot of the work for the immunology, for the care of the patients, for liver transplant. So I will ask him, what is your experience of the journey of transplantation, liver transplantation in Gangaram Hospital?
Yeah. I'm sure some of you who had been in Gangaram Hospital for many decades would recall the story. Dr. Ajay would recall when he was already in the management. I was a young hepatologist under Dr. Sama, who was the leading gastroenterologist at that time. Dr. Sama was incidentally the founder of gastroenterology. So we had a patient of Budd-Chiari syndrome with tense bulging ascites and number of collaterals and not passing urine. He required a liver transplantation. At that time in 1998, there was no liver transplantation which was being done in India. So as a young guy, as a young consultant, I was posted to go with them to send Cromwell Hospital in London to get a liver transplantation done. And this was an industrialist son, and we had a total money of around 2 crore Indian rupees, and we were told that that should be sufficient for liver transplant. And then once I got him admitted, he had a tense ascites. They will not drain him because they said, oh, we don't drain it, the ascites regularly to make him comfortable. He's waiting for his liver transplantation. The cost of, in 1998, sir, the cost of ultrasound in St. Cromwell Hospital was 700 British pounds, and the cost of the room stay was 2,000 pounds. So we exhausted all our money over the next 2 weeks. So since there was no hope of getting a cadaveric donor because we were outsiders for the British mainland, we had come from India. So we came back, and unfortunately, in spite of doing a TIPS procedure, we lost him. So that is what instigated us. That is what only propelled us to go in for our liver transplantation training. Fortunately, we had 2 young, bright surgeons from AIMS, Dr. Subhash Gupta and Arvind Soin, who had been in Indian cities trying to set up liver transplantation. So I was the first hepatologist who was sent to Birmingham by Subhash Gupta for training for liver transplantation. We came back, and thanks to our ever-encouraging team led by the management, especially Dr. Mahajan and Dr. Sama, we started doing liver transplantation. Being from hepatology, we had a huge clientele of patients with cirrhosis who needed transplantation. And then after Dr. Subhash Gupta, who had set up the preliminary program, we had Dr. Soin, who joined us from Apollo Hospital. And between 3 of us, we did around 10 consecutive transplantation. Now, there is a basic difference between liver and kidney transplantation. In kidney, you have to only attach an artery and a vein and a ureter. Liver is the most complex organism. It is almost 5 times the size of the kidney, and yet it has multiple inputs and multiple outputs. So technically it is far more demanding. But logically, immunologically, it is far more stable than kidney. That is the basic difference. So if you are able to overcome the technical factors, liver transplantation is something, is a rebirth given to you. Whereas problems occur in renal transplantation because of long-term immunosuppression. So first 10 consecutive patients we lost. In fact, we as hepatologist team thought कि अगर patient ऊपर गया है in OT, so means ऊपर ही गया. But that was a learning phase. And hats off to our committed team, Dr. Sama, Dr. Mahajan and the surgical team. We still persisted and our 11th patient was a success. So I conducted the first national conference on liver transplantation held as it come of age in this very Indian Habitat Center in the basement. And it was the first time we had everybody around in 2004. And after that, it is a success story. India is the biggest hub for LDLT program in the world after Korea. We are the biggest training center all over the world. But as Dr. Ajay said that we have been brewing distilleries, we have been maturing the saplings into the trees. So all our trained people, we have been exporting without imposing any tariffs like what Trump does to other cities. But fortunately, we have been able to establish a very good liver transplantation center. But problem is because of the constraints of the space, we have missed our stalwarts. But we have excellent trained people like Dr. Dheer and his team, and we are doing a good work. Thanks to you.
Thank you, Dr. Arora. Now from there to Dr. Sudhir Chadda, who's been with me for the past almost 3.5 decades. Transplantation, kidney transplantation in Gangaram Hospital was the vision of Dr. D.S. Rana, who was the first person to have the confidence to say that we will do transplant in a non-government institution in northern India. And I joined them very shortly after that. Then Dr. Bhalla came, then Sudhir joined, and we got going. Now, I would like Dr. Sudhir tell me about our journey over the last almost 4 decades. What you count as your achievements and what innovations we have put in there.
Thanks, sir, for inviting me, sir. As told by Dr. Johri, we started the program very early in the late 1980s. We were the first center in the country to start using external iliac artery as the main artery for the recipient. Before that, almost everybody was using internal iliac artery. I presented the series of 300 cases in UCCon 1993. And after that, we were using external iliac artery routinely in all the cases. We started transplants with the catgut, using catgut for the anastomosis for the doing ureteral hysterostomy. Almost every 4th patient used to have urine leaks. I used to sit there with the patients, seeing urine coming in the catheter or in the drain. After say around 3 or 4 years, we shifted to Vicryl, and almost all the urine leaks stopped. We were the first center in the country to routinely use double stents in the ureteral hysterostomy. Again, that helped us a lot. We were the first center in the country to accept diabetics and hepatitis B positive patients for the kidney transplantations. We have done roughly around 8,000 kidney transplants, and our success rate matches with the best in the world. Our success rate in the first year roughly 98 to 99%, 5 years 70 to 80%, 10 years 50 to 60% patients are alive and doing very well.
Thank you. Question, you have talked about the innovations and achievements, but at the same time, today you have taken, especially you, he had the confidence to stop using drains. He had the confidence to start doing laparoscopically the work, donor work, right? And now confidently taking the right side, which most people used to avoid, taking double vessels, multiple vessels. We've been using all of them where other hospitals used to refuse. And add to that, we also started taking on the ABO incompatible. Now, ABO incompatible is largely a medical issue. But when you start doing it surgically on high-risk patients, the first few patients, you are as much on tenterhooks as everybody else. If you have a mistake over there and you have a acute rejection on the table, you have got problems. So it was a high-risk affair, but today we are routinely doing at least 1 or 2 a week. So this is sustained effort over the years. And now we have come to a stage where I will talk to Dr. Vipin, who is now our star for robotic work, which was started when we were all doing together. I want to ask you, you are doing a whole lot of robotic work, and just recently you did some tele-robotic surgery, right? And you did a pyeloplasty or something like that?
Yes, sir.
Now, I want to know, how do you think there's going to be a scope for transplantation as associated with robots?
Sir,
or will there be?
Yeah, it is there because we are the pioneer in starting the transplant way back in 1980s, and we have responsibility to cut all the competition down, and we should become pioneer in all the things. And to become a comprehensive, we should avoid saying no to the recipients, and we should avoid to have as low complication as possible. So like in obese patients, the robotic kidney transplant offer a very distinct advantage, because in about 70 to 80% of the patients who are obese or morbidly obese, they are either denied a transplant in inexperienced centers, and when we used to do a transplant, we used to put a drain in subcutaneous plane, and we used to encounter a type of wound infection. So in those group of patients, the robotic kidney transplant offer a distinct advantages, and that's how we become, even that 1% of increasing the success in an institute like Gangaram will make a hell of a difference. So we have improved in leap and bounces in last 10, 15 years as far as the minimal invasive surgery is concerned, to increase the indication of doing the recipient surgeries and to increase the indication of doing minimal invasive surgeries for the donors. As you say, right side. We have not only taken the right side by open method, we are the biggest center globally who has taken the right side by laparoscopic way. So by using this all minimal invasive technology, we are increasing the indication for doing the transplant, and we are decreasing the morbidity to the recipient and as well as to the donors.
Thank you. So that brings me to the end of our distinguished panel's questions. Now I ask the distinguished audience if they would like to ask any question, then I will sum up. Yeah? Any questions from the audience, please?
Hardly less than 60,000 rupees. 60,000 rupees is the additional cost is hospital charges for the robot. There is no significant cost difference.
For liver?
You see, if you look at the success of liver transplantation, it is to the tune of about 80 to 90% in 1 year, 70% to at the age of 5 years, and up to the 60 to 70% after 10 years. Problem is, 50% of the patients develop complication related to immunosuppression. As I said, of all the organs, which I think most of the elite panel has already discussed, most least immunogenic and most immunotolerogenic organism is the liver. Problem occurs because of the continuing suppression. As Dr. Dheer very rightly mentioned, that after 5 years you have minimal immunosuppression. So if you are able to pull on for the first year and then subsequently for the first 5 years without the metabolic syndrome occurring as a side effect of immunosuppression, you have a practically normal life. Yes, we have an experience. I think Dr. Dheer has the data, because a lot of these patients have an underlying etiology of metabolic syndrome, MASH, MESL, and diabetic, which affects both the things, kidney and the liver. And we have been doing combined liver and kidney transplantation, and Dr. Dheer can just tell us about his experience.
A very good question. Actually, we have one of the largest series of combined liver kidney transplantation in all ways, whether it is a combined deceased donor liver and a deceased donor kidney. We've done a combined live donor liver and a live donor kidney. We just did recently, and the patient was discharged in 14 days. As Dr. Khanna was saying, that these patients may make around 10 liters of urine, And I want to share the recent combined liver kidney transplant that we did. Me and Dr. Vipin is also here. And we are missing Dr. Malik. He was a nephrologist. So he made 21 liters of urine overnight when he was totally anuric prior to it. So the patient was very happy to see that he's making urine now after almost 3 years. So, and we have also done something very unique, is that we have done live donor liver and deceased donor kidney and a vice versa as well. And the success rate of combined liver kidney transplant is approximately 70% in our institution, which is comparable to international standards. The reason being they are very sarcopenic patients and they have dual organ dysfunction, so they're very weak. They are on maintenance hemodialysis. And we are very proud to have a very, very strong hepatology and a nephrology team to support us in the preoperative optimization and postoperative care. These patients generally behave like a liver transplant patient because, again, when we have liver along with them, it's a very immunologically forgiving organ. So their immunosuppression is quite less and the outcome is very good. And if you were to see the transformative pictures in the journey, within 3 months you cannot recognize these patients. They're doing so well. It is exhaustive because we need 2 donors and we do not take both the organs. This is a very common question which people ask me. Can we take liver, half liver and a kidney from the same donor? No, we, as a Gangaram institutional policy, we do not stress the donors. We like to have 2 donors, and that's the most logistically difficult scenario.
Thank you. So, if there are no further questions, I will just, sir, I cannot deny you. Sir, all cadavers are potential hand donors. But unfortunately, it takes a lot of effort and a lot of, it's a leap of faith for the family also. There is reluctance, but it's moving. So I'll take that question forward by saying that the ministry and NATO, that's National Organ Tissue and Transplant Organization, and the National Organ Transplant Program, of which I'm one of the whatever. So we are pushing at every meeting that there should be combined, there should be commitment, that people should make donor pledges and try to get awareness, a lot of meetings. But one of the things which has come out from our conversation here, that in Gangaram Hospital, every single known transplant is being done. What we do require is a much more concerted meeting with the ministry and with the authorities. Maybe we should have a separate symposium. Right? The hospital will be only too happy. The ministry will be only too happy. So we should bring that forward so that the other lesser known transplants also come up in, that's one. Second thing is, I will just say that the hospital in no way has ever let us down. We were the first institution in the country to be declared a center of excellence for transplantation. And it has just gone on and on and on and gone to other departments. So we continue to be a center of excellence. Most important is, why do we do the transplant? To give a better quality of life. Yeah, we're not talking about just giving life. And I just want to say, to take what Dr. Dheer said forward, last year there were World Transplant Games in Germany. We had 53 patients who were heart, lung, kidney, liver transplants. Came back with 63 gold medals. Our entire Olympic team till now has never got it. And they were running 5,000 meters, squash, badminton, javelin, high jump, long jump, you name it. And the one who won gold medal was having a liver transplant and winning gold. So the quality of life is unimaginable. I have got at least 70 to 80 men who after transplants have become fathers of normal children. We have got women, at least 22 women, after transplants have become mothers. So this is the quality of life we want to give. Length of life nobody can guarantee. I can't guarantee my own. But quality of life. So it is all there to be done. So thank you very much for a patient hearing and a round of applause for our Thank you.
लग गया?
Good afternoon. Our next session brings a vascular surgery perspective to conditions frequently encountered in clinical practice. Dr. Ajay Yadav will discuss clinical insights, emphasizes early identification, referral, and involving management strategies that can significantly influence outcomes. The chairperson for this session is Dr. Sandeep Agarwal. Sir, I would like to request you to join us on stage.
Hello, Dr. Anil Agarwal. We have IMA President Central Delhi. He wants to just share one thought. Please, sir, I request you. एक second. आइए sir. Dr. Anil Agarwal. Just 1 minute.
Thank you for inviting me, and I am privileged. I am happy for last so many years I am coming and being a witness of the conference. So it is a regular feature. So I am really happy to see such large gathering, and I am one of the part of this gathering. Thank you and good wishes.
Thank you, sir. Thank you, sir. Dr. Ajay, over to you.
Thank you very much. So I'll be talking about something that we all see in our practice, but fortunately the treatments are changing, and I think a lot of things have changed, and I'll try and go through some of it. So we start with the history of a case where a 57-year-old gentleman travels from Paris to Delhi, economy, window class, standard, but we like, complains of left calf pain, swelling on landing, has breathlessness by the time he reaches home, and is rushed to hospital with severe breathlessness. So he comes to our casualty with severe breathlessness. We get it quickly an echo done. Fortunately, we have a 24-hour duplex facility in the hospital, so within minutes we can get a duplex done for you for the lower limbs. So we had a left iliofemoral popliteal DVT, and an echo also had done at the same time showed massive RA-RV dilatation. So this is a classical sign of pulmonary embolism. So if we talk about this, this is classic economy class syndrome, where one air passenger, especially because he's sitting in a constricted seat, a long flight, probably had a drink or two, it's dehydrated, develops deep vein thrombosis. So I think more important for elderly group of patients or for patients who have had previous history of DVT, they need to stretch and walk more regularly. So and probably an aisle seat is preferred. And always keep doing your calf muscle exercises. So keep moving your toes, wriggling your toes. And this is something that we forget. So air embolism, or I would say economy class syndrome because of air travel, is seen, and it is frequent. And mind you, if you go through the magazines which airlines provide, in last 5 or 6 pages, 1 page is dedicated to actually DVT prevention. We don't read that. We probably end up using just the advertisements part of it. So autopsy data from PGI also has corroborated that around 14% of all hospital deaths or certain cardiac deaths or that we attributed to were actually VTE. So we take up this patient quickly into our cath lab, and we find that there's a massive DVT. So we have a special machine, which is an AI operated machine, a computer assisted device, where we can quickly put in, it basically go into the pulmonary artery, You can suck out the clot, you can see the amount of clot which comes out, and immediately the patient's saturation starts improving. That's how you collect clot. So huge amount of clots cleared from the pulmonary artery. There's immediate relief in breathlessness. Mind you, this is being done while the patient is awake. It's done under local anesthesia. The vital stabilizer echo next day, the PSP is 35. So you can averted a major tragedy within minutes of patient reaching the hospital. So I think this is what is important, that pulmonary embolism no longer means death. It means that we can salvage this patient and give them their life back. And this is something which I'm going to reiterate today. So that's the kind of clot the patient had, huge clots in the pulmonary artery. And once we are able to suck them out, the patients immediately improve. The level of breathlessness or the cor pulmonale or the right heart pressure changes that they get with such severe PE actually absolutely disappear. So these are the usual symptoms of DVT, and I think we have all gone through these slides earlier and understood that pain in the legs, swelling, and probably pulmonary embolism is something that we dread, which is usually by dyspnea, severe chest pain, coughing, or even hemoptysis. If you go for examination, they have a low pulmonary artery pressures, they have a tachycardia, tachypnea. On echo, there are right heart strains, there are classic ECG changes, and I think we are all aware of this. But I think more important is, once you see any of these, how do we treat them, and where do we get them sorted? I think the aim today is, and I think all studies today have very clearly indicated that all clots in the body, wherever they are, whether it is deep vein thrombosis or whether it is pulmonary embolism, need to be taken out. And we have special devices. So I think I'll see if we can have some. So yeah. So this is a special suction machine. You can hear the voice, and it clears a clot like that. Within 3 minutes, you can probably clear the whole of femoral vein. Another 5 minutes to clear the iliac vein, and in probably 10 minutes, you can clear up the whole of IVC. So you can clear up the whole iliofemoral system within 10 to 15 minutes, and that's life-saving. You don't need to do it under anesthesia. You can do it under just local anesthesia. So this is the main technology there. It's a computer-assisted system. It's got an AI which basically opens. There's a valve which opens when you're aspirating thrombus, but it closes as soon as you're aspirating blood. So imagine putting a tube, which is practically the thickness of my finger, into your veins, but the problem is it's going to suck blood. And if it sucks blood, that kind of blood is probably suck around maybe 500 ml of blood in a minute. But this computer-assisted system actually blocks as soon as you're sucking blood, but will only suck when you are aspirating clot. And that's the AI part of it, which makes it work. So the actual blood loss reduces by 70%. So it is designed for clot detection. And this is how you see it. You see that valve opening in milliseconds for just sucking the clot. And as soon as you get water or saline or blood, it stops sucking at all. So you can reduce the blood loss by 18 times and makes a patient safe. So another case, another young lady, army officer posted at high altitude, comes back with massive swelling, and usually in high altitude thrombosis. We managed with low molecular heparin. The symptoms didn't improve, so came to us. So we did the similar device. So this is punctured around the knee area. You get a catheter in. You start sucking the catheter through the catheter. That's a penumbra catheter again. And once you start doing it, you see that the clots have improved. You can remove more and more clots through it. You make multiple passes. If you look at that slide, you can see the catheter actually engaging those clots and sucking it. You can see the clot moving with the catheter. And the multiple passes like this, you can actually remove most of the clots. And within 5 minutes, you can get a clear vein. The patient actually had something called May-Thurner syndrome, where there's an occlusion of the left iliac vein by the artery. We can do a balloon plasty, put a stent there if needed. And that's the final result, a clean vein. So imagine an army officer with an obstructed system. She can't go back to active duty. But with this, she can do any kind of activity she wants. So that's the kind of clots we removed. And this can be done even for iliac system, for IVC. So these are the new cath labs we have in Gangaram Hospital, which we fortunately can do such complex cases. So in the end, I would say, is DVT still there? And I think the myth was that India doesn't have DVT patients, but that's wrong. We are probably underreporting. We are not catching them as frequently as we should. The hospitals need to be more careful. I think as GPs or as physicians, we need to be more careful on understanding that blood clots can be dangerous, and we need to treat them as much as we can. They tend to have an iceberg effect. We see much or maybe treat much less, but we miss out on a lot more. Please be more vigilant in getting a good Doppler done, getting an echo done, or a CT pulmonary angiography to diagnose these things, and we get them treated early. So our take-home message would be a early thrombus removal strategies which is working. We need to have an open vein hypothesis, so remove clots but reduce blood loss. And computer-assisted venous thrombectomy is probably the new thing to go for. Thank you very much.
Thank you, Dr. Ajay, very beautifully shown both the cases. The DVT is a very dreaded situation. Sometimes it is mistaken as a massive heart attack. And as Dr. Ajay told, I remember 30 years back when I started my practice, our first slide used to be in our talk, the DVT. Is it a myth or reality? Everybody thought that it is a disease of the Western country. But daily we see at our center in Gangaram Hospital 8 to 10 new cases. Every patient is not put for these fancy treatments. Many patients, they are put on the anticoagulation, but when the patient, they are having the massive DVT, just not for today, for tomorrow, to preserve the wells of the deep veins, we do this. And obviously, if the patient is having acute P, then too it is a life-saving procedure. Dr. Ajay, I just want to know, everybody is now talking about artificial intelligence, this way, that way, assisted. What the artificial intelligence can do the harm of a professional, professionally, physically, financially? What do you think in the future?
Doctors will probably end up using a lot of these technologies to help diagnose patient better. We're going to be missing less diseases too. It will probably help us in making better drugs or getting drugs back from discovery to market quicker, hopefully. Treatment-wise, I think they will probably dictate at some time, but right now I think doctors still need to make their own clinical decisions.
Okay. Thank you. Any question from the house? Yes, one by one, please.
Sorry, sir? So I think thrombolysis has its own side effect because obviously you are giving thrombolytics, so the chances of bleeding are much higher. In clot suction, you are able to remove the bulk of the clot and you're getting a clean passage. But if you find that there are small clots in the smaller veins, you can give thrombolysis, but the duration of thrombolysis will decrease because without clot suction, the thrombolysis would have continued for at least 3 to 4 days. Then the risk of bleeding would be there for 3 to 4 days. Whereas in this, within 24 hours, all the clot is gone. Sir. So I think the treatment starts obviously with you because the correctly diagnosed and correctly timed diabetic treatment is what is important. So if you are able to diagnose and treat diabetes properly and also counsel the patient to look at the feet every day. And I think this is important because the patient as well as the family needs to understand that looking at the feet is more important than looking at their own face. And this is where we are lost. So treating them early, treating them well, and referring to a person who can actually manage these diabetic feet ulcers is the treatment.
In form of discoloration of the toes?
Yes, sir. So then get a Doppler done, and then maybe we do a angioplasty or surgery to improve the blood supply of the feet. Thank you very much, sir.
See, what you presented was a acute DVT. Somebody reaches Gangaram, that mile na mile, you don't know.
इनके लिए सबके लिए है सर. इनके लिए हमेशा मिलेगा.
But the question is, we land up with lot of cases which are chronic or acute or chronic. Okay, what do you do with those, especially even in pulmonary embolism? I recently came across, I got a call from the US. There is a relative who मैसिव पल्मोनरी एम्बोलिज्म था और अभी सडनली पेशेंट डिसैचुरेट कर गया, उसको घर भेज दिया गया था. आइडिया इज हाउ डू यू मैनेज दिस chronic cases? Can you do something besides anticoagulant?
Yes, sir.
Dr. Saab, I think your question is needs a demanding answer, which will take a long time, है ना? And because of the shortage of the time, I would like to request Dr. Ajay, है ना?
Thank you very much, sir. But this will work both in acute and subacute cases. It does work. Even in subacute cases, you can remove the clots. Yes, sir. Thank you very much.
Thank you. Thank you.
As we move on to the next session, there's a very interesting question. Do miracles happen in oncology? Do they really happen? Let's see. Cancer care has evolved remarkably through the years, and Dr. Aditya Sareen will take us through the thought-provoking session on unexpected outcomes and advances in oncology, highlighting how science, innovation, and timely care continue to redefine possibilities. For this session, we have Dr. Shyam Agarwal as our chairperson. I request you both to join us on stage.
Good afternoon to everyone. So switching gears from vascular to oncology, and the topic is really intriguing. And actually, we are seeing miracles today in medical oncology, although cancer remains a multidisciplinary approach. So we have now chemo, we have targeted drugs, we have immunotherapy, we have bone marrow transplants, we have antibody drug conjugates, you name it. There's so much happening in the field of oncology. And Aditya is going to show you a few cases and his experience in showing miracles.
So, good afternoon, everybody. And obviously, it's a post-lunch session. So, do you think cancer is increasing? Can I just see a show of hands? Do you feel that the incidence of cancer is increasing? It's a very simple yes or no. My God. So you just see, if this conference was happening 15 years back, I think hardly the hands would have been like 20%. But right now, I can see more than 80% of hand up in the air. So with cancer, the one thing, miracle has never been attached. So my job for the next so many minutes is going to make sure, and it's going to be a very thrilling ride for you. If you blink, you will lose their interest. So this is a disclaimer in the upfront setting. Okay, so let me just give you some brief examples. So we'll be starting with very simple case discussions. So I had a female, 48-year-old female, who presented with headache and visual symptoms. The headache was for 3 months and visual symptoms for 1 month. No complaints of any fever, bony pains, dyspnea, and on vital examination, she was fine. So she went to family doctor, who after taking more extensive history was found to have a pan-hypopituitarism, and for the same, she underwent biochemical and endocrine parameter analysis along with that MRI brain. Their MRI brain showed that there have been a contiguous extension of the lesion into the cavernous sinus, and there is a thickening of the pituitary stalk. So this all happened on 5th of July. So you see, destiny works in very different ways. I had no idea that I'll be standing here today, and these cases are very recent. So then the patient was referred to us in the medical oncology department, and I'll just give you the brief. We did the PET scan. PET scan showed CA lung, which was metastasized to both the livers, and it was in the brain. So it was metastatic CA lung in a young female. And if I were to show you the PET scan, you can see all these black spots. And here you can see the pituitary and a big lesion over here. Again, more lesions over here, lung lesion, then multiple liver lesions, all, classical metastatic CLR. So for us, the next step was to go and do the liver biopsy from the liver SOL. But you know what they did? Patient went to Canada. And they took off for the next 2 months. Acceptance might be an issue, but then again, they came back to me after 2 months in a complete panic mode. Well, obviously, patient was increasing in her, symptoms were increasing. And we had to do our PET scan and MRI. And obviously now time was of essence over here. So we have to do the FNAC and biopsy. So everything showed increase. The brain lesions increased, the lung lesions increased, mediastinal, liver, everything got increased. And in fact, now there was another lesion which was in adrenal. And MRI was also there, which showed mildly increase. Along with that, the symptoms. So we did the FNAC. FNAC showed to be carcinoma. Biopsy also turned out to be carcinoma. What we lost was time. I lost precious 2 months. And what the patient gained over those 2 months? symptoms. We got the best of the best NGS and we found this mutation, which is the RET fusion, and we started the patient. So we did both the solid and the liquid. We planned the patient for RT. The RT happened in our own department, and Dr. Hukul led that, and SBRT. So, only in 3 days, we were able to take away all our symptoms. And in the meantime, we imported this drug, which is sulpercatinib. It is not available in India. And in Jan 2026, we did the assessment. I will not read, I will just show you. All these black spots you can see, not visible now. The brain region was post-treatment, and within 3 months, it's gone. Again, this lesion, you can see it's gone. Lung lesion, gone. And mediastinal lesion, gone. All the yellowness is gone. And liver lesions, you can just appreciate that this yellow part was the pre-treatment, and now it's not there. So mind it, I have not even given any chemo, target, or hormone. I have just given targeted oral pills, and the liver lesion again has gone. More liver lesions gone. So this was something very classical, miracles. जो तो आपने डॉक्टर साहब एक टैबलेट दे दी, चलो और आगे देखते हैं. But what happens in the case too? So this is a 54-year-old female who presented with the neck lump, aggressive swelling, and within like 1 month, her neck was like elephant. And we were expecting some kind of a very dangerous malignancy of the thyroid, and we did the PET scan. I'll not go into the details in order to save time, but you can see the primary lesion was of left lobe of thyroid and extending into the superior mediastinum. So it was completely, you can see all this yellow component over here around the thyroid. This big was the tumor in the neck. So her neck was like an elephant leg. But then again, this was the only major part. You just focus on my cursor and you will be able to see the bulk at that point which I was dealing. We did the biopsy, turned out to be an anaplastic thyroid carcinoma. Well, I have been in this field for a very short time, but then again, it is ultra rare globally. It constitutes to less than 2% of the thyroid cancer, and Indian data is hardly 1% incidence. One of the deadliest tumor known, median survival is maybe 3 to 5 months. With the, stage 4 is the disease. If you diagnose any patient with anaplastic, it's stage 4. Then it is a chemotherapy resistant, slow and short-lived responses, and exceptionally uncommon. So we did the MRI neck. Obviously, I wanted to see whether you can do the biopsy or not. But then again, we started the treatment up front with paclitaxel, carbo, and Keytruda. And to my surprise, with the first dose of the immunotherapy, she landed up with one of the worst toxicity, that is Stevenson-Johnson syndrome. And you can just see how her face started to swell. This happened within like 7 days. Everything happened so fast that I had to admit her into a nearby ICU setup and had to use a brute force discussion with the team over there because they were not in sync with my thought process. But then again, our friendships, they take leaps and bounds. And I had to counsel the family that not to lose hope, even I am facing a certain death. But then again, we stabilize her, we give management, we settle the SJS, which is Stevenson-Johnson. So the guidelines say that if you have an SJS or any life-threatening complication post-immuno, you are not even supposed to even retouch the immunotherapy. But then again, I may be young, I am happy to do something for my patient. So we still continued pembrolizumab, but I tweaked the dose, and now you see the response after 3 months. So all this yellowness is gone. There is no yellow component in the neck. This all black part has gone away and patient is in CR. And obviously the next update of this patient I'll show you in the next conference. But then again, is it really enough? I still don't feel that you guys are convinced that in oncology miracles can happen. So I'll take you another one of the most interesting cases. So this is a 52-year-old female who presented with fever, weight loss. And on PET scan, I'll just show you, look at the liver disease. All the yellow spots in the liver. So technically there was no liver and it's a breast tumor to start with. And there is no normal liver left. You are seeing a certain patient in this bulky disease. It turned out to be a breast cancer with HER2/neu3+. So I asked the patient to undergo an MRI brain, but she landed up with, jerky movements. So patient was called back from the MRI department to my OPD, and by the time she reached my OPD, she was having a decreased urine output, 2 episodes of diarrhea, and there was some twitching around the legs. So I advised to, just admit and give supportive in the form of antibiotics, analgesics, and IV fluids. And her, urine output became nil, hypotension worsened. So see, any cancer patient, if you have, you can see that at the end of the day, it's a metastatic disease. Your patient is having nil urine output, and your AKI, your creatinine is 4.7, uric acid is 15. So everything became worse within the span of 2 days only. So for my working diagnosis, it was a metastatic breast cancer with acute kidney injury, with absolutely no urine whatsoever, and acute liver injury, anemia, hypotension. And this was when I just started my practice. So for me, it was whether to treat or not to treat. What about the role of palliative care? That was my thought process at that point of time. But relatives' thought process played a key role here. Dialysis once started, it will be continued, and it's already a stage 4 cancer patient. Husband refused for signatures. Will she even make it? And even if she makes it, is she going to have a troubled quality of life and will take the patient home as patient is having advanced stage cancer? Better to be amongst the family members. So, I had a detailed discussion with the family. Our team sat down. We took high-risk consent. We started the patient on dialysis. And their thought process was, Doc Sahab, aap yahan pe dialysis kara rahe ho, aur saath mein aap apna chemo bhi de rahe ho, target bhi de rahe ho. Well, that was at that point of time, thought process was like that. But yes, we did that. We went completely outside the realm of the guidelines in our textbook. We started with dialysis, chemo, and targeted therapy. Her parameters stabilized over time. And just see, in January 2023 and in March 2023, all the black spots are gone. All this yellowness is gone. All the yellow cancer spots are not visible now. The breast lesion is gone. And till today, patient has shown a near response. And I'll show you the last follow-up, which was done in September of 2025. There is absolutely no disease. So I had to take her for only 3 sessions of dialysis at that point of time. And that gamble paid her off. And I think she is on her 50th injection of the targeted therapy. She comes to my OPD, takes the injection and goes back. But then dialysis and chemotherapy and targeted therapy was at that point of time where every rule said no, we still said yes, and we took this patient out of the CREP. And last, I want to just show the targeted. There are so many targeted options. And my final case, the final case to convince you that yes, miracles can happen. So this is a young 35-year-old female where we have this mutation by the name of ALK in lung cancer. So just imagine, she was diagnosed at the age of 35, a stage 4 lung cancer. And you can see, अब इतना तो सबको पता चली गया है कि जो yellow spots दिख रहे हैं, ये cancer spots हैं. And all these black spots are like the spread of those cancer lesions. I'll take you fast forward. When she presented to us, she was completely bedbound, anxious family, taken 4 to 5 multiple opinions. Everybody said, start with chemo and immuno and give palliative RT because she was having severe backache and there was a bladder bowel involvement. She was having a weight of only 37 kgs, a complete lower limb paralysis because of the dorsal met which was there. So for me, it was whether to treat or not to treat. Then again, shall I just send her to a palliative care setting? And then came the relative thought process. It's a money-making business. Our profession is a money-making business. Doctors are there to just extract money. Will she even make it? And the same questions, she is going to have a troubled quality of life. And they had written opinions from Pan India to give chemo and immuno. And obviously for me, there was a lot of political pressure, which I came to know. I will take 2 more minutes. There was a lot of political pressure, and obviously patients do have some young consultant trust issues as well. But then again, I had to, just counsel them. I had to blur my own background noise. And we started with the best of the best, which is the chemo along with the targeted therapy, lorlatinib. And now just see the result. All these yellow spots of the liver are gone. I'll show you in a better picture. So all these yellow spots, the lung lesion, mediastinal, this is pre-treatment, this is post-treatment. Bone lesions, all gone. Brain lesions, gone. Just with 1 tablet and chemo. And she had an excellent response and she is still doing well under our care. So do miracles happen in oncology? I think powerful belief creates hope. Powerful evidence makes destiny bow. And powerful people make cases more successful. So in cancer, which is ruled by doubt, these cases didn't just survive, they proved that when science and doctor stands fearless, even the deadliest disease must step aside. So with this, I thank you.
Thank you, Aditya. I think he's just shown you 2 cases with targeted drugs, one with, ADC and one with immunotherapy. So we have more than 300 such molecules which are able to target more than 50 to 60 types of common cancers today. So I think all of us are doing the job. As the drugs improve, the quality improves, the numbers improve, the prognosis is getting better and better. So I think, is there any question from the audience there to answer? We're running short of time. Sanjay.
There is a small, something to say.
Yes.
And that is basically when Aditya came to me with this topic, do miracles happen in, the thing is, there were people who said, why miracles? It is his job, let him do it. And thank you, Aditya, you have reposed the faith, and it has been a wonderful presentation.
Thank you, sir.
Right. Great. So I think all the medical oncology has progressed a lot, and it is actually going to progress. And let me just say this one thing which is on my mind. The goalpost in the next few years is changing from imaging to ultra deep gene sequencing. So it's food for thought. I think go back and read. And with this, Aditya, thank you very much for this presentation and bringing us more hope and more strategy in treating patients with cancer. Thank you.
So this was truly an eye-opening session. And now as we move on, we start with another session called Organ Sparing with Radiotherapy, a Paradigm Shift. The speaker for this session is Dr. Deep Shankar Pruthi, and he'll discuss how organ-shaping approaches are improving outcomes while reducing long-term morbidity. Radiotherapy in itself has undergone a paradigm shift with increasing focus on precision and organ preservation. For this session, our chairperson is Dr. Huku. Please join us on stage. Dr. Shikha? Dr. Shikha? Ma'am, please join us on stage. Ma'am?
So, good afternoon. You heard about the miracles with, drugs. Cancer, as you know, is a multidisciplinary treatment. And many years ago, radiation was always considered as a palliative method of treatment. And whenever nothing could be done in cancer, the patient was referred to radiation. And it was supposed that radiation sab kuch jala dega. But over the years, you will listen to the lecture now, radiation has done a lot of changes in the management of cancer, and it has led to organ preservation in a big way, and the morbidity has really gone down. So modern radiation, which we are practicing today, will be presented by Dr. Deep.
Thank you, sir. Good evening, everyone. It's a privilege for me to be speaking in front of both of my seniors from the department. Curing cancer no longer means losing organs. Yes, this is one of the biggest shifts in modern oncology. Earlier, cure meant sacrifice. You will see a lot of ectomies being done for cancer. And survival actually came at a functional cost. Today, there is cure with preservation. Organ preservation and function is actually now a treatment endpoint for specific tumor sites for specific selection criteria. And radiotherapy sits at the heart of this shift. What is organ preservation? To achieve oncologic control while maintaining structure and function of the involved organ. Radiation therapy techniques have drastically improved over the last 30 years. It is not just radiotherapy, it is now precision medicine. Because we are able to see better with the help of newer imaging and better imaging like PET and MRI. So our radiation margins have become tighter. We are able to target better with image-guided radiotherapy, intensity modulated and motion management. So the side effects are less. And we are treating smarter because the number of sessions of radiotherapy are actually going down with hypofractionation stereotactic radiotherapy. So let me walk you through some examples of organ preservation. First, larynx and hypopharynx. For early stage tumors, there's radiation alone. And for advanced stage T3 and T4A select cases with a functional larynx, concurrent chemotherapy and radiotherapy is the treatment of choice. The oncological outcomes are comparable to surgery and patient avoids a stoma. For urinary bladder, So the treatment of choice is cystectomy, but then there is organ preservation approach, which has 3 components: maximal TURBT, which is the resection of the bladder tissue, chemotherapy and radiotherapy. This is known as tri-modality therapy. Again, specific indications for bladder preservation, and it is also can be used for patients who are unfit and refusing for surgery. See, the patient is avoiding a Eurobag. Anal canal, the earliest standard of treatment was APRs with permanent colostomies and loss of sphincter function. Now, definitive CTRT is the treatment of choice. Surgery is actually removed from the first line treatment. Even in rectal cancers, there's an evolving role of non-operative management, because after radiotherapy, if the patient has complete clinical response, there is an option of observation, and more data is coming up in this field. And of course, with immunotherapy, there is even some patients can avoid radiation and surgery. So with this, we are avoiding a stoma bag. So you see, the quality of life of the patient is maintained, the image is maintained. Now, the biggest shift has happened in breast cancer. Earlier, breast cancer meant removal of the chest, mastectomies. Now, there is breast conserving surgery in which only the lump is removed, and then we add radiotherapy. So the combination of BCS with radiotherapy is equivalent to mastectomy. That means patient gets to preserve the image with a better quality of life. Esophagus. So the treatment of choice is neoadjuvant chemotherapy, and then the patient goes for surgery. However, definitive CTRT can be offered for patients who are unfit for surgery. In fact, for cervical esophagus and upper thoracic esophagus, it is the treatment of choice and surgery is not done. Similarly, in cases like in rectum, if patient has had a complete clinical response, there is an option of follow-up, and more data is coming up in this way. Prostate. The age-old debate between surgeons and radiation oncologists, which is better. So for localized prostate cancer, whether it's low, intermediate, high risk, radiation plays a key role. And in high-risk cases, it is actually preferred. Equivalent cancer control to surgery. With the advent of stereotactic radiotherapy, the number of sessions have gone down. So from initial 40 sessions to 28 sessions to 20 sessions, now in select cases, you can actually treat in 5 sessions and even maybe lower. And that has led to more patient convenience and compliance. So what is this stereotactic radiotherapy? So it is high dose radiation with surgical accuracy. So imagine for select cases of cancer, radiation behaves like a non-invasive surgery. And there are multiple examples in brain tumors, benign cases, metastasis, malignant cases. For example, in AVMs, in vestibular schwannomas, in brain metastasis. You see, this is a classical case of a single brain metastasis treated with radiation, and the met has disappeared. You don't need to go under the knife every time. For lung metastasis, also similarly, you can see one case scenario in a peripheral lung metastasis after SBRT, the lesion has vanished. Similarly, for liver metastasis, HCC, portal vein thrombus, you name it, radiation has a role, and stereotactic radiotherapy has actually changed the game in this case. So organs move, and so does the tumor. So how are we able to manage this motion? We can either restrict the movement with the help of abdominal compression during the radiation planning. There is internal target volume approach, in which actually the CT scan is divided into multiple phases, and we draw our radiation volume in all the phases so that the tumor is moving and the target is also being treated. Or we can gate the treatment. By that I mean we can actually choose which phase of respiration we want to treat in. For example, end expiration, so the beam will only be on when the patient is exhaling. And there is also deep inspiratory breath hold, where patient is holding his or her breath and being treated, which actually is a classical case in left-sided breast cancer, in which we want to spare the heart. So organ sparing is incomplete without the mention of interstitial brachytherapy. This is radiation delivered from within the tumor, not externally. The maximal tumor dose is in the tumor, and the normal tissues are spared. For example, in head and neck carcinomas, in breast cancer, in soft tissue sarcomas, in recurrent cervical cancers, even in penile cancer. So you see, organ preservation from external to internal radiotherapy has multiple aspects to it. With this, I would like to introduce our Department of Radiation Oncology at Sir Gangaram Hospital. We have two state-of-the-art machines. One is TrueBeam STX with HyperArc. With sub-millimeter precision, we can actually treat tumors with accuracy finer than the grain of rice. A non-coplanar arc therapy, that means that radiation can be delivered from multiple angles. There is real-time image guidance in which the position is corrected before treatment. We can actually treat multiple lesions simultaneously, which means a single isocenter setup. And advanced motion management which tracks the tumor. So there is another radiation machine which we have in the department. It is called tomotherapy. This actually looks like a CT scan to me, but it is a radiation therapy machine. So how I am equating it, that CT scan takes images slice by slice, and tomotherapy treats the patient slice by slice. So it actually conforms to the slice of radiation, to slice of CT scan rather than the whole tumor. And the machine inside, the patient moves inside the machine and the radiation linear accelerator moves around it. This makes long and complex fields effortless. If TrueBeam is laser focused surgery, tomotherapy is precision painting, and we have the luxury of both these machines at our hospital. We also have brachytherapy, like I mentioned, an indispensable part of radiation oncology with the latest remote afterloaded microselectron HDR iridium 192 source. It has sub-millimeter accuracy, it is CT and MR compatible, it is multi-channel, and we can tackle all cases of brachytherapy, whether it's intracavitary, intraluminal, interstitial, all of them can be tackled very easily. And this is one of the pictures of a recurrent cervical cancer which we had done in our hospital. Now, what is your role? So, first of all, correct counseling, reducing fear. So, radiation can have so many aspects to it. And it is not just about it can burn the patient, it generates heat, or it has pain. No, there's nothing like it. These are X-rays used with millimeter precision for the treatment of cancer. And in fact, the organ can be spared. So your role is to reduce the fear in your patients and create this awareness. Help us create this awareness. And of course, an early referral will always have a better outcome. And with this, I thank you for your patient hearing. And this is a picture of our department, oncology. Thank you.
Thank you, Deep. As I can say, like nowadays, radiation is no more, precision radiation is no more aspirational. It is the standard care. And organ preservation really is an important area where we preserve the quality of life as well as cure. Basically, now the intention is not what is the highest tolerated dose. Now it is the most effective dose and what is the less harmful dose we can give to the critical areas. We have treated about 20 hepatocellular carcinoma with SBRT, which he had mentioned. And we have seen about, we have to still evaluate all of them. About 5 to 6 patients has complete response, that is completely the lesion is gone. And we have done about 5 patients with CS lung where surgery was not possible because of the medically unfit. The patient was medically unfit. And we have two of the patients who are in CR, 3 are still on follow-up because we need to assess them only after 3 months of treatment. So we need to assess them. They're still in, they'll come after 3 months to see the response. But at least out of the 5, 2 patients had a complete CR. So that is the radiation is just an outpatient treatment. There is no surgery. There is no, not much of a side effect as much, not general side effects. And so as I can say, like presently the precision radiation therapy and with this high technique we are achieving a cure, highly curable disease, high rates of cure along with chemotherapy and immunotherapy. Thank you all.
Any questions?
Thank you.
Thank you for such an enlightening session. And as we move ahead, we now have Dr. B.S. Vivek, who will update us on recent advances in cardiology. It is one of the fastest evolving specialties, and today's session will focus on what is relevant for early diagnosis and referral in primary care. For this session, our chairperson today is Dr. Ashwini Mehta. Sir, I request you to join us on the stage.
Good afternoon. Well, cardiology, as we all know, has taken rapid strides. Whether it is intervention cardiology, coronary artery disease management, or cardiomyopathies, cardiac transplants, and we at Gangaram are not far behind. To take you through this brief presentation, Dr. B.S. Vivek, who is a senior consultant in Department of Cardiology, and a very fine cardiologist. He has been doing a lot of pioneering work. In fact, in northern India, we look up to him when patients of cardiomyopathy come. He's doing a great job, and many patients who have been misdiagnosed, not been diagnosed anywhere in the country, have come here, and he's been able to pick up nuances and get them treated properly. So I would like to request him to share his thoughts about the recent advances.
So thank you so much for your kind words, Sir Dr. Ashwini. And this topic actually would require hours if I get to it. The newer advances in, how do I go down? Some help from the people, please. Yeah. So I'll just trying to summarize this extensive topic into 3 subparts. We're going to just look over certain newer cardiac drugs, newer cardiac non-invasive imaging methods available in our hospital, and the newer invasive cardiology techniques that we are following. There are a lot of drugs which have generated a lot of excitement. For path-breaking trials have come in the last couple of years, and we have been part of it. Dr. Ashwini Mehta and Dr. Sani have been pioneers in research. A lot of these international studies have involved our patients too. Now, amongst the newer drugs, let me just start with Finrenone. Now, Finrenone, these are the 5-6 drugs that I'll be just touching briefly. Finrenone actually is that potassium-sparing diuretic group. It is the MRA which does not have steroids in it, and therefore the side effects are much less. Now, Finrenone was studied first in the subgroup of patients who had CKD and diabetes. That did not actually excite us as much as the publication of Fine Heart's heart failure study did. This was a study in which those patients who have very little that medicine can offer, that is ejection fraction more than 40%, the mildly reduced and the preserved ejection fraction group. This was a drug which showed a significant benefit. We have been trying to look for answers for this group of patients, and a lot of drugs have been tried in HFpEF people, but nothing has worked much. This was one of a very extensively studied drug and a trial which has shown a huge benefit, so much so not now. After the SGLT2 inhibitors, most of the guidelines are recommending Finrenone as the drug of choice. The inclisiran, again, another drug where Dr. Ashwini Mehta and our hospital have been a part of research. And I'll not go into the details. We have amongst the other non-statin drugs, the technologies that are being followed worldwide, inclisiran stands out because it acts at a level of the RNA. And it is not the monoclonal antibody that have been in use for the last decade or so. The regimen is simple. Day 1, the second dose at 3 months, and then 6 monthly intervals. This basically a difference between the monoclonal antibodies that have been used widely to be given every 14 days, and this is the one which needs only maybe a biannual sort of a subcutaneous injection. There are a lot of trials that have gone behind inclisiran before it has now been approved all over the globe, including India. And again, significant LDL reduction. Now, these are the resistant LDLs which have not been brought down by any of the drugs that are known, the high-dose statins, everything. And and so much so that in our guideline, the Indian guidelines context also, if the statins, ezetimibe and bempedoic acid have failed to keep the LDL levels to the desired level of less than 55 milligram per deciliter, this is where the PCSK9 inhibitors or the inclisiran is indicated. This is the group in which stable CAD, again, once we have exhausted all the drugs that are known, the hydrostatins, the bempedoic acid and ezetimibe. And now the third drug, which I will just briefly touch on, is the mavacamten, which is again a path-breaking drug. We had nothing to offer to people who suffer from obstructive HCM other than beta blockers, which do not really have any clinical evidence behind them. And this is another drug of its kind, which actually targets the basic disease. So mavacamten is now in India. It has been approved a couple of years back in US in 22 and 23 in European countries, but Indian reach was not there. And this actually targets the active myosin bridging, which is the basic pathophysiology of obstructive HCM. And this is a group which is often missed in our clinical practice. And once we do have patients who have been diagnosed, yet we have very little to offer. Beta blockers and calcium channel blockers many times do not work because they are not targeting the disease per se, but they are only trying to mitigate the physiological effects of this disease. These two trials have the landmark trials, the Explorer HCM, which came first in lesser sick patients, and the Valor HCM. Valor HCM is of particular should be noticed because this is the group where all these patients who are actually going for the septal reduction therapies, that is myectomy, which is again very rare in our country, and they had they had gone into class 3 despite the known beta blockers and calcium channel blockers being given, and 83% of such patients could be saved from going through any of these extensive procedures. So again, amongst the HOOKM, the hypertrophic obstructive cardiomyopathy patients, this has at this moment to be prescribed in patients who have had a trial of beta blockers, but soon in no time we'll have this as a class 1 agent for obstructive HCM. A very effective drug, brings down within 4 to 6 weeks, brings down the obstructive gradients from as far as 75, 80, which was in Explorer HCM, to less than 25. This is it requires a lot of, in the first couple of weeks, 4-week, 8-week, and 12-week, there'll be 3 echoes done to look for a possible side effect of lowering of ejection fraction less than 50%, which may happen in about less than 5% people. Usually the patients who do have a fall in EF are the ones who do so in less than 12 weeks. And we are cautious in the first 12 weeks, so we do every 4 weeks an echo to see whether there has been a fall in ejection fraction. If it isn't, then we go up on the doses, and we go up to 5 to 10 to 15. Semaglutide is a drug which is now in the masses, in the social media everywhere. Everyone is excited about it. This, again, our institute has been fortunate, again under the auspices of Dr. Ashwini and others, that there were a lot of participants from India in this huge select cardiovascular outcome trial. Cannot go into the detail of it. It is just to be remembered that these are patients in select who were obese and who had an established CVD. So this drug showed a lot of benefit. The MACE reduced by 20%, and this was the first anti-obesity medication with proven MACE reduction in people with overweight, obesity, and CVD, even without diabetes. So lots of trials. The bottom line is that this again is a drug which should be prescribed more than it is being used at this moment. A lot of people deserve the benefit of this drug, and they're being denied that because of misconceptions. Tirzepatide is another group in this, the combined the GLP, GIP one. A lot of evidence behind it. CV outcomes are still being studied. It has also a very exciting future. Basically, it's more for diabetes and the the obesity lowering, that it is better than, superior to semaglutide in that aspect. So again, there are trials now which are studying the outcome, CV outcome 2, and it is quite an exciting treatment by itself. Tafamidis, an entity which was almost forgotten, that is another place where our institute has had the most number of patients and publications, in which we are missing amyloidosis, and tafamidis is one drug which is life-saving in this. Again, prior to tafamidis, we had no drug to offer to patients with cardiac amyloidosis, and it is available in our country, a little expensive, but then again, the diagnostic and the therapeutic part needs to be spread amongst the doctors before going to the masses. So this is a TTR stabilizer, again, not going to the Verisuguat is the 5th pillar that is now being called for patients with HFrEF. Victoria, there are lots of trials. I'll just skip through the data. It's basically now being used in patients as the 5th drug over and above after the 4 drugs have been trialed, but people are doing it right at the outset. So the non-invasive imaging methods, the GLS that is now being a part of our usual workup in a patient who comes with any suspicion of a cardiomyopathy. This is a technique which can easily pick up a lot of diseases that were being missed earlier, cardiac amyloid being one of them. It is also can be fruitful in chemotherapy-based earlier detection of patients who are having lower ejection fraction. Again, CT coronary angiography is being extensively done these days. The calcium score and the angiogram itself are now well established. We are offering a good cardiac MRI evaluation, and this, along with the non-invasive cardiology methods, is proving beneficial for the accurate diagnosis of a lot of patients who are going about undiagnosed or misdiagnosed. Quickly going through the cath lab things that we are doing. We're doing all possible technologies that are available globally, and we have OCT guided the treatment, the IVUS, the intravascular imaging is being extensively used. One of the widest applications has been in our hospital across the North India, and the scoring, and so basically the devices which are there to actually get over calcium. Now, the calcium is our biggest enemy in the cath lab. This can cause a lot of havoc in the lab, and it's very resistant to treatment. But there are certain modalities across the globe now which are being used in our center also. Rotational atherectomy was age-old, but now we have lithotripsies, lasers, and all sort of equipments available to deal with this situation. We have a physiological guided management of lesions which are intermediate and which are visually not, we really don't know whether they are significant or not. And we have the CFR now is being, again, one of the only few centers in the country which is doing coronary flow reserve. We have recently acquired this system which looks at the intravascular, the myocardial, we have all these lesions that I just talked of, and the calcium debulking, the ones that I just described. Last 30 seconds, if you can let me be, please. And that is the structural heart things that we're doing, transcutaneous valve procedures for aortic valve, TAVR. We are doing almost 6 to 7 or even more in a particular month per month. This actually is a boon to people who are not fit for surgery, and the lesser used, but again applicable, is the transcutaneous mitral valve repair. Thank you.
Thank you, Vivek, for summarizing such a vast topic. Well, I'd like to just summarize and tell you that today at Gangaram, in the last 20 years, we have come really a big far way. If I tell you, like we started with a very humble beginnings, and we had just non-invasive setup in the beginning 25 years back. We started with a cath lab about 26 years back, And now, today we are able to offer one of the state-of-the-art therapies, be it valve replacements, be it coronary interventions, be it cardiomyopathy. And that's not all. In fact, we've been part of various path-breaking international trials, and a lot of our investigators are national leads. In this short span, you have nicely shown various techniques, which I'm sure some of them, a brief idea would have been there with most of the people. But if there are any questions, we'd be very happy, and Dr. Vivek would be happy to answer that. Later? Okay. So I think for the sake of time, we've been instructed to take this question answer later.
We request all the audience members that they can ask their questions outside over tea. Chai pe charcha kariye. And as we move on to the next session, that is by Dr. Rajat Chopra, who's going to talk about a new era in management of avascular necrosis of the femoral head. The chairperson is Dr. Sarabjit Singh. Sir, please welcome on stage.
These are two big men of Gangaram Hospital.
Hello. Good afternoon, ladies and gentlemen. Today we are going to talk about avascular necrosis of femoral head, meaning that where we lose the vascularity of the femoral head, leading to a spontaneous onset of pain in young individuals, usually because of binge drinking, or after, as post-COVID we have seen, maybe because of steroid use. Traditionally, we have been doing core decompressions, fibular grafting, and in recent times, we had tried doing plasma, stem cell, and for the first time, the new technology which has come in, that we have been able to isolate osteoblasts, which are impregnated in the target lesion, that is a bone, after we do the decompression. My colleague and my dear friend, Dr. Rajat Chopra, is going to put some light on this.
Thank you, Dr. Sarabjit. Namaskar, everyone. I am Dr. Rajat Chopra. I am one of the senior consultants in orthopedics in Gangaram Hospital. So I'll be giving you a little bit of insight on the management of avascular necrosis and what new can be done for this problem, which has been going on for a very long time. So what is avascular necrosis? As the term suggests, avascular, that means the blood supply is compromised, and necrosis is cell death. So the compromised blood supply leading to cell death. So what happens is that because there is no blood supply to the femoral head, the cells over there, the osteoblasts, the osteocytes, they are dying. So because of that, there is a space, there is going to be a subchondral collapse, and which will lead eventually to arthritis of the hip joint. It is affecting the younger population of our country, so that's why it's important, and the management is also, that's why, tricky. So if we look at the epidemiology of avascular necrosis, around 10,000 to 20,000 cases a year, but in our country, I think the incidence is more, and the common causes are steroid, which is being misused in our country a lot, and alcohol abuse. Trauma, yes, definitely, it will lead to avascular necrosis, post-traumatic arthritis, and we have seen recently a lot of cases because of steroid use as a lifesaver during COVID. And in terms of investigations, there is no good medical, you can say blood test, which can pick up avascular necrosis of the hip joint. So the X-rays in early stages are going to be normal, so we have to depend on MRI. MRI is going to pick it up early, and the classification of the disease and the treatment is also based on the MRI findings. Management challenges. So as I said, that this is going to affect the younger population more, so and the treatment modalities that we have are not that great, except total hip replacement. So I'll just go through it. There is no medical management. There is no medicine or a drug that we can give and say that we can cure avascular necrosis. Unfortunately, we don't have it right now, but in near future, if we get it, that would be great. So in early diseases, in early condition, when the patient presents to us and we are able to pick it up in grade 1, I think co-decompression helps. But if we find the case which has presented to us a little bit late, then total hip replacement is the treatment of choice. That's the gold standard. But limitation of co-decompression is that it is going to reduce the intraosseous pressure. So that helps in the pain relief in that patient, but it does not address the cellular deficit that has happened because of the necrosis, the cell death. And that's why it has got a high failure rate, and most of the patients after co-decompression end up getting a total hip replacement done. So why total hip replacement? And if it is a good choice, then why do we need more management modalities? It's a very good surgery. It works very well in avascular necrosis of the hip joint. Total hip replacement will give you a good 20-25 years that you can walk pain-free, do your routine day-to-day activities, but it is not the treatment of choice in a younger individual. As I say, because total hip replacement will give you, let's say, 20 years. So after 20 years, you have to revise. The implant fails. So you have to revise. You have to put a new prosthesis in. So that may give you another 10-15 years. So if you are doing a total hip replacement in a 20-year-old, at stage 40, at the age of 40, you have to do another surgery. At stage 50, or maybe 55, you have to do another surgery. So by the time the patient is 60 or 65, they may end up in a wheelchair. So doing a total hip early is not a good option. So that's why people are looking into other modalities and orthobiologics like putting PRP, other things, so that we can postpone the total hip replacement. So that's the reason that orthobiologics have come into action, because co-decompression on its own alone is not enough. So when you are doing co-decompression, if you can do something more to rejuvenate the cells, the dead cells, that will be more helpful. So that's the reason that orthobiologics have come. And they should be trying to solve the problem. The pathology is osteocytes death, reduction in the number of osteocytes, and the impaired stem cell differentiation. So this is the modality that we are using in our hospital now. It's known as ALCO, autologous adult live cultured osteoblast. So this, the ALCO is basically trying to replace what is missing. And it is a precise treatment, and we have a standardized dose of what we can inject into it. And it's the patient's own mesenchymal cells that are grown and into matured osteoblasts and which are put into the target area. So the procedure comprises of 2 stages. So in stage 1, the patient has to be admitted into a hospital and under local anesthetic or maybe under GA or short GA, that you take and aspirate around 10 cc of bone marrow from iliac crest. So the 10 cc you inject, you take it out, and then that 10 cc is given to the agent, which has come. We are doing this. We are doing this with the help of a company which is known as Regrow Biosciences. It's an FDA-approved company, and they basically take the bone marrow aspirate with them. They have set up an plant in Lonavala in Maharashtra. So the cells, the aspirate, bone marrow aspirate, will be transferred from Delhi to Lonavala, and over there they will try to grow the osteocytes from those mesenchymal cells. So they go through 2 or 3 cell culture lines, and then the osteocytes are left, and then they grow it. These osteocytes, once they have achieved 48 million to 50 million level, then they are detached from that level. So that will take around 3 to 4 weeks. So after 3 to 4 weeks, you readmit the patient, and then you do co-decompression. So this is the stage 1, which is harvesting of osteoblast. And in stage 2, the patient is readmitted, and then we do co-decompression. And that time when we are doing co-decompression, the 48 to 50 million cells, the osteoblasts that we have got, they are detached a day before from Maharashtra, and then they are flown to Delhi, and then the next day we do the procedure. So we are doing co-decompression. We know where the lesion is, where there is a gap, where there is cell which are vacant. So we curate it, we clean it, and then we put these cells, around 48 to 50 million cells, into that area along with the setting material. So then you have to wait for 5 to 7 minutes. It sets over there, and hopefully that should do the trick. So post-surgery, we keep the patient non-weight bearing or partially weight bearing for 4 weeks, and after that they can start walking with the help of a stick, and eventually they can give up the stick, and we follow them up every 3 months. So how does this procedure works? So basically, we are trying to replenish the depleted osteoblast population, enhancing bone regeneration with a known precise cell dose of around 48 to 50 million, using autologous cells, ensuring safety and biological compatibility, integrating effectively with local immature bone, and benefiting from the decompression-induced hematoma scaffold. And yes, the company which is helping us to grow the cells is keeping all the data of all the cases that have been done so far in India. And we have got a mean follow-up of around 3.5 years now. And around 319 cases have been done so far in India. And with the 3.5 years follow-up, less than 10% of these cases have gone for a total hip replacement. So that suggests that there is a slowing in disease progression and prolonged joint preservation. And an ideal condition to do this procedure would be a young individual with early stage avascular necrosis, and the femoral head is preserved. So if the femoral head is deformed and then there are changes like hip arthritis changes, then there is no point doing this. Then the best thing would be to do a total hip replacement. We are wasting our money on this. And in our experience, we have started doing this procedure in our hospital, and our results initially are encouraging. Mainly the doctors are coming to us to get this procedure done because they are aware of this procedure. They feel they don't want to go in for a total hip replacement. They are young individuals, young, active, and they would like to have their hip preserved. So they are coming for this procedure more than the normal population. And in conclusion, I would like to say AVN can be classified as a cell-deficient disease, and core decompression along with ELCO helps us to address biology, promote regeneration, preserve femoral head, and it's a promising step. Thank you.
The whole idea is to salvage a dying hip. No young individual wants his hip to be replaced. And if we are replacing a hip, so we are making sure that this guy is going to come back again and again to us till he lives, eventually landing up a wheelchair till the point when the hip replacement revision surgery is not possible. Any questions? The keynote is that we physicians, surgeons are sitting over here. Most of the time, we are getting, patient with a complaint of spontaneous onset of pain, a vague pain, right? Which you end up saying, okay, you take some Prosin or paracetamol or any anti-inflammatory drug. The thing is, for the surgeons or physicians, restrictions of internal rotation, especially, and external rotation in a young individual or a person who you've been known that he's been taking some drugs, that should arouse your suspicion, and you should be prescribing MRI, right? So I will request that you can have some questions over tea. Thank you so much.
Thank you so much. And as we move ahead to our last few sessions, our next session is on constipation, dry pipes and slope lanes, a pediatric perspective. Constipation in children is a common yet often underestimated problem. Dr. Nishant Vadhwa will present a simple, structured pediatric approach, helping physicians differentiate functional issues from red flags. And for this session, the chairperson is Dr. Suresh Gupta. Sir, please join us on stage.
Thank you very much. A very good evening to all of you. A disclaimer that I am a pediatric gastroenterologist. So all that I am going to talk about pertains to the pediatric age group, less than 18 years age group, and right from birth till 18 years. And how are these dry pipes and narrow lanes affecting these small kids, and how it affects their lifestyle. And how lifestyle actually leads to this is what I'm going to talk quickly in the next 10 minutes. Any difficulty or delay in passage of stools is constipation, we know that, but this definition is quite subjective because it involves both stool frequency, consistency, and difficulty in passage. A soft stool every 4 days is normal, a hard stool every day may be abnormal. Pediatric constipation is different from adults because adult constipation is largely episodic, comes and goes, and does very well with stimulant laxatives. Pediatric constipation is chronic, usually lasts for more than 2 weeks minimum, and 90 to 95% of these patients have functional constipation, which means that the constipation can be severe, but there's really no organic cause leading to this entity, unlike adults. So there are 10% causes, and among these 10%, Hirschsprung disease is the commonest cause for constipation in children. So a typical case would something be like this. A 3-year-old boy who has passage of hard stools every 3rd to 4th day, straining present, blood streaks on stool sometimes present, stool frequencies decreasing from 1 per day to 1 per week over 2 to 2.5 year age group, and he has no other history of fever, abdominal distension, drug intake, or has been passing stool regularly in the first 6 months of life, normal growth and developmental normal. Classically, in northern part of India and several other parts of our country, milk intake is quite huge for these children. Usually, when I say large, it's more than 1 liter per day, and that's when these children are diagnosed with constipation. But what they usually receive is lactulose and other enemas off and on. We treat them as small adults, but here is what really matters in the treatment part. And then this constipation actually worsens, leading to soiling, and which we know in technical terms as retentive fecal incontinence. And that is when a modified diet is introduced, which solely just concentrates over reducing the milk intake of these children. So this chronicity, which begins at around 3 years of age or 2.5 years of age, then increases in magnitude when the child actually joins schools and does not poop before going to school, and then he starts withholding stool. Classically, these children have a normal examination, normal growth and development, and on per rectal examination, there is no gush of air, which is usually pathognomonic of a Hirschsprung disease. And this is the garden variety of functional constipation 90% of children would ever come to their GP for, or the parents would complain of. So there is a fecal impaction because there is a fecal withholding behavior. The onset is beyond 1 year of age. The child is growing well, and there are no enterocolitis episodes. And this is a difficult entity to treat because the seeds of which are sown when these children are not properly toilet trained at around 2 years of age. And they usually go early to nursery schools in India because even before they are toilet trained, they've already joined a school and learning nursery rhymes and making their parents proud. So I thought I would just illustrate this small video as to why pediatric constipation is different from the adult variety, because we know that when the stool reaches colon or the proximal part of the colon, it's largely liquid, and the process of absorption of water is what going on as the stool moves through the ascending transverse and descending colon. Now, when it reaches the rectum, that's where there's a signal which goes to the brain that, okay, this is the time to poop. And if the child is able to, if he knows how to poop, and he sits on a toilet seat in a proper position for 5 to 10 minutes, that should be a simplistic procedure for him. But in today's day and age of active lifestyle of nuclear families, working parents, junk food, and children busy with their many screens, iPads and iPhones, what this results in, they actually try to postpone the act of defecation. and the stool stays there for a longer period of time. Now what this results in is more and more stool getting accumulated because each one of us is busy feeding the children but not toilet training them. And as and when this stool keeps accumulating in the rectum for a long period of time, there's a gradual distension of this whole rectosigmoid area, and that is when we label it as functional constipation. Now, this child behaves differently because if it is treated in an acute manner by a treating physician and receives lactulose or enemas, they relieve the constipation but transiently, and they again keep inflating this like a balloon again and again. And this results in a disfigured sigmoid in the rectum. Now this disfigured large rectum and sigmoid accumulates a lot of stool and does not help this child in any way because now he is in a habit of withholding stool. And this is when this signal, the urge to poop, is totally lost, and these children keep playing for 3-4 days without pooping. And they do not complain to the parent that they want to poop. And what they actually complain of is this. Because it is largely filled up rectosigmoid, they complain of soiling. And this complaints of soiling can come from school, from their friends, that this child is actually smelling, or by the child himself complaining of huge pain abdomen because of this large fecal mass which is staying in the rectosigmoid region. So when can a pediatrician or a practitioner actually identify that his or her patient is suffering from constipation? Because they will usually come to you not for constipation, they'll come to you for chronic abdominal pain. So if the child is not passing stool daily, or he does not pass in the morning, or there's a history of bedwetting, or passage of stool involuntarily into the clothes, if the child strains while passing stool or spends a long time in the toilet, or conversely, if he's passing 8 to 10 times, he goes and comes back quickly, even then he's constipated because he's unable to defecate that large volume of hard stool. If there's pain in the periumbilical region or poor appetite, excessive milk intake or excessive junk food intake, or if there is a family history of IBS or IBD, one should be alerted that this child can be chronically constipated. But whenever you are in doubt and you are suspecting it, a simple abdominal X-ray would be useful. So what are the red flags? If your patient has any of these red flags, then please refer them for further evaluation. If there's onset of constipation in less than 1 year old, if there's delayed passage of meconium, if there's absence of withholding or bladder dysfunction, or there are extraintestinal symptoms, if the child has an empty rectum on upper rectal examination, or there's abdominal distension or lower limb weakness, then this is the child who should be referred. Treatment-wise, after evaluation, you fecally disimpact them using polyethylene glycol solution and then keep them on a maintenance phase for at least 3 to 6 months so as to be able to reduce the size of the dilated rectosigmoid and the rectum. And that is why that video helps if you can actually teach the parents why the treatment duration is long. So that mainly 4 treatment pillars: diet, fluid, exercise, and toilet training. And of these, obviously, diet and toilet training are the most important ones. And they would need to be taught and retaught on each visit to the, and this is the usual position which you would like the children to be sitting in. And this is important because nowadays they are not going to get Indian toilets as they grow older. So it's important that we plan and treat and accordingly train these children for this kind of a defecation process and the posture. But if you're treating them effectively for 3 to 6 months and they still continue to be having pain abdomen and constipated, then this is a refractory constipation which needs further evaluation. And these kind of constipations are what pediatric gastroenterologists are equipped to handle. There are 2 kinds of such refractory constipations. One is a slow transit constipation where inherently and familially the intestines are slow in their movement. And then there are dyskinesias, dysynergias, where there is a dysynergia between the internal and anal sphincter, wherein the child is unable to actually defecate because of the weakening of the internal muscles and paradoxical contraction of the external anal sphincter while they defecate. And these are the kind of graphs which we come across when we do an anorectal manometry for these children. Now, these dysynergic kids are initially normal. They are functionally constipated kids who have now worsened to an extent that even while trying, and when they actually try and defecate, strain, they are unable to defecate stool with adequate osmotic laxatives. So this is the kind of 5 to 10% cases which would require evaluation. So to summarize, Functional constipation is the commonest variety in children. Good history and physical examination is enough. You don't need to over-investigate these children. But not all functional constipation kids will respond to the guideline protocols, and these 10% kids would require further evaluation. Non-responders and those with the red flags, these are the ones which you should be referring to a gastroenterologist. Thank you so much.
Thank you, Dr. Nishant. Thank you so much. Constipation is really becoming a very, very, very common problem. And I will say more than 30% of school-going children are constipated nowadays. And there is a really need to prevent the constipation. So they need to educate the parents how to toilet train their children, and not only toilet training, a focus on the diet and adequate liquid intake is very, very important. Many of us may be having children or grandchildren were having the similar problem. If they want to ask some question regarding this thing, we can take 1 or 2 questions.
Minimum once a day is enough, and if preferably in the morning before going to school, so that they poop and they go to school. Because if they go to school without pooping, they would withhold stool in the school, and that's where the seeds of constipation are sown. No, not normal. Not for Indian kids. In the Western guidelines, that would be normal. Sitz bath, definitely a role if the child has anal fissure and painful defecation. It would help reduce the pain. In fact, post sitz bath, and you don't add anything in the water. It's just lukewarm water. That's all that's required for the children. Their skin is sensitive. Post sitz bath, it's always advisable to use a lignocaine jelly so as to help relieve the pain initially for 7 to 10 days, and that's all.
I think you can take more question in the tea area, because program is.
Fiber needs to be increased, but so is the water intake. Junk food is a culprit, so avoid maida, avoid bread, biscuits, and namkeens, and chips, and kurkures. Obviously, that would need to be avoided, but as much as you can say, it has become a part and parcel of their daily intake. At least, if not daily, weekly intake, or their weekly visits to the malls and cinema halls. So we would like to definitely avoid that.
Thank you, sir.
Thank you. So common sense is sufficient to prevent the constipation.
Yes.
Thank you.
Thank you. Thank you, sir.
Moving on to the topic which is actually the need of the hour. It's an extremely important topic in terms of physician well-being. Unshakable. How doctors can stop absorbing stress, drama, and negativity. In today's demanding clinical environment, physician well-being is crucial, and Dr. Roma will address practical psychological strategies to build resilience, manage stress, and prevent emotional burnout. And for this session, I request Dr. Rajesh Goyal and Dr. Sanjay Manchanda to join us as the chairperson.
Dr. Kopal.
Thank you so much, Dr. Kopal.
Kopal.
Our budget 2026 has spoken about mental health being the thing now in 2026, and it's no more optional, but it's mandatory for us to talk about mental health. And healing is not optional. Healing is the power that we all need to be in. But unfortunately, as I see the crowd over here versus the crowd for the inauguration is less than 1/4. So that's how we treat mental health. And I think as doctors, we need to address it far more than anyone else. And why did we think of this topic? Because recently we've seen a lot of doctors, a lot of medical professionals going through stress, but not wanting to talk about stress and feeling that emotions is something that we do not want to talk about or we do not want to address. And why this matters is to help build emotional resilience. Why unshakable? Reduce reactivity to stress. We are going to be stressed with all the, surgeries, the medical profession by itself, being there for long hours, seeing chronic ailments, and that stress leads to a lot of negativity. But what is important as medical professionals is to stay centered under that pressure. It helps in cultivating lasting inner calm rather than constant worry. And doctors definitely carry invisible emotional weight. But chronic exposure leads to burnout. We're all aware of that. And emotional overload affects care and clarity. What does being unshakable mean? Most of you might think, why this topic? Unshakable because we need to remain calm under a lot of pressure, and we know that the medical profession leads us to a lot of pressure, and this is long-standing pressure. We need to respond and not react to situations. It's very important that when patients' relatives are there who are actually triggering us to say many things or wanting us to say or attacking us or shaming us, it's important to be responding and not reacting, and compassion without exhaustion. Where does stress comes from is patients' suffering and expectations. Of course, we are human beings, and it does affect us when a patient is suffering and there's long-standing health issue which is not getting corrected, or like what I heard of, we heard some time back about this, miracles happening. In every area of the body, human body, the psychology aspect is there. And yes, we are aware that if a person is resilient, if there is a lot of agility and a lot of willpower, a lot of medical problems can get corrected. We do see angry and anxious relatives. There's workload, long hours, the pressures from the system in which we work in, and we do have limited resources also. What needs to be done is building emotional boundaries. Now, a lot of us talk about limit settings and boundaries, but what does emotional boundary means? Feeling empathy and not owning a problem. We don't need to own that problem. Acknowledge the feelings without absorbing them and putting them inside us and actually brewing over those thoughts. Separate our own emotions from the patient's emotions. That is very important. And you can care without carrying that burden. Going back home, carrying that burden creates a lot of problem. Let's also understand that we need to use mental protective pause, which is like an armor that we need to have. One deep breath, a pause between patients, very important. Visualize our emotional boundaries and reset before the next interaction, and not one patient after the other. One room, one patient, second room, second patient, third room, third patient, go back to the first room. So let's have a breath in between and let's take care of ourselves. Leave work, emotions at work. This isn't emotional numbing. A lot of you might think that you're trying to numb your emotions. It isn't. It is actually self-preservation, so you can remain present and be very effective. We need to practice mindfulness and ground the nervous system. So slow breathing, 2 minutes of slow breathing, calmness, most important. Notice body and your surroundings. Calm body is equal to calm mind. It helps in emotional reactivity. Setting healthy work-life boundaries. Protect your rest and recovery and personal time. Very important is to have your own time, your own family time, and not get burnt out by all the medical areas that we are working at. Taking short breaks, they are essential. Within the day itself, the hours of work, you need to take those short breaks. Avoid unnecessary after-hours work. We also need to address this, that rest is not a luxury, it's essential, it's mandatory that all of us rest. The body needs rest, and so does the mind need rest. This lessens cumulative stress and gives your system a reset. Thus, sustainability definitely matters. Let's also learn to share the load. Debrief whatever the issues are with your own trusted colleagues. Share and not suppress. And let's normalize supporting each other. Medicine is a teamwork, and you're not alone. Reframe the moment. When you see that the patient is scared, the relatives are scared and stressed, and not attacking me, let's not think that they're attacking me. They have a problem. They have to learn to deal with it. I will not get into that and not get affected by what they are saying, not reacting, not impulsively reacting to the situation. Focus on the impact and not blame. People will be there to blame. This is known as cognitive reframing, how we talk to ourselves, and it helps reduce emotional stickiness. It means that you're protecting your own resilience and reducing your own emotional burden. Long-term resilience habits within us medical professionals helps in adequate sleep, regular movement, healthy relationships. We also need to have our own healthy relationships within our families, within our extended families, our friends. Professional support is there, and I would say that a lot of doctors and medical professionals do need that professional support, but because we are medical doctors, we don't like to talk about us wanting that emotional support. And I think it's time we address that, it's time we talk about it, and it's time we actually help ourselves move away from all the stresses that we are going through. And since we are human beings, we will have stress. Let's not feel that we are without it. Remember that compassion is not equal to emotional absorption. Boundaries will protect our empathy, and a calm doctor is definitely a better doctor. The bottom line says that to be unshakable as a doctor means you care with presence, not emotional absorption. You protect your energy while remaining compassionate, and you use evidence-based habits to stay resilient under pressure. We will always be under pressure, but we have to see how to take care of that, how to regulate our own emotions. And yes, you can care deeply without carrying everyone else's emotions as much as yours own. That's what makes sustained practice and self-care truly unshakable. And we have to be grateful for everything. So the forces that help you are focusing, healthy relationships, gratitude, patience, courage, and perseverance. And what doesn't help you is remaining in guilt, the fear of change, regret, and lack of confidence. I would not do justice if I only speak about good sleep hygiene with Dr. Manchanda sitting there, but I thought I should add in there that put away your phone and devices, 3 rounds of mindful breath walk before you sleep, 2 sets of pranayama breathing, take a mindful warm shower, lie down quietly and breathe gently, read, listen to music, talk to your partner, put off the light, do shavasana, sleep well, because all of us know that sleep will give us better health. Thank you. Take care of yourself so you can continue taking care of others. Thank you.
Thank you, Dr. Rama. It was a very, very nice presentation. The thing is, basically, a lot of people ask me, I'm just saying 2 sayings on, actually today we have put a lot of price on our happiness. It is coming at a huge amount of price because we are more, say, skeptical about somebody else getting it and we are not getting it, or we want more. So somebody asked that what is the definition of happiness? So one dictum with which I try to live is that today is the first day of the rest of my life. So start afresh, don't carry extra baggage, it is not going to help us in any which way and will add on to the stress. And other thing is basically happiness is a mode of traveling. It is not a station you arrive at. So don't put preconditions to be happy. Because if we do that, we will never ever be happy and contented. So this was more of a kind of a metaphysical kind of a thing. I leave it for the last comments to the experts.
Thank you, sir. Thank you, ma'am, for a wonderful presentation. Good evening, all. As ma'am started saying that the presence is 1/4, because everybody feels कि मेरा तो mind ठीक है और mind को तो मेरे कुछ होगा भी नहीं आखिर तक. Liver, kidney, गुर्दा ये खराब हो सकते हैं, दिमाग तो मेरा ठीक ही रहेगा. Everybody feels so. So I don't need any mental health. Today, while presenting budget, our finance minister, she talked a lot about mental health, because they've realized in so many years that whatever they are doing, it is putting a lot of pressure on the general population mental health. So now they are trying to give a solution for that. More means like institutions and all that. So that was on a funny line, but definitely mental health is very important. This is UPS of the system. If mind is well, everything is well. And being healers, being doctors, हमारा माइंड तो ठीक रहना बहुत ज़रूरी है. इसके लिए कुछ भी करना पड़े, किसी की हेल्प लेनी पड़े, कैसे भी, everybody has his or her own ways. See, we talk, but everybody has own ways. So by using them, we should try to be mentally healthy. Thank you.
Ma'am is an eloquent speaker, and I think she has covered everything so well. We as doctors have to remember that even if we give our best, even if we are good, great, or even the best doctors, we still can have bad days. It could be anything. It could be stress, it could be feeling physically unwell, or even mentally unwell. And taking that as a challenge, and deciding that I have to perform, often causes a lot of burnout. So the first step would be to acknowledge that maybe, yes, I might just be stressed. And that in itself is a huge step. It may seem a little step, but it's actually in reality very big, because that first acknowledgement leads to acceptance, which can help you take some help. And that help could be very little. It could just be checking in with a colleague or a family member, or just venting out about your day. And that could actually cause magnitude of change in yourself. So I would request everyone here who's present, take a little bit of a step, even if you're stressed, even if it is the most silliest reason in your head. Take some help, talk to somebody, vent it out, and I'm sure you'll feel 100 times better. Mental health is the need of the hour, and it's time that we as doctors pay attention to it first. Because if we are mentally well, we can take care of everyone else.
मेंटल हेल्थ तो हम बहुत बोलते हैं, एक लाइन लास्ट बोलूँगी, हमें अपने भावनाओं के बारे में बात करना चाहिए. और जब हम भावनाओं के बारे में बात करते हैं, और अगर आपको लगता है कि आपकी बात कोई सुन नहीं रहा, या आपने किसी से बात करनी है और लगता है आप कोई जज हो रहे हैं, प्लीज़ डू नॉट हेजिटेट टू सी अ मेंटल हेल्थ स्पेशलिस्ट. वी कीप information that you share with us completely confidential. Even amongst us, we do not talk. So that's the confidentiality we keep, and it's imperative that we take help. Thank you.
As we move on, our next topic is 3 musketeers of minimally invasive surgery in urology, laparoscopic, 3D, and robotics. And our speaker for today is Dr. Vipin Tyagi, who will take us along this journey. For this session, I request Dr. Neeraj Dhamija to be our chairperson.
कौन सा? शुरू से ये
Good afternoon to all, and after a very good mental talks, we need to have some fun of the things which we should associate to our medical practice, and I associate my medical training into a 3 Musketeer things, which is a very famous novel. You have learned all about that thing. I just give an example. This is a muscle invasive cancer of urinary bladder, and we know that in these cases we need to take out the bladder. We have to use the intestine to make a new bladder, and then we have to implant both the kidneys on that new formed conduit and take this out of the stomach. And most of the time we used to do this surgery by a bigger midline scar, but which is better? The one on your left side and one on your right side. The right side is just 5 minimal holes and 1 stoma, no bigger scar. The patient will have a better recovery and a better outcome as compared to the picture which I have shown on left side. And how we can achieve that by using the 3 Musketeers things. And these 3 Musketeers are laparoscopy, 3D, and the robotics. Now, what is the aim of the surgery? It used to be, when the surgery started, we have to just perform a task. If it is a gallbladder surgery, take out the gallbladder, forget about all the other things. If it is appendix, take out the appendix. If it is a stone, give a bigger incision, cut the kidney, take out the stone, and forget about all the things. Then in the medieval time of medical history, it comes, we have to decrease the morbidity of the procedures. And then the era of minimal invasive surgeries come into the picture. And now we do not only want to decrease the morbidity, we want to be precise. We want to offer a quality surgical services to the patient so that the patient have an enhanced recovery and a very less wastage of human resources of active time. every patient nowadays asks you कि मैं कब से वापस अपने काम पे जाऊँगा, because everybody is worried about his optimization of the resources which he had, and we also need to have a comfort to the surgeon. We need to be tired less to do a better work for my patients. We know all this theory since the school time, that there is the Darwin theory of evolution, every thing will go down and the best thing will remain. This is a process by natural selection, and what we are doing in a surgery is an artificial selection. From a freehand surgeries to minimal invasive surgery to robotic and the era of fully automatic, which the Elon Musk have already talked about. This surgery is basically indicated for patient to make the surgery minimally invasive, early recovery, less blood loss for the diseases, wider indications. Like radical prostate in India is about 1% of the surgeries before 2000. Now it's about more than 60% of the robotic surgeries in today's time. For the surgeons, it is a comprehensive use of their skill and they need to be comfortable too. Now, open surgery, we know that it's a direct visualization with tactile feedback and a very big statement which we used to learn. Big surgeons give big incisions. The idea of giving an incision is just to put the hand inside the body and perform that function. What is the limitation of this? It increases the pain, it have a longer hospital stay, higher blood loss and a slower recovery. When I'm doing my MS, we used to do a radical prostate and the patient used to remain in the hospital for 2 to 3 weeks and with the leaking of urine every from, and we have to just take care of his urine leak and his apprehension too. Do we need this big surgical incision? This is a study and a comprehensive data that in elective surgeries, the wound complication is 3 to 17%, that every 1 out of 5 will have a complication, and if we are doing a surgery in emergency setup, this have increased to more than 2 or 3 times out of 5. Why we should move away from open surgery? Because we want to decrease the surgical trauma, post-operative pain and hospital stay. But yes, this is our desire, but how we can do this? Because we have now better optics, better energy sources, better instrumentation and better interaction of hardware and software. We now understand how to convert the desire to an outcome. And here comes the 3 musketeers. The Athos, which is the eldest noble and mentor figure, which is the laparoscopy. The Porthos, which is known for his strength, vanity and good-hearted nature, that is extreme, the robotic. And the middle of these 2 things is a 3D system, which is romantic and intelligent. Now, laparoscopy, we all know, it is a small incision, camera-based surgery, magnified views. But we also know that these are minimal invasive surgeries, have a reduced pain and all the better outcome of a minimally invasive surgery. It is well developed, affordable everywhere. Everybody now knows about the laparoscopic surgeries. But what is the limitation? Laparoscopic surgery is mainly eating the sushis or the noodles by a chopstick. You need to be a specialist. You need to acquire that knowledge and that skill to do so. And why it is there? Because it is altogether different from the open. There is a loss of 3D visualization. There is a compromised dexterity, limited degree of motion, the fulcrum effect, amplification of the physiological tremor, and the difficult articulation of the instrument. And that's why in urology, nowadays, the laparoscopy is limited only to diagnostic purposes, just to take out the kidney or adrenal, do some cyst marsupialization or taking out the stone. Beside this, laparoscopy always have a limit to be used in urology. And because of these limitations, we are not using the laparoscopy for partial nephrectomies, radical cystectomy, radical prostate and ureteric reconstructions. So basically, whenever there is an ablation, laparoscopy is good. Where we introduce any reconstruction of the system, the laparoscopy has its own limitations. Now, then comes the second musketeer, that is 3D laparoscopy. It addresses the problem of depth perception which is there in the laparoscopy, and it improved a bit of hand-eye coordination. The benefit is, again, better precision and short learning curve, because now you are seeing the way you used to see with the 2 eyes, and improved suture accuracy. But it is still limited by the rigid instrument, surgeon fatigue, and the limited wrist movements. So 3D laparoscopy is still a very big challenge for complex suturing for narrow anatomical spaces like the prostate. Surgeon have to just stand and deliver the surgery like this. Tremor amplification and long operative time in complex cases. And then comes the third musketeer, robot. Now, robot is not the new word. It was first coined in 1920 in a play which called Robot, and the meaning of that robot is forced labor. And what basically robot, it is again not a new concept. It was started in 1970s by NASA, and it has seen his shape in the early 2000s, and in Gangaram Hospital we acquired the robot in 2012. Now, robot provide a better insight vision of 3D, digital camera zoom, camera stabilities, endorist movement, improved dexterity, filter of the tremors, elimination, whatever the problem we used to have in the laparoscopy, those has been addressed by robot, and thus we are able to deliver a better outcome to the patients. Now, what is robotic surgery meant? It is just a form of minimal invasive surgery, which is a computer-controlled system where whatever movement I am making, that movement are seamlessly transferred onto the patient's side without any delay or lag. So it is more like a Kathputli ka game where the person is manipulating the arms and the legs of the Kathputli. And it is basically possible because of the endorist movement. These instruments are morely function like our arms, and it is better than actually endorist because our hammer 270-degree movement, these have more than 540-degree of the movements. Gangaram is pioneer in acquiring all the robotic. In 2012, we acquired one of the first Da Vinci system in India, and till 2023, we have performed more than 1,400 cases. In 2023, we are the first in the Asia-Pacific region to acquire Hugo by Medtronic, and till now we have performed more than 600 cases. And recently, we also got Miso, which is a made in India by Merrill, and we have did about 950 cases. And we have that concept of always being first in the technology side, which Gangaram has proved over this improvement. Now in urology, what it changes? Now first, nowadays, whenever a patient with a kidney tumor comes to me, my question to myself is, do I need to take out the whole kidney or can I preserve the kidney? So partial nephrectomy is possible, so why to sacrifice the kidney? Ureteric reconstruction of all type, pyeloplastic, implants, urogynecological fistulas, and practically no failures. We have the largest experience in India about radical cystectomy with intracorporeal conduit. And in a radical prostatectomy, when we used to do, if you're taking out the prostate, urinary leakage is something which is a consequence. Now it is a complication, it is not a consequence. So leakage is not there by using the robotic advantage. Comparison, you all know all these technical things that robot have a 3D vision, dexterity is very high, and ergonomics are excellent. A surgeon can sit. He is mentally not challenged by his ergonomics of standing for 3 or 4 or 5 or 6 hours. So these three musketeers in urology, the laparoscopy can be used only for diagnostic and ablative purposes. The 3D is used for complex nephrectomy. In few of the donor nephrectomies where we have multiple arteries, double IVC, difficult anatomy, we actually shifted to 3D because that gave me a 3D perception of all the anatomical structure. Adrenal, I am using 3D because adrenal is surrounded by, on the right side by liver, IVC, kidney, on the left side by spleen, pancreas, bowel. So you have to preserve all these things, and if you can see them better, you can preserve them better. The robotic is used for radical prostate, cystectomy, partial nephrectomies, and ureteric reconstructions. What it changes my life, I just, before making this presentation, I just run through my logs, and I found that nowadays only 10% of my surgeries are open, 50% of my surgeries are laparoscopy, 3D laparoscopy is 10%, and 30% of my surgeries are robotic. So there is a big shift from open to minimal invasive surgeries. And I'm not only using these three musketeers. Dr. Neeraj from minimal invasive surgery and general surgery, the gynecologist, the GI surgeon, the pediatric surgeon, thoracic surgeon, colorectal surgeon, all are using this technology to make the patient much more comfortable. So these three musketeers are non-competitive. They are complementary. These are tools. And master is the surgeon. Now, this is the fourth musketeer, which we have just performed 3-4 days back. Can we control this musketeer from a distant away? Now, this is a picture in which I am shown on the back side. I am in a normal clothes. I am operating from Vapi. This is called telerobotic, which we have first did in Gangaram on 27th, where I am operating in Vapi, which is 1,200 kilometers away from Gangaram Hospital. And the patient is sitting in Gangaram Hospital. And you can see in the second video, all the instrument movements which you are seeing on the patient side has been controlled without any lag from a 1,200 kilometer distance away. And we have performed 5 of these surgeries successfully. So this is something which I may say that the fourth musketeer in forming. So these three musketeers is an example of a love story of human and the machine. But as a surgeon, a good surgeon does not just concentrate on the technical ability, but also on the appropriateness of what you are doing. It doesn't mean the robot is for all, 3D is for all, lab is for all. There is a role of everything for patient as per the patient indication, patient demand, and the surgeon's competence and the skill. Thank you.
Thank you, Dr. Vipin. Indeed, yes, this was a news. You're doing telesurgery from Vapi to Gangaram, and we're proud of you and your team. And I believe the outcome of surgeries have all improved by when we have resorted to these minimal invasive procedures. Thank you.
Thank you.
I think that was a pretty interesting and new session. And now we move on to endoscopic excursion gastroenterology. Where are we? Endoscopy has transformed GI diagnostics and therapy, and Dr. Shivam Khare will walk us through current endoscopic advances and what they mean for timely referral and patient care. And for the chairperson, we have Dr. Mandir.
Actually, when we started gastroenterology, we were limited to just endoscopies, colonoscopies, or maybe ERCPs. Now we have gone much beyond the lumen. We are performing procedures, going outside the GI tract and performing procedures like direct visualization of bile ducts, taking biopsies from pancreas, which is outside the lumen and closely opposed to duodenum, and doing procedures like gastrogynostomies and drainage of bile ducts where we cannot go beyond. So many other things. I think Shivam will show few videos also.
So, good evening everyone. I will be presenting this endoscopic excursions in the gastroenterology. So first question is, why should we focus on endoscopic advancement in the gastroenterology? So answer is, now everyone needs a accurate diagnosis of any disease, and second thing, minimal invasive treatment of any disease. So endoscopy provides both accurate diagnosis and minimal invasive treatment. So I will discuss advances in the endoscopy in last 10 to 15 years that will include diagnostic. So diagnostic includes US guided diagnostic procedure, high resolution manometry, image enhanced endoscopy, and therapeutics like US guided therapeutic intervention, third space endoscopy, and cholangioscopy. So coming to the endoscopic ultrasound. So as the name suggests, endoscopic ultrasound is a combination of the endoscope and ultrasound. In this second image you can see, this is the ultrasound probe, transducer along with the optics and biopsy channel. So by using this scope, we can do multiple therapeutic intervention, not only biopsies. So after the development of the endoscopic ultrasound, the reach of endoscopists has been significantly increased. Now we can see many organs neighbor to the GI lumen, like pancreas, pancreatic duct, gallbladder, common bile duct. So we can see the diseases of the gallbladder, common bile duct, like stones, masses inside the gallbladder and pancreas, common bile duct, and also we can take biopsies by using the endoscopic ultrasound. And also we can see the lymph node even in chest and abdomen, and we can also take biopsies from these lymph node. You know, these lymph nodes are very common in India, and we can make the diagnosis what is the reason behind it. Now coming to the next procedure, US guided liver biopsy. So traditional route of the liver biopsy is the percutaneous liver biopsy or transjugular liver biopsy. So during percutaneous biopsy, we have to go from the skin. So patient can have pain after the procedure, and most of the percutaneous biopsy are blind. So patient can also have bleeding after the procedure. So in US, we can do under the color Doppler. I'll show you the main part of this video. So here you can see this is the liver, and you can apply Doppler, and you can choose the vessel-free path, and you can take multiple biopsies to make diagnosis in case of US liver biopsy. So next is US guided cystogastrostomy. I will give a small case here. 32-year-old male who has history of acute pancreatitis, 6th week now, And now patient presented with recurrent vomiting. In CT scan, you can see there is a large collection. On endoscopic view, you can see this collection is compressing the gastric lumen. So lumen is compromised here. That's why patient is having the recurrent vomiting. So what is the treatment for that? So this is the newer US guided treatment in these type of the cases. You can place this lumen opposing stent between the stomach and the pancreatic pseudocyst or collection. The next role of US is when ERCP failed. So we all know ERCP is the well-established procedure for the common bile duct and pancreatic duct intervention. We can remove stones and we can also place a stent inside the pancreatic duct and the bile duct. So these are the routine indication of the ERCP. If any patient has bile duct stone, obstruction because of cancer like bile duct cancer, gallbladder, pancreatic, ampullary cancers, or any patient has bile duct leak. So whatever the reason, we have to place a stent across the stricture or narrowing side by the ERCP. But if ERCP failed, then we have an option of for the other intervention like US guided hepatogastroscopy and choledochoduostomy. So in first image you can see we can make a connection between the intrahepatic duct and the stomach, and in second image you can see the connection between the common bile duct and the duodenum. So I'll show the small video. This is the common bile duct. First we punctured with this needle and then cholangiogram done which shows the dilated duct here, and after that over the wire we can place a stent between this common bile duct and the duodenum. Similarly, if ERCP fails in the pancreatic duct diseases, then we can make a connection between the pancreatic duct and the stomach, and this procedure known as pancreaticogastrostomy. So this is quite similar procedure just like choledochoduostomy, so I am not going in detail. The next procedure is US guided gastrojejunostomy. So I will give you an example, 70-year-old female with duodenal malignancy along with the liver metastasis. So this is the unresectable disease, but this patient has the luminal narrowing because of this luminal narrowing, patient has a recurrent vomiting and patient need treatment. So option for that either surgical gastrojejunostomy or second US guided gastrojejunostomy. So these patients are quite frail and usually not fit for the surgery. So in this type of the patient, we can do the endoscopic minimal invasive procedure. We can make a connection between the stomach and the jejunal loop. So in this video you can see this is the jejunal loop, and first we punctured this jejunal loop with electrocautery enhanced stent device, and then we release this flange in the jejunum first stent and followed by the second proximal flange released in the gastric lumen. And similarly, like gastrojejunostomy, if any patient has severe acute cholecystitis and not fit for the surgery, then we can perform a similar procedure just like gastrojejunostomy, and we can make a connection between the gallbladder and duodenum also, and this procedure known as cholecystoduodenostomy. Now coming to the next advancement, that is the high resolution manometry. So high resolution manometry, we use a catheter that has multiple closely placed pressure sensor, and these pressure sensor measure the pressure in the esophagus and also at the GE junction, and these pressure are displayed in the color coded plot, and after that we can analyze on the computer screen. So on the basis of the manometry we can diagnose the esophageal motility disorder, and the most common esophageal motility disorder is the achalasia cardia. Apart from the achalasia cardia, we also diagnose hypermotility disorder like contractile esophagus and diffuse esophageal spasm, and also we can diagnose hypomotility disorder like ineffective esophageal motility. So this is important for the surgeons. If any surgeon is planning to do surgery for the hiatus hernia fundoplication, so first we should perform the esophageal manometry. If any patient has ineffective motility, then we should not perform the 360-degree Nissen fundoplication. In fact, we should perform 270-degree Topid or Dorf fundoplication in these type of the cases. And we also have a treatment option for the small hiatus hernia, and that is known as endoscopic anti-reflux mucosal ablation. So if any, how to select patient for the either endoscopy or the laparoscopic fundoplication. So if any patient has a symptom of refractory GERD, then we should perform the manometry. If manometry shows the adequate motility, then we should do the endoscopy. So in endoscopy, if GE junction anatomy is up to grade 3, then we can perform endoscopic procedure, or if anatomy is more than grade 3 or patient has large hiatus hernia, then we should send the patient for the surgery. And this is the small video how we do this mucosal ablation. Then coming to, so in this image you can compare in first pre and post anti-reflux mucosal ablation. There is quite tightening at the GE junction after this procedure. So next is the image enhanced endoscopy. Image enhanced endoscopy actually an inbuilt feature of in the newer endoscope, by which you can just do switch on the button of the image enhanced endoscopy, and you will see the different kind of the image like this. So after doing the image enhanced endoscopy, you can see the microsurface and vascular pattern of the mucosa in the stomach and the colon, and you can diagnose the early malignancy, early cancer, by doing this image enhanced endoscopy. Now coming to the next third space endoscopic procedure. So first is, what is the third space? GI lumen can consider as a first space, peritoneal space can consider as a second space, and third space is space created within the GI wall. In this small video you can understand better. So this is the GI wall, mucosa, submucosa and the musculus propria. So what we do, we create a submucosal blab by injecting some methylene blue mixed saline, then we create a tunnel here. And if disease is located in the muscle, then we do the myotomy. If there is any tumor, then we dissect the tumor from the all around and remove this tumor, and finally close the defect by using hemoclips.
Shivam, you will have to hurry a little.
Yes. So I will discuss one case of third space endoscopic procedure, that is the achalasia cardia. So standard treatment for the achalasia cardia is the laparoscopic or endoscopic pneumatic dilatation. But now we have a third space endoscopic procedure, that is per oral endoscopic myotomy, and this, the advantage of the per oral endoscopic myotomy is the safe procedure, lower complication rate is there, quicker recovery and better outcome after this procedure. So similarly, like per esophageal poem, we can also perform gastric poem if any patient has tight pyloric junction. And if any patient has Jenker's diverticulum, then we can perform the JAT poem. So next is the endoscopic submucosal dissection.
Go to the videos.
Yes. So in this video you can see, this patient has early gastric cancer. Now we can remove these type of the cancer by only endoscopic procedure, and this procedure known as a endoscopic submucosal dissection. So this is the last procedure, cholangioscopy. So this cholangioscope, now we can introduce inside the ERCP scope, and if any patient has large stone that we cannot remove by routine ERCP, then we can break these type of the stone by the laser lithotripsy. So coming to take home messages in my presentation. So if any patient has any disease related to pancreatobiliary system, by the US you can make a diagnosis, and also you can treat the patient by the endoscopic ultrasound. And similarly, if any patient has achalasia cardia or refractory gastroparesis or Jenker's diverticulum, surgery is not required nowadays. You can treat these patients only by the third space endoscopic procedure like poem. And also in early gastric cancer or colonic cancer, now we can perform third space endoscopic procedure like ESD. Thank you.
So in the interest of time, we will not take any questions. Thank you, Shivam. Thank you, Dr. Mandhir. It is really good how we are getting forward to in endoscopy. So this brings to the last topic.
So today's last topic, dental implants. How, when, and in whom? To conclude these sessions, Dr. Ajay Bharija will discuss dental implants, focusing on patient selection, timing, and indications. an area increasingly relevant in holistic patient care. And for the chairperson, we have Dr. Vikas Sethi. So please join us.
नहीं है ठीक है
नहीं चलेगा छोड़ना इससे कर लेना
ये हो गया
ठीक है कर
क्या हो गया
स्लाइड चाहिए
स्लाइड शो Good evening, everyone. This is the last presentation of today. Thank you all who all are present for staying back. I'll keep this presentation as practical as possible. So I'm confident that after the end of these 10 minutes, you'll be able to answer few questions when you get back to your practices. एक मिनट यार. Is the patient suitable for implants? When should we delay or modify the treatment depending upon the systemic conditions of the patients? And when to refer the patient for the implant surgery? Why should a physician know about dental implants? Because the tooth loss affects the nutrition, because when the teeth are lost, the chewing becomes difficult. The patient is not able to eat or chew on all the hard fruits, nuts, or the food which provides the nutrition, which causes the nutritional deficiency. And as the patient lose more and more teeth, they shift to the softer diets, which leads to the gastrointestinal problems that has to be addressed. Second is the speech. There are the teeth, especially the anterior teeth, when they are lost, certain sounds like S, T, F, or V, it requires the proper positioning of the anterior teeth and the tongue. When these teeth are absent, these sounds, producing these sounds become difficult, and words may become difficult to understand. This affects the overall quality of life of the patient. There is increasing demand among middle-aged and elderly patients. Physicians are often the first contact. What is a dental implant? Dental implant is a titanium screw that is placed in the jawbone. It acts as an artificial tooth root and supports the crown, bridge, or the full mouth denture. Dental implants are indicated when a single tooth loss, thereby preservation of the adjacent teeth, unlike bridges in which we need to sacrifice the adjacent teeth for making a fixed prosthesis, or multiple missing teeth. Completely dentulous patients, we can place implants. 4 to 6 implants can be placed in the maxilla and the mandible to completely rehabilitate the patient. What is osseointegration? Osseointegration is a direct bone to implant contact. So when the implant is placed in the bone, a woven bone is formed that is little softer and that cannot bear the load of the tooth. So we need at least 3 to 4 months after the placement of the implant so that that woven bone is replaced by the lamellar bone. That has a strength to bear the occlusal loads. Osseointegration gives the implant stability and strength to bear the forces of chewing and biting. Implant longevity is also dependent upon the osseointegration. Implants can last for decades to lifetime. They support the bone health. When the tooth is lost, the bone, in the first year of tooth extraction, there is a 25% reduction in the bone height, and width. So when we place the implant immediately after extraction, it supports the bone and the bone health is maintained. Who are the ideal candidates for implants? People who have good systemic health, adequate bone quality and quantity, good oral hygiene, controlled systemic conditions. Common systemic conditions which require optimization before the implant placement are diabetes. In this, we recommend the HbA1c should be kept below 7, that is preferred. Hypertension should be controlled, especially in diabetic patient when the long-lasting anesthesia is given. The patients may experience, the patient may not be able to have their food after the surgery for a long period of time. So especially insulin-dependent diabetics, the insulin should be regulated by the physician. Then comes the thyroid disorders, especially the hyperthyroidism. Hyperthyroid patients, they are sensitive to epinephrine. And along with the stress of the implant surgery, there is a spike in the catecholamine release, which the patient could go into thyroid toxicosis or the thyroid storm. So the thyroid has to be controlled before we plan the surgery. Anemic patients, again, it has to be, the hemoglobin has to be maintained. Medications of concern. First is warfarin. So, American Dental Association recommends that we should not stop warfarin before the surgery, because various studies have shown that embolic episodes in the patients who have stopped warfarin before the surgery. So, it's better to maintain the INR in the therapeutic range, that is 2 to 3.5. So if the INR is above 3.5 or it is above 4, then that has to be regulated. Then only we can plan the surgery without stopping warfarin. Aspirin, if the patient is on aspirin that is below 100 milligram, then no need to stop that. Instead, local hemostatic agents can be used. Then come bisphosphonates. Bisphosphonates, they affect the bone metabolism and bone turnover because the osteoclasts are lost. So, care should be taken, or physician consult is required before proceeding for surgery. Contraindications, absolute contraindications are uncontrolled diabetes, recent MI, like 6 months or 6 months to 1 year before the procedure, active malignancy in the jaw, and severe immunosuppression. Relative smoking, osteoporosis. Osteoporosis is not a contraindication for dental implants. Instead, we have to modify the surgical protocol. Like bone condensation techniques we have to use to get the dense bone. Poor oral hygiene and bruxism. Bruxism is a habit that can be controlled with habit-breaking appliances. So we can give implants and give a night guard or some guard to relieve the occlusal pressure. Dental implants, to place the first diagnostic tool is the orthopentamogram, which gives a two-dimensional view of the height and the width of the bone. But sometimes it is not enough, so we need a three-dimensional view of the bone, that is a CBCT. It gives a very good overview and detail. Exact measurements of the exact dimensional measurements are possible, the bone height and the width and the anatomic structures. So a 35-year-old male, he came to the clinic with a loosened bridge, anterior bridge. So which was supported by two anterior teeth, and the central tooth This tooth is fractured. So what we planned was, yeah, a CBCT was taken, and we see a very thin buccal cortical plate, and the palatal bone is quite good. So we need to extract this tooth and place an implant. This is a clinical view of the case. Atraumatic extraction, bas ho gaya, just 2 minutes. Atraumatic extraction is done to save the buccal bone so that we can immediately place the implant. After the extraction, curate and disinfect the socket. Right implant size is placed, relieving the buccal cortical plate so that there is no pressure on it. In that space, we can place the bone graft, placing the superstructure over the implant, and the final crown. This is a radiograph of placing the implant. So dental implants are safe and effective. Patient selection is the key. Physicians play a vital role in identifying candidates, optimizing systemic health, and timely referral. Thank you.
So just last final lucky draw which was left. We'll draw the last 10 draws. If you are here, you can claim the prizes. Dr. Kishan Gola. Next is Dr. Narendra Kumar Gupta. Satish Chandra Gupta ji. Dr. Savita Saini. Dr. Rajesh Chabra. Everybody is left. Huh? Dr. Rakesh Goyal. Last 4 to go. Dr. Parag Gupta. Anyone? Dr. Swarna Jain. Last 2. Dr. Anil Agarwal. And last, Dr. D.D. Arora. Thank you, but we have to forward the gifts to these people only. This is being exported. And export results, these are being sent on the WhatsApp. So these are the gifts which we have drawn, all 20. These will be given to these people. So, but we cannot do another draw, sir. So there are 195 candidates who are left. So what I will do is, so there are 10 gifts which are left. Okay? So there are 10 gifts which are left. I'll just reset it. Just wait. So I will put it amount to 200. Save. So I will draw all. If you are here, just claim depending upon the number of the thing, okay? I'll just export the final result. So if you can read. So I will show you the result. If you are here in the top list, you can claim it. First 10. Anybody here in first 13? They can read. Anybody there in the first 13? So No, 2 people are there. 12. So come please, you come forward. Anybody there in the next group in 26? Please come forward. We have 10 gifts. We have 10 gifts. We need 10 people on the stage. Okay, we need 10 people here. Anybody here on the third? Okay, I'll check it. Third? Anybody here on the third? Dr. Goyal? Dr. VK Goyal? Okay. Fourth? Only 10 people on the floor, please. Okay? Fourth list? First वाली फिर से दिखा दी. First. नंबर 5, आप आज ही 4 हो गए 5 हो गए, बता देना, 10 के ऊपर छोड़ देना. हाँ ठीक है, बताइए. ब्रिज नंदन चोपड़ा ऊपर आ जाइए फटाफट. करण 10 गिन ले प्लीज, करण 10 गिन ले. पेज नंबर 4. एनीवन ऑन दिस पेज? एनीवन ऑन दिस पेज? आज ही ऊपर आ जाइए सर. 10 गिन लेना प्लीज. एनीवन ऑन दिस पेज? आप देखिए. पुराना दोबारा दिखा रहा हूं, देख लीजिए. ये देख लीजिए. नेक्स्ट है ये. नेक्स्ट. नहीं, आप जब बोलेंगे मैं वापस भी ले जाऊंगा. कितने लोग हो गए हैं? 1 2 3 4 5 6 7 8 हो गए, 2 रहते हैं. एनीबडी फ्रॉम दिस? हाँ, आजिए ऊपर आजिए. लास्ट वन टू गो. एनीवन फ्रॉम दिस? आजिए ऊपर आजिए. नहीं, आपका नंबर क्या है? नहीं, रहेजा जी का कौन सा नंबर है? 124. आपका कौन सा नंबर है मैम? आपका कौन सा नंबर है? 124 विंस. लास्ट गिफ्ट था 124 विंस. 124 मिस्टर रहेजा. डॉक्टर मनचंदा? सो ये पकड़, मैं देता हूँ एक को. नहीं 24. थैंक यू. लेना जी, कोई नहीं, 10 लोग ही लेंगे यार. 10 लोग के बाद खत्म है. Thank you. I believe this was justified. Thank you. Thank you for staying till end. We had a pleasant evening and pleasant day. Thank you all for attending. Regards from Gangaram Hospital. Thank you.